Okay, so good morning, everybody, and we will be starting with our session. The first session is more of a workshop in which we are going to talk about advanced hybrid closed loop system and how things have changed over that. I still remember around 25 years ago when we were managing children with diabetes at AIMS Delhi, patients used to be admitted in the hospital because they could not afford glucometer. So they were there for a day so that they can get 5, 6 readings, and then monitoring was done. And we know people are doing urine sugar monitoring, and it was a very, very difficult scenario. Syringes were very difficult. We used to use reuse syringes earlier, and gradually from there have been dramatic change in the last 20 years or so. There have been a dramatic change which happened with the newer insulins, the pens availability, the glucometer, the CGM, the pumps, and now we have the advanced hybrid closed loop system, which is close to, we can say, closest to what comes to artificial pancreas. So we'll be having a very good discussion. We've got renowned experts from across the country, and we'll have a live demonstration also on that. So I'll hand over Dr. Sandeep to introduce the overall topic, and we can start with the sessions then.
Thank you very much, sir. Good morning, everyone. On behalf of Dr. Anurag Bajpayee and Team CDR Regency, I, Dr. Sandeep D. Paimude, welcome you all for this 6th Advanced Pediatric Endocrine Symposium held under the aegis of Indian Society of Pediatric and Adolescent Endocrinology, Grow Society, CDR Regency, and Mediclasses. This is a platform dedicated for advancing knowledge, collaboration, and clinical excellence in the field of pediatric endocrine. This symposium brings together leading experts and clinicians all across the country who will share their insights, valuable opinions, and address challenges in the field of pediatric endocrine. In these 2 days, we will try to discuss all topics and will cover major factors in pediatric endocrine. I once again request all of you to take active participation in this symposium, and let's all together make this festival great. Since we have already introduced everyone, now I request Dr. Anurag Bajpayee, sir, who is the mind behind this symposium, to kindly come over on the stage and kindly give an overview of the symposium and the background of the symposium.
Thanks a lot, Dr. Sandeep. And this symposium will be discussing much more in detail how the evolution took place over the last 15 years or so in terms of the Grow Society, Mediclasses, Regency, CDR. We will be focusing on the next day on different topics, starting from advanced hybrid closed loop system to what we call state-of-the-art management, in which 6 talks are there covering the wide spectrum of pediatric endocrinology, followed by diagnostic talks in which we're going to talk about bone mineral density. We're going to talk about advances with regards to endocrine diagnostics in terms of imaging, along with what new innovations we have been doing in terms of Mediclasses to make diagnosis much easier, improve the quality of life and evaluation. Then we'll talk about 6 topics on glucose grand round, followed by the various glucose in 2025. Tomorrow morning, we have got wonderful debates on 3 topics, which are quite intriguing, followed by overview sessions on 5 topics in 2 grand rounds. So it's a very power-packed one, but we want to keep it clinical. We don't want to go into too much pathophysiology. We just want to be focused on that. And right away, we'll, without wasting any time, we'll be starting off this session. And the first session, as we have discussed already, is focused basically about the issues of advanced hybrid closed loop system. And I have the pleasure to invite Dr. Chetan Dave, who was, along with Dr. Neha, the first fellow who joined us in 2017 and has now been working a lot in terms of pediatric endocrinology in Gujarat. He has set up his own center for pediatric endocrinology and diabetes, has been continuously involved in research, educational activity, is also executive member of ISPE for the last 4 years. So welcome, Chetan, and you can start off with the initial talk, which is the overall concept of type 1 of HCl.
Thank you, sir. Hello. Good morning, everyone, and welcome to the workshop of Advanced Hybrid Closed Loop System. As we know that humans are stubborn, we try to find out solution for each and every problems, whether it is medical, whether it is social, or whether it is personal. And type 1 diabetes is a challenge not only to the parents, but also to the doctors. And why type 1 is challenge? Because we know that multiple pricks are needed to manage the type 1 diabetes effectively. 4 to 5 pricks of insulin, maybe 6 to 7 pricks for the glucose monitoring. And this makes a headache for the parents. Also, there are dietary restrictions, not as to the extent of type 2, but still type 1 patient needs to have dietary restriction. Also, there is a risk of hypoglycemia. And for this, parents try to give lesser insulin, leading to hyperglycemia and long-term complications of type 1 diabetes. And as of now, we know that there is no cure available of type 1 diabetes. So these all are challenges related to type 1 diabetes. And as a human, we try to find out the solution for the same. So what we did, the main issue is pricks. So we try to decrease the prick. So first, we went for the continuous glucose monitoring system, which continuously measures the sugars every few minutes and sends data to maybe our mobile or any device. And in this way, we could decrease the pricks and we could ease the monitoring as far as type 1 diabetes management is concerned. Then we know to decrease the pricks of insulin, we invented pumps. Pumps deliver specific tiny amount of insulin every few seconds so that multiple daily injections can be avoided. This also helps in metabolic stability, decrease in the hypoglycemia, and overall increase in the time in range. And with the help of AI interface, we make pump automatic. So pump automatically delivers insulin when and when needed, and also pump stops when pump needed to stop. Who knows, maybe we can have transplant or we can have permanent cure for the type 1 diabetes as well. So these are all invention, use of technology to ease the management of type 1 diabetes as far as doctors are concerned, as well as far as parents and patient is concerned. So we use CGM, but study showed that despite increase in the use of CGM, there is not much decrease in HbA1c. There is not much proper or effective management as far as the hypoglycemia is concerned. Because whenever CGM shows that there is a spike in insulin, mother or parent need to give correction. And here, there are complications, there are hesitations from the parent side that they don't give extra shots, because already they are giving 5 to 6 shots of insulin as well as they are monitoring glucose. So CGM alone is not enough. So then we invented pump, and these are the earlier pumps. These are of small carry bag size. These are the very initial, you can say primordial pumps, in which insulin has been put on and they deliver small tiny amount of, you can say, insulin injections every few minutes. And then as a human, we invented far beyond this pump and now come up with the very small tiny pump which acts specifically as we want them to act. So for the ease, I have divided into generations. So generation 1 pump came into existence maybe 30-40 years back in India, and this pump injects insulin slowly at a predetermined rate. So we have to decide the rate according to the patient's sleep pattern, activity, and diet, and pump delivers that specific tiny dose every few minutes. So this will become their basal rate. And whenever parents want that his child has to be delivered bolus, they just have to press the button on the pump so that the same insulin goes as a bolus. So with the use of just one insulin, it can be of basal as well as it can be of bolus as well. So this was the first pump. Then, as we know, we are humans, right? We try to invent more and more and more. So then we integrated this sensor or CGM system with the pump, and then this CGM sends signal to the pump every few minutes regarding the glucose readings. And whenever this pump senses that it is going into low, that is hypoglycemia, the pumps sounds a beep or pumps give us an alarm, so that patient as well as parents knew that now this is a hypoglycemia state. And then parent or patient need to stop the pump, maybe decrease the rate, maybe stop the pump. So with this invention, there is decrease in cardiovascular complications and mortality, as well as there is a decrease in the hypoglycemia, and a mild to moderate reduction of HbA1c achieved. But still, hypoglycemias were occurring because there is no provision of intervening before hypoglycemia occurs. So then comes the generation 2, or we can say sensor augmented pump, in which what happened that whenever pump gets a hypoglycemia alarm, pump will stop its functioning. And whenever again sugar rises and goes above the threshold level, then again pump will automatically start. So in this way, hypoglycemia is prevented and hypoglycemia is managed effectively at the start of the hypoglycemia reading level. It's just like whenever you have met with an accident, the airbag flows. But another invention in which predictive action of the pump is there, in which pump says that now sugar readings are decreasing very rapidly. So pump stop even before hypoglycemia occurs, and again pump starts whenever sugars are rising. So this is called predictive threshold action, in which there is no hypoglycemia. Pump stops even before hypoglycemia occurs. Just like our ADAS1 and ADAS2 system in the car, in which car sense that now accident might happen, so car gets automatically braked or slow down its speed. It is the same technology in pump. So these are the generation 2 pumps in which suspension before hypoglycemia occurs as a predictive manner happens. And with this pump, we could have prevention of hypoglycemia and more of an HbA1c reduction. So this we are advancing. First, there were simple infusion pump, then alarm, then stopping at hypoglycemia, and then stopping even before hypoglycemia occur. So these are the advantages of insulin pump, which are sensor augmented. But still, basal rate you need to set with this second generation. Time in range was very variable because patient has to give boluses whenever hyperglycemia occur. There is no provision of mealtime delivery. Patient or parent has to inject the mealtime bolus, as well as there is no automatic identification of meal as well as sleep pattern to have those tiny adjustment as far as the time in range is concerned. So then we come up with the third generation, in which the pump is working on the AI model. Whenever this pump is applied to the patient for first 2 to 3 days, pump sharply observes the pattern of that individual patient, that whenever sugar goes down, whenever the patient sleep, whenever the patient is removing pump for bathing or physical activity, this all is recording. Then algorithm is made for that specific patient, and then according to that, pump sets the basal rate. So we don't need to set even basal rate as well. Pump keeps a target of maybe 100, 110 or 120. And whenever sugar goes beyond or below this target area, pump either gives more bolus or gives less bolus or even stops. So with this, we are closing the loop in terms of no need for basal adjustment. Pump gives this tiny basal every few minutes and adjusts the sugar to be remain in 100 to 120 range. So this is regarding basal, but still there are chances of shooting sugar whenever patients eats or whenever patient is in stress. So again, another invention leading to automatic bolus delivery as well. And this, what pump does that whenever sugar shoots rapidly, which is out of the control for the basal delivery, the pumps give extra bolus shot every 5 minutes. So imagine every 5 minutes, there is an extra bolus to keep the sugars in control. So whenever sugar goes above the 120 range and pump thinks that now it is going beyond the maximum basal delivery, it gives tiny boluses as well. So with this tiny bolus, again, sugar is coming down towards our target. And whenever sugars are in target, pump stops giving those tiny boluses as well. So with this, we are able to achieve 100 to 120 of our target for more than 50-60% of the 25 hours, which is practically impossible for multiple daily injections using either pen or using either syringes. So in a way, if you think we are working towards artificial pancreas, in our normal pancreas, the glucokinase senses the glucose, according to which insulin, which is pre-synthesized in our beta cells, released into the bloodstream, and it acts according to the sugar level of whatever we have ingested sugar, or either we are in stress. So this closed loop is working on the same model. It delivers specific tiny amount of insulin according to the sugar pattern, which is specific to that patient. But again, with this closed loop system, there is no automatic meal bolus which is to be given, because pump and sensor doesn't know that we are eating or the patient is eating, so that he or pump should be ready with the more of a bolus. So nowadays this Medtronic company is coming up and teaming up with the one of the daughter or sister company of the Apple, in which there are researches going on that patient has to wear Apple Watch, and at the specific time, if patient eats and specific movements occur, then this Apple Watch sends a signal to the sensor as well as pump, and then pumps thinks that now the patient is eating, and pump should be ready for the bolus of that meal as well. So maybe in future, next 4 or 5 years, maybe 10 years down the line, there should be no need for even bolus as well. Because of this technology, automatic mealtime bolus may be delivered, and we will be able to deliver almost artificial pancreas model, and this is called advanced hybrid loop system, in which automatic basal delivery occurs. Whenever sugar shoots, tiny boluses are delivered just like our pancreas, as well as whenever we eat a meal, it detects motion, it sends the signal to CGM as well as to the pump, and pump delivers tiny boluses according to the shoots in the spike due to the meal, and automatically meal boluses are also to be given. So this is related to the concept of hybrid loop system. And also advanced loop system assesses our sleep pattern, our exercise pattern, our stress pattern maybe, and according to that, pump is also ready for the corrective insulin for these tiny fluctuations of the sugar as well. So maybe in future, who knows, our all type 1 diabetic with the use of AHCL might achieve the target of time in range between 100 to 120 for more than 80% of the time. So starting from the simple infusion pump, now we are coming to the advanced hybrid closed loop system. And maybe who knows, type 1 diabetes will not be headache for the patient as well as doctor with the advancement of this AHCL. So with this concept, I stop my talk, and thank you very much for the patient listening. Thank you.
Thank you very much, sir, for the lucid presentation. I request Dr. Vibha to come on stage and kindly give memento to Dr. Chetan.
So it was a very wonderful talk, and the concept has really been covered. So now you have made a mind that the patient should go now into advanced hybrid closed loop system. Now, what are the practical issues? How do you really onboard the patient? And how do you really solve some of those practical difficulties which may happen? And for that, we have got Dr. Manoj Kumar Agarwal, who was fellow with us also till very recently, a couple of years ago. And he is currently working as an endocrinologist and pediatric endocrinologist at Shalby Hospital, Ahmedabad. And he has been quite active in the field of diabetes in children, very actively involved with ISPAD. He is part of the ambassador program that they have, which spreads information, and he's been doing a lot of awareness program. And he is also a consultant nutritional advisor for a whole lot of doctors across Gujarat. He has developed a very innovative program called Dal Roti Ka Sawal Hai. And that probably you can also get some glimpse of that, because that also is relevant on. So Manoj, you can carry on forward with two specific topics. One is related to the aspects of how do we put somebody on pump. And second, what are the practical issues that we face in that perspective? Over to you, Manoj.
Thank you very much, Anurag sir, for such a nice introduction. So I would like to thanks for inviting me. And it is always great to have be with my Kanpur family. So that is our innovative CM is Dal Roti Ka Sawal Hai. As a prescriptions writer, we often missed to write our prescriptions. And according to the Gujarat research, we have 53% of the diabetes in the doctors. So that is why we came with the innovative idea of Dal Roti Ka Sawal Hai. So without the wasting of time, I would start my sessions. How many of you are using the technology? I think everybody. So now we are in the world of the technology. So if patient is asking to us for the CGMS and the insulin pump, then what would be the answer from the family perspective? Might be their answer would be simple, yes or no. But from our perspective, we have to ask the variety of the questions, and we have to ask the variety of the questions to the ourselves. Let's start with the story of 10-year-old boy who was on the MDI and wanted to move on the 780G pump, which Dr. Chetan has been talked very nicely. So from the clinician perspective, how to start, what is the role of the clinicians, what are the criteria should be fulfilled, how to calculate the bolus, how to initiate the protocol. If reports is coming to you, then how to interpretations can be done, and what are the clinicians' perspective in terms of the hypo and hyper. So we will talk for entire 9-10 minutes regarding these series of the questions. So many physicians thinks that a pump is fully automated, but my answer is no. Still, we have to work as a guardians of the safety. How? Because as a clinicians, we have to set the auto bolus. We have to decide the carbohydrate ratio. We have to see the active insulin's time, and we have to set the auto basal mode. But from the automatic perspective, pump will decide the automatic basal that will work on the auto basal target. So answering to my second questions, what education is required before putting on the insulin pump? So that is a very important steps that it will take more than 10 days for the starting of the insulin pump. But what are our perspective mainly? From the clinician's perspective, we have to check the eligibility criteria. If patient is enough educated to understand what are the criteria for the pump, suppose if you are putting that technology not friendly family, then it would be disaster. Then we have to idealize our expectations and the responsibility of the family. They may have an expectation कि pump लगाया सब कुछ सही हो गया. It is not like that. We have to ask them to have a responsible for the sensors alarm and the sensor response. So my third questions, when to start and what are the insulin is required for this pump? So it should be started on the earlier on the day and earlier in the week. Why? Because we can get a easy help. And before the starting the dose, if the day before we have to reduce 60% of the basal insulin. What about the bolus? Bolus could be the same, but we don't have to forget the reduce the basal to avoid the hypoglycemia on the pump day. And we have to set up the pump. How? You can see in the screen that we have to set exact date and time. Why it is important? Suppose guess you have entered PM and rather than the PM, you have entered AM. So at the night time, patient may have a hypoglycemia. So at the initial periods, you have to ask the patient to set an exact date and time, bolus menu and the basal menu. And we have to explain the anatomy of pump, that is an insulin pump, insulin infusion, what is the reservoir, and what insulins can be used. According to guideline, 3 insulins can be used: Novorapid, Humalog, and Epidra. So coming to my fourth questions from a clinician's perspective, how to calculate the bolus? So we have to decide the basal and the bolus. If patient is on the previous pump, then we have to continue that setting. But for the bolus, we have to take care about the fourth thing: insulin carbs ratio, insulin sensitivity factor. We have to set the blood glucose target and active insulin time. How much of the carbohydrate is covered by the 1 unit of insulin, that is the insulin carbs ratio? How much sugar will be covered by one unit of insulin, that is the insulin sensitivity factor? What is the blood glucose target? We have to put the specific target. How? Suppose if you are dealing with the more than 15-year-old kids, then your target would be very strict because you are not in the fear of the hypoglycemia. So might be it would be 90 to 100. But when you are dealing with the very small kid, when you have a fear of the hypoglycemia, your target mood would be 110 or 120. So according to your clinical practice, you have to set the target, and you have to decide the active insulin's time. Means for the how many durations the insulin will be active. Means if you are eating the gulab jamun, that time your active insulin's time would be 2 hours. But if you are eating something pizza or like protein or fat rich diet, that time active insulin's time would be 3 hours. So that is how we have to decide the bolus. What about the basal? Suppose if a patient was on MDI taking a 60 unit of the insulin's total daily dose, then you have to reduce 15 to 25%. Suppose if you are reducing 20%, means 60 minus 12, that is a 48 unit that you have to give. Among them, 50% should be bolus and 50% should be basal. So 24 is a bolus and 24 is a basal. And that 24 of the basal, you have to divide it by the 24 hour of day. So ideally, you have to give 1 unit per 1 hour. Might be at the night time, your basal rate would be a little bit lower, but at the daytime, it would be higher. So according to your clinical practice, you have to decide. And for the bolus, same formula you have to take care about: insulin sensitivity, carbohydrate factors, blood sugar target, and active insulin's time. So regarding the education perspective, company person may take care about the CGMS setting, but we have to advise to be in the smart guard. Can you tell me the difference between the CGMS setting and the smart guard setting? CGMS is eye of the insulin pump, but smart guard is a brain. Whatever target you will decide, it will try 100% base to be in that range. So all patients should be advised to be use a smart guard. And from the education perspective, we have to explain the patient when to give bolus, when to resume, and when to suspend. We have to explain the carbs counting. We have to explain to giving the collection bolus, and we have to explain to give a calibrations. If you are using the G3 sensor, then 12-hourly calibration is required. If you are using the G4, then no calibration is required. So from the education perspective, it is very, very important that it is not fully automated. Still, you have to announce your boluses. So that should be not missed. To asking my fifth questions, that what is the initiation protocol and what are the interpretations of the reports? Might be it is looking at busy slides, but I would try to explain one by one. So if you are seeing in the topmost slide that it is giving 2 dates. In the blue, that is a current date that you want to compare, and the orange is the last date that you want to compare. So you can compare with your current data with the previous data. You can see the beautiful graph here that you can compare with the previous data which is mentioned in the orange. So you can have a comparison always. You can have a hypo and the hypoglycemia event rate. Suppose by the generating reports, you can see what time patient may have a hyper and hypo, and according to that, you can act. And you can decide what is the carbohydrate ratio at the different time zone. Yes, here that is a beautiful thing that you can see what is the comparison of the time in range. If you compare in comparison of the time B, your time in range was improved in the 8 time periods with the similar episode of the hypoglycemia, but with the less time with the time above range. So you can always have a comparisons while having reports. And this is the features of the smart guard exist. Then you can see in this data that in comparison of the B, in the time frame of the A has a no sensor exist. And you can see the reason also, okay, why the smart guard was not working in the B frame of the time, because sensor was updating, sensor expired, and the prolonged suspension. Because of that, smart guard exists. So you can have all the data in your reports, and here you can have a statistic that for how many durations patient have wore the sensor, what is the smart guard wear per the week, and you can have a GMI. What is the GMI, if I can ask? It is a calculated HbA1c by the CGMS data. So you can have your current every day's 14 hours HbA1c. So you can see in the comparison of the time B, there was improved CGMS GMI in this setting. and you can have a statistic about that. You can have your average blood sugar. You can see that in the blue line, that average blood sugar was 138 in comparison of the previous time. And you can see what is the insulin doses was going on. Previously, patient was taking the 60 unit. Now it is taking the 54 units. And how much bolus is given? That is a 55% of the total daily dose. And you can see the reason, because patient has improved their meal pattern, and because of that, the meal pattern and the insulin and the time in range has been improved. So by the one report, you can have a whole idea about the what patients are doing, how much a meal is added, how much carbohydrate ratio is added. So it is looking all the busy slide, but A is given by the time frame. Second is a graph. Third is a hypoglycemic and a hypoglycemia event. Four is a CGMS data that you can always compare. Six is about your smart guard statistic, and here you can see the insulin time, meal bolus, and what is your target. And six is a smart guard techniques. So I want to discuss the last point. What are the clinicians' interpretations for the hypo and the hypers? So suppose if patient is going low, means time in range is low, then that time we have to check the insulin carb ratio. Suppose if you are giving insulin carb ratio is 7, so you have to add 3 more. So instead of the 7, your insulin carb ratio would be more. If you have a hypoglycemia on that setting, then you have to decrease the insulin carb ratio. And if your time in you are constantly having the hypoglycemia, then you have to check every setting. You have to decrease the carbohydrate ratio. You have to increase the insulin's timing. That you have to everything you have to take on care. And if patient is wearing less than 80% of the sensor, that time education is must. So might be it is overlapping, but you always have to see insulin's carbs ratio and the time in range. And this is the ideal recommendations that best practice should be done, that you always have to check on the manual mode. And you have to always set the target in the range of 100 to 120, specifically in the pediatric age group. So end of my talk, that pump is not fully automated, but by manual interpretation, we can have a based response. So I'm completing my first talk, and I'm starting my second talk about the practical issues with the insulin pump. It was a very difficult talk for me, because I was talking about how technology is looking beautiful, and now I'm talking about what are the practical issues. So before 2 days, just I was calling Dr. Sajili. That time I heard a caller tune, and everything. I think everybody has that caller tune. Can you tell me the answer? What caller tune you have? It is Amitabh Bachchan. Yeah, Amitabh Bachchan's story. And what Amitabh Bachchan was talking about? Yeah, digital fraud. Yeah, so exactly that at that time, one thought has come in my mind, that we were technology pro people, but we are seeing the practical issues with the technology. So same with the insurance pump. So this is the story, that 8-year-old boy recently started on the insurance pump by our 2 motivation talk, and patient went on the family vacations, and within 1 day, patient was doing better, but within 1 day diagnosed with the diabetic ketoacidosis. And you can see what is the reason. Can you guess the reason? Yes, it was the blockage. And within 1 day, patient has a diabetic ketoacidosis. So there are the practical point is going on with the insurance pump or any of the technology. So manual interpretation is must. So we love the technology. It is a brilliance, but we have to always take about that brilliance. So what are the selections criteria? We cannot use less than 6-year-old child whenever our maximum requirement is there. And if patient is taking less than 7 units, that time we can't use the insulin pump. So that is a practical point. We have some disadvantages regarding the usability and interference challenge. How? Because insulin pumps require active training. 84 days training support is going on. That time, patient may have a mental fatigue. we may like to see the reels and we can spend the 1 hour in seeing the reels, but this is not like very exciting to some family. So there is a technological burden is there, and there is a training burden is there, and constantly we have a alarm. Alarm is buzzing on. We have a low alarm. We have a hyperglycemic alarm. So that time mental fatigue is there, and there is always gap between the parents and the family regarding the technology. What? Because they have to understand the programming interference, they have to see the troubleshooting, they have to understand the understand the alarm, and they have to take the appropriate actions, and that sometimes that create the negativity towards the family. फिर उनको लगता है कि अब नहीं लेना है. So that is a creating the practical issues in the that perspective. This is the second case. 14-year-old boy, real life case scenario which I have faced in my clinic before couple of days. 14-year-old boy, we have put it with the insulin pump, 780 g pump, and constantly that patient had a HbA1c was 8.1. Previously on the MDI, where his HbA1c was 8.9. With the insulin pump, I was expecting 7.5, but constantly he having the HbA1c more than 8. And the primary issue that my diabetic educator found that patient was not announcing boluses. So we have to always announce the boluses, and we have to always announce our meals. Whatever meal they are taking, we have to announce. So that is a practical point. And from the discovery perspective, many people forgetting announcing the meals and administration of the bolus that create the hypo and the hyperglycemia. So and the many setting that my diabetic educator have an insulin pump, but many time he has to take a more protein rich diet. So he was entering the ghost or forget carbohydrate entry. So some instead of the 30 carbohydrate, intentionally he was putting the carbohydrate like 20. So there was a fact carbohydrate entry is there in this setting. This is the second case that I was discussing with the Anurag sir, that 17-year-old students was experiencing trouble during the board exam. Patient was started at the insulin pump, and after 6 months, patient had a board exam. Patient was stopped at the security checkpoint. For to the normal physician also, insulin pump is not familiar. So for the layman, it was not familiar. And after so many documents, they allowed to sit with the insulin pump in the exam. But when patient has seated in the examination hall, that time it doesn't work. Why? Because his jammer was there, and insulin pump stopped working. So, and that time, at the very critical point of the time, during the board examination, patient had a no backup. So, this is the real life challenges that my patient may feel. And constantly, there is a alarm fatigue is there regarding the hypo and the hyper. And whenever time is there, when the alarm should be there, that time, because of the alarm fatigue, it was not working. That was causing the diabetic ketoacidosis. You may surprise that why it can cause the diabetic ketoacidosis in one day. In your clinical practice, patient is on MDI, then it will take 3 to 4 days to have a diabetic ketoacidosis, because something basal you are giving. So either 50%, but it is working. But here in that setting, there was no basal we are giving. We are giving only the regular insulin, Humalog or Tapidra. So in the 0 to 2 hour, patient have a feeling of the hyperglycemia. In the 2 to 4 hour, patient may have a feeling of the hyperglycemia with the ketoacidosis. And after the stopping delivery of within 6 hours, patients turn into the diabetic ketoacidosis. So we are starting insulin pumps to decrease our HbA1c, improve our glycemic control, but we are knocking at the door of the hyperglycemia and the diabetic ketoacidosis. So there is a hidden danger of the technology reliance that it can cause the rapid deterioration. It can cause the silent failure, and we may require the emergency care in this particular setting. But these all things can be preventable. We have to educate the patients and the family in the structural manner. We have to explain that they have to ready with the backup plan. So always pen and syringe should be available at the backup point of the time, and we have to do the regular security assessment. Other issues that we find with the insulin pump, that pump page kinking, that is a major issue, site atrophy, and we have to change the pump and the pump pages every 3 days. And what are the issues that regarding the calibration? That if patient is using the G3 sensor, then it should be changed every 12 level, calibrated with the every 12 level. But with the G4 sensor, no calibration is required. But calibration is must when we have a continuous hyperglycemia. And you may have a fear of the diabetic ketoacidosis at the time of the sick day, but many time it is well documented at the time of the sick day it doesn't work. So it is always a limitations to have a manage with the sick day. And what is the skin issue? That a glue reaction is there. When I was in the Singapore with the type 1 diabetic therapeutic conference, that time they applied to CGMS to everyone, and that time I had allergic reactions. So glue reaction is very common. That is a 42% in the pump users. And tap insertion is difficult. Excessive sweating is a problem. And if you are giving simple paracetamol, then also the entry, the sensor performance will be the questionable, because according to the company guideline, it is mentioned that if you are using the paracetamol, Dapsone, or any interfering drug, then you have to take care. So this is the data that 42% has a gum or the skin issues. 220% case has been reported due to the app-related injuries, and 170 event has been noticed and well documented with the hyperglycemic event. And that this was the last slide that I was talking about, Amitabh Bachchan's slide, that 780G has also reported the cyber security fraud. So we always we have to take everything as a pinch of salt. And many insulin is preferred, but if you use the Epidra, then might be precipitation can be seen according to their data. And the most practical issue from the clinician point of view and from Indian market setting, that you might be agree that it costs 6 lakh rupee one-time investment and 20,000 per month recurring budget. So it is not looking just inexpensive. It is inaccessible to the many family, because it is monthly 20,000 expense is there. So many times they do have a mechanical and the hardware failure. Like you have seen the movie of the Brad Pitt of the Achilles, and the tube kinking is a like Achilles heel. It can cause the diabetic ketoacidosis. And there is always a problem with the reservoir and the troubleshooting, and there is always some issue with the battery life and the physical damage. But I think in the comparison of the MDI, these complications and practical issues are very little. If we educated the patients and the family well, then might be we can overcome with these practical issues. We have to give the comprehensive training, we have to back up the insurance plan, we have to rotate the site, and we have to follow the security protocols. So at the end of my talk, technology always bring excitement to us, but manual inputs is must. So by that talk, I would like to complete my this two talk. Thank you very much. Yeah.
Thanks a lot, Manoj, for this wonderful talk. And you've really covered a lot of issues which are there with regards to the overall process. And of course, any technology will have its own limitations. But what we need to understand is that the good use of technology is something which is going to be quite beneficial in that regards. I'll just give you an example how things have improved. Just hold on, yeah. So how things have improved. So when I had gone to Australia in 2005, the pump uptake there was only around 10%. So they had started, and within 3 years, they had become 60%. And now the figures are close to 80-85%. So I think if the cost is not an issue, then there is not much of a doubt that this represents a significant leap in technology. But the other thing that often the parents think that when we have started the pump and this is the end of the story, ab hame kuch nahi karna, apne aap auto mode, everything will happen. That is not true. So I always give an example that you may have a Nokia phone which is working fine and you go to iPhone, you can't use it, you are logged out. So that could be a problem which can cause a big issue in terms of overall perspective. So I think this aspect has been very well highlighted by Manoj, Chetan, both of them, that we have to take it with a pinch of salt in terms of what could be the possible complications and other issues which can be there in that perspective. But definitely this represents a significant advance. I'll request Dr. Alappan to kindly come up and honor Dr. Manoj with a memento. And now we have discussed about what are the concept of insulin pump, how do we really go forward in terms of insulin pump. The next issue, of course, is now we have talked a lot about the practical issues, but what really are the hardcore evidence? Because unless we have the proof, we cannot use it from that perspective. And I'm really happy to have Dr. Saurabh Uppal, who is a renowned pediatric endocrinologist in Jalandhar, Punjab, and has been very closely associated with our events, have been participating here for over a decade. And every time he's coming, thanks Saurabh for coming. Saurabh doesn't need much introduction to pediatric endocrine circle. He has done a lot of work in pediatric endocrinology, especially diabetes technology, closely associated with ISPAD, ATTD, and other organizations as well. He is also currently the treasurer of Indian Society of Pediatric Endocrinology. So he's part of our team in from that angle as well. And I'm very happy that Saurabh is here and he'll share his own experience as well as the overall global experience of how advanced hybrid closed loop systems do make an impact. Over to you, Saurabh. Thank you.
Thank you, Dr. Bajpayee. In fact, I am really happy I was there to be here. I was just thinking, out of all, it is the sixth APES, and I think I missed just one of them. So it's a very nice feeling to be here again. And to all of you, congratulations. You are through and you are now deep into pediatric endocrinology. So I would put this question to you. Why are we so excited about insulin pump now? Dr. Bajpayee just mentioned that from 10%, it has come to 80%. Why is that? So suddenly in the last few years, 2, 3, 4 years, the pump uptake has increased. So there is a hospital which is the flag bearer for these technologies. It's in Slovenia, Ljubljana, that hospital. So there are 950 children in that hospital with diabetes, and 926 are on insulin pump. And most of them are on advanced hybrid closed loop. So why we are so excited and why the uptake is increasing? Because this is a technology that has been a game changer for children who are already on insulin pumps also. We're not talking about all children with diabetes. Those who have been on the previous generation pumps have now graduated. And most of the children now on insulin pumps in insurance reimbursed markets are on advanced hybrid closed loop. Very few are on the previous generation pumps. So we need to, and in a few years, this technology is going to replace all the previous technologies which were there, even in the insulin delivery. So we're talking about automation, and my job is to inform you, maybe to make you understand why this technology is good and why it is changing everything around the world for children with diabetes. So when we talk about diabetes, when you have treated children with diabetes all through your pediatrics career, and what you're really scared of is hypoglycemia. Always, sugar kam na ho jaye, sugar kam na ho jaye. Parents are concerned about hypoglycemia. Doctors are concerned about hypoglycemia, but the picture is bigger. And this is how we started looking at the picture. This is in 2020, this landmark paper came out, which showed us that chronic hypoglycemia in small children impairs the working of the brain. This is because functional MRI came. When functional MRI came, we could look at brain function. Before that, it was only a static MRI. Now, functional MRI showed that chronic hyperglycemia impaired working memory in children as young as 4 years old. So that means high glucose was dangerous. And this is the population where we think, let the sugar be a little high so that there is no hypoglycemia. That's what doctors think. That was a chronic hypoglycemia. And then what happens in acute hypoglycemia? So this is a very elegant study from Ljubljana, which took adolescents with diabetes and adolescents without diabetes, put them into a functional MRI, and induced and saw how their brain functions when their glucose goes up. Now, this is the finding. The same areas lit up, which were lighting up in the previous study for chronic hypoglycemia. Hyperglycemia we're talking about, not hypoglycemia. You've always heard about hypoglycemia. I'm talking about raised blood glucose. So the same areas lit up. And what this study showed was, if you have diabetes and your sugar is high, your brain is not going to function well. So child with diabetes and adolescent who sits in an exam with a high blood glucose, his brain is not going to function as well as it would have functioned if the sugar was normal or the child did not have diabetes. So high glucose is dangerous. And then came this closed loop. Closed loop, very elegantly, Chetan has told you what is closed loop. That means so you already know what is closed loop. Now, this is a very primitive closed loop. How do I point? forward and this is the pointer. No, it's not pointing. I want to highlight something. Okay. Okay. This one. This is a very primitive closed loop. So the time in range here you see is around 50%. Wait, see the second line, and this is 57%. So present pumps have time in range of 80-90%. This is a primitive closed loop. So if you put patients on closed loop, we already saw that their brain gets damaged if they are high on glucose. But if you put them on closed loop, whether the brain recovers or not, that is what the proof is required. So the answer was this. In 6 months, once you put them on closed loop, their brain areas started showing a recovery. Next, this very elegant study used MRI spectroscopy to look at N-acetyl aspartyl glutamate to creatinine ratio. It is a marker for axonal density and axonal death in the brain. So when you look at areas of the brain, as the HbA1c increases, the axonal density comes down. So that means if the glucose stays high for a long time, brain cells start dying. Second graph, you see decay is onset. This is very, very important for us to know because we work in such an environment where a lot of children come to diabetes diagnosis with a decay at onset. A single DKA at onset causes more damage than years of high HbA1c. So those who did not have DKA at onset had higher density of brain matter than those who had DKA. Now you combine these two, high HbA1c with a DKA at onset, which is a story for many of the patients that we care for. The brain density keeps on decreasing. The axonal density keeps on decreasing. That means the brain keeps getting damaged because of hyperglycemia. So higher HbA1c and history of decay significantly increase axonal loss. So you cannot allow children to have a high glucose as we have been doing in practice for the last decade. Now, you must have read about DCCT and EDIC trials when you were reading about diabetes. So these are the two trials that showed us how to manage glucose. This is the EDIC follow-up. So most of them are 60 years of age and have been having diabetes for the last 35 to 40 years. Now, the regional brain atrophy is pronounced in thalamus, the same areas as 4-year children had damage because of high glucose. Same areas are damaged in those in EDIC follow-up over 35 years of diabetes. And people with type 1 show an acceleration of brain aging without any early signs of Alzheimer-related neurodegeneration. So the brain aging is coming from high glucose. That is what we have learned. Now, doctors treating type 2 diabetes, they figured it out a long time ago. Because see, last 10 years, if anyone of you have seen people how the adult with diabetes are treated, their drugs are no longer causing hypoglycemia. The modern drugs are, the hypoglycemia risk comes in when they are getting onto insulin or some of the, I would say, the previous generation drugs. The modern generation drugs in type 2 diabetes don't cause hypoglycemia. So what they're looking at is a population which has effect of hyperglycemia. So this study showed that the areas that were damaged in those patients are the same as those which are damaged in type 1 diabetes. That means it is not the type of diabetes, but it is the hyperglycemia which is damaging the brain. Type 1 or type 2, doesn't matter. It is the glucose. Now, this is a study which had a large number of patients, followed people who were non-diabetic and then later on had diabetes. Now, see this. Even when they were pre-diabetic, mild cognitive impairment started. That means you don't need to have diabetes to have a damage in your brain. Pre-diabetes, what does pre-diabetes have? Pre-diabetes has dysglycemia. It does not have hyperglycemia. Even dysglycemia causes brain damage. And when you adjust for everything, behavior, medical conditions, physical function, everything else, high glucose damages brain. Now, we saw MRI in people with diabetes. Now, this study in North Korea, what they did was, can you look at an MRI and tell whether the patient has diabetes or not? The answer is yes. You can see an MRI and diagnose diabetes. Because diabetes starts pre-diabetes, because diabetes damages areas of the brain even before clinical damage starts showing in patients. This is very important in children. Because in children, problems will come later, but damage starts very early. Now, okay, if you don't have diabetes and you have a high glucose, still the glucose is damaging the body, not just the brain, but also the heart. Now, this is a study which looked at Europeans and had a genetically proxied HbA1c. That means the way that you see genes, create a score, and then see whether what would be the estimated HbA1c. Now, in individuals without diabetes, if you have a lower HbA1c, your risk for coronary artery disease is low. But if you have a higher HbA1c, so on the left you have 4.9 and right 5.8. As your HbA1c increases, before you having diabetes, your hazard ratio for coronary heart disease, this is 1. So you are constantly above 1. This is the light lines are the confidence intervals. This one is the hazard ratio, how it goes. Now this is proxied LDL. That means the LDL is out of the equation. Only looking at blood glucose, you have higher risk of coronary artery disease and the incident CHD in individuals. As your HbA1c increases, more people have coronary heart disease. So hyperglycemia is dangerous, and that's what I've tried to convince you. That it is not that you have to prevent hypoglycemia always. Hyper is equally, if not more dangerous. In fact, how many patients have you seen who have had a seizure because of hypoglycemia? If I say 100, how many? 1, 2, 3? But 97% of the rest of them who have hyperglycemia will have this brain damage. Now, whether it actually is happening or not, we are targeting hypoglycemia. What is happening? So what is the outcome? This is a study because in Europe now, most of them are on CGM. This is around 21,000 children on CGM. And as your mean sensor glucose increases, it does not decrease with increase. So I think the formatting has a little changed. So if you increase mean glucose, that means you allow more glucose, your hypoglycemia does not decrease. In fact, the hypoglycemia increases if you allow for a higher blood glucose because of increased insulin and various other reasons. In fact, and also what also increases when you allow higher mean glucose is your DKA risk. So once you allow higher glucose, hypoglycemia does not go away. Get this out of your mind that you can prevent hypoglycemia by not targeting high glucose aggressively. This does not happen. This is the evidence. So increasing mean glucose is harmful. Now, as the time in range increases, I don't need to tell you what time in range is. As your time in range increases, hypoglycemia does not increase. So you're not increasing the risk of hypoglycemia by a tighter control. You're in fact decreasing it. But what decreases when you decrease TIR is DKA. So allowing low TIR increases your diabetic ketoacidosis. So what is important? You increase TIR. And how do you increase TIR? You've seen in the previous 2 slides by using an automatic insulin delivery. Decreasing time below range decreases the variability, coefficient of variation. So as your severe hypoglycemia increases, it increases with increasing variability. What counters variability is if you give insulin when the glucose is going up. So that is why advanced hybrid closed loop is such a good technology. So coming to the evidence for AHCL, though this is the study which shifted people who were already on injections and CGM to a pump. Over the period of time, their HbA1c reduced. So the top one is those who are on injections, the lower one are those on pump, and the HbA1c reduces. We'll see what happens when the top ones are also switched to it in the next slide. Overall, 27% increase in time in range once you put them on closed loop. What is 27%? So 1% is around 15 minutes. So 27 means 6.6 hours per day more spent within target range. So 6.6 hours more without hypo and without hyperglycemia. So compared to those who were injections, more patients achieved an HbA1c of less than 7%. More patients achieved a GMI less than 7%, time in range more than 70%, but at no cost of increased hypoglycemia. So time below range is almost the same in both arms. Night is good because children don't eat in night, so you can actually evaluate a technology better during the night. So nighttime increase in the time in range was even more. So more than 30% increase in time in range once the more than 30% increase in time in range during the night time. And also the dose was not very different. So you don't need to give more insulin or less insulin to achieve better outcomes because 66% of the total dose is automatically delivered by the system. So it takes away the human error. At the same time, it takes away the human bias from the treatment. And there were no side effects, so it's a very safe technology. Now, what happened when those who were on injections were switched to pump? This is what happened. Their HbA1c also came down to the same level, and they also did as well as those who were on the automatic insulin delivery. Now, time in range increased significantly by 28% in those who were on injection at 6 months but shifted to pump after that. Now, this is the second part of the looking at the same thing. So, if you are switching them from MDI directly to pump, no CGM, straight away finger prick injection, go to advanced hybrid closed loop. The results are similar, 21.5% increase in time in range at 3 months with advanced hybrid closed loop. And those who have time in range more than 70%, 100% of those who are on an automatic insulin delivery had a time in range of more than 70%. Only 30% of those who stayed on injection had a time in range of more than 70%. There was no episodes of severe hypoglycemia, no episodes of DKA in those who went on a pump. So 1 year follow-up, they maintained the same time in range, you see. And also once the sensor, the calibration-free sensor was started, the outcomes did not change. What about exercise? How does advanced hybrid closed loop? I don't have time to go into the detail, but it works well. And it works best when you have announced exercise. So you reduce the bolus before the exercise starts and go accordingly. If you have sudden spontaneous exercise without telling the pump or planning in advance, still the pump has 65% time in range. Those who are on injections, they won't have this good time in range anyway. How old can you use it? Now, the Lenny study evaluated that, and now the results are out, is going to be published soon. Any child above 2 years can be put on the advanced hybrid closed loop, and they do quite well. Now, over 100,000 real-world users, the data came out, flattering time in range numbers, 72%, 69 and 76%. If you are looking at children, it is 70%, and adults, it's 76%. And most of them reach optimal settings. Now, this is the overall, the formatting has gone a little bad. So this is the overall picture. So we are interested in the blue bars, less than 15 years age group. 55% had a GMI less than 7%. Half of them have a time in range more than 70%. And in our practice, it's not unusual to see time in range more than 90% in those who know good carb counting. And time below range less than 1% in 85%. And those who had all parameters met. So GMI less than 7 is HbA1c, as Manoj told you, less than 7, TIR more than 70, time below range less than 4%. This is a staggering percentage. So in conclusion, hyperglycemia is the primary cause of short and long-term diabetes complications, not hypoglycemia. Advanced hybrid closed loop is currently the best options for individuals with diabetes. Reduction was achieved both in hyperglycemia as well as hypoglycemia. And more evidence is still welcome. So thank you very much. And
Thanks a lot, Saurabh, for the wonderful talk. And to cover such a vast aspect in such a small time, I'll request Dr. Vibha to kindly hand over a memento to Dr. Saurabh. And I think the key message is that while we have always been scared about hypoglycemia, Saurabh has really told us that why hyperglycemia is equally, if not more important. So I think we have had a very good discussion. If there are any questions, we will be happy to take it before we start off with the practical session. I'll request the team Medtronic, Dr. Lalitji and everything be ready with the practical demonstration. We'll be starting soon. If there are any questions or queries, we can go for there. Dr. Rahul, yeah. Mike.
Is there any criteria in that
Saurabh, you
study
can come up here, yeah.
to diagnose diabetes or pre-diabetic? Because what area shows in only diabetic and pre-diabetic patient? Are there in normal, those patients who are having normoglycemia? Or is there in
so
comparison?
the comparison is, so you look at MRI and you note the areas which light up on a functional MRI and also spectroscopy. And then you go back and see whether they have diabetes or not.
So what criteria they form to diagnose diabetes on the basis of MRI map.
Yeah, so there is a slide which shows which areas. So the areas are earmarked.
Huh.
So if these areas, I'll give you the slide. Yeah. So if these areas light up, the probability of diabetes. So that's what you calculate, and then you look back and see whether they have it or
Yeah,
not.
but it,
So this is basically a
Correlation.
pattern matching. So
Pattern
it's a AI based thing. So of course, nobody wants to say that you will diagnose diabetes using an MRI. What Saurabh was trying to say is that it is so particular and specific effect of diabetes in those areas, which
okay.
is there. So this is just that it's so specific that it's like digital signature. Now, what AI does is that when radiologists will see to a image or a MRS, they will see only few things.
Hmm.
AI will see millions of things you don't even know, and then it will try to correlate. But of course, that does not mean that, or nobody wants to say that you will diagnose diabetes using a MRI. But yes, those areas are affected.
So
Yeah.
it means
Okay.
whether you can look at that and say whether this patient has diabetes or not, and then you
Uh,
look back, go back
because-
and see, okay, whether he actually has
So
diabetes.
in a way, what can happen is that, see, this is how the futuristic people are talking about. You look at the eye and say whether they have a risk
Yeah,
of developing
it's a
stroke
kind of
10 years
window.
later.
Incidentally, we can.
Yeah, so it is like that, but I think it's too early to go into
Yeah.
that in terms of diagnostic. But that's a very important point which Saurabh brought out, that there are certain areas which have a specific predilection. Or like we know that hypoxia will affect this particular region.
Yes.
Like if you have severe, this will be affected. So glucose has a predilection for certain areas. This is what the thing will be. And this is very interesting.
Interesting, because there were the research on the mental trauma and mental retardation.
They've got out, and so from that study, they have created a scoring system.
Yes.
And the hypothesis now comes in that in the lenticulostriate area, the
Okay.
small vessels start getting affected way earlier, before you get diagnosis of diabetes. So that is the new hypothesis.
Thank you. Thank you.
So, and of course, diabetes is a continuum.
It's
So
a
when you say start of diabetes, especially type 2 diabetes, we don't know when it started
Yes,
and how it was
yeah,
gone. That
exactly.
just that we say that 6.5 HbA1c is diabetes. So if this is for R, but neurons don't know what level of HbA1c is high or what is not. So I think we had a very good session. I like to give a big round of applause to all the three speakers, Dr. Chetan for really talking about the concept, Dr. Manoj for the practical issues, as well as the onboarding, and Dr. Saurabh, who talked about so many other issues in terms of the overall concept of AHCL. So now I'll request, so we'll now have a hands-on session, and you have some, you can maybe start off with the, so over to Lalit ji and the team.
Thank you very much, sir. Thanks a lot for giving us the opportunity. My team. Well, Where are you from, David? Check. Check. So basically, we have the one Lenny girl demo for the demonstration purpose. We have the hands, that insulin pump. So this is a very simple process. Just start as 1, 2, 3. This is a cannula known as the quick set that includes the 9 mm or the 6 mm Teflon cannula along with the tubing. The tubing also comes in the variable lengths. One is the 23-inch and another is the 43-inch. So in the very simple way, we just took that cannula in simple way, and this is the serter which would be useful for inserting the same. Just simply insert the serter, remove out the cap, peel out the tapings, and just load. Once it is been loaded, and then this is the navel part, and 4-finger fars of the navel part, we can draw the M or W kind of the shape. There are the various points we can use it, that cannula at the site, and just determining the place, simply press the both buttons simultaneously and then press upper one button, and it has been successfully applied. This cannula can be, the tubing which has been added on the cannula can be removable whenever you wanted to go for the snack bath and any kind of the events where you wanted to remove that cannula tubing, easily can be removable. And the safety cap is also there. During the bathing, you can use that safety cap, so it can be prevent for the any water leakage and all. So this is how we have put up the cannula, and there is a one reservoir where insulin used to be get filled, and this reservoir capacity is 300 units. So we usually prefer for the insulin vials. Even from the cartridges also you can simply fill that. So you just fix the vial. There is a part known as the transguard. This transguard having the needle in both the side. At lower side you can use that reservoir, and then you can draw the insulin. For the 3 days insulin would be the more than sufficient for the patients. At the moment you will fill the reservoir, you just simply remove out the reservoir from the vial and then drawer. The now reservoir need to be connect with the tubing, the same tubing which has been deployed with that cannula, and then tubing you can go for the inserting process in the pump. There is some small process for rewinding the plunger, and after doing the small process, since the pump is been already Achha. Achha, achha. Since the pump is already been programmed with your multiple basal rates, whatever the doctor being prescribed, so the basal rates would be shifting automatically based on the time to time. So the basal delivery being continuously at the time of giving the bolus, that would be determined based on your carbohydrate content, whatever the carb doses would be prescribed based on your carb counting. And whenever the patient wanted to take the bolus, multiple bolus he can take. So it would be a very useful kind of the device for the users. And at the same time, if the patient wanted to go for the automated based pump, then we have the sensor augmented pump. I would also like to show how the sensor can be deployed easily. So this is the sensor. You need to just peel out the sensor in such a way, and we need to put it on the hard surface. This is the sensor inserter. Simply just press the inserter. It has been loaded. Take out that sensor from your arm, from this one body, shell body of the sensor plate. Find out the suitable place. We usually use to put the sensor behind of the arms, or we can also go for the doctor recommendation like thighs or the buttocks. Simply just press the inserter in the same way how we use for the cannula. Both button need to be pressed simultaneously. Simply take it out. And there is a one small pin that need to take it out. So the now sensor has been deployed successfully. There is another part known as the transmitter that used to transmit the body glucose data with your device like pump or the phone. Simply just attach the transmitter with the sensor, and then there is a process for the taping. I'll show you how easily that process is. So there are the two sides of the tapes need to be peel out, and then simply just use the taping, remove out both the peel outs. Now the sensor is being stick very adhered very easily, and now it will get connected your pump. It will start to give the pump data after 2 hours. Your glucose data will be reflected on the pump. If the pump is AI enabled, based on your data, pump will start to give the insulin delivery. If anyone is having any kind of the question and answer, please do let me know. Is there any queries? So my contact number is there, and I'm based out at Lucknow. I'm looking after entire UP and Bihar. If anyone is having any kind of the help or assistance is required, I'll be there for demonstration of your patients, or even for you also. Whenever you would like to conduct any kind of the hands-on insulin program for your type 1 patients and all, we are always ready to do that. So I would be very happy if anyone would like to ask any question or the concerns regarding insulin pump therapy. It seems all are very saturated. Thank you very much. Thanks a lot for your time. Have a great day. Yes, I can rotate my pump and device with table wise. So personally, we can take that, right? क्या हो गया सर? और ये टेप बना रहता सर, टेप से आदमी को लगता है कि ये एडेरेबल पार्ट है, वो लगा लेते हैं ना।
So we are having the live demonstration for individual groups. We will be having the case presentations from 12:30. We'll start with the case presentations. अब ये जूम अपना है, अभी ओजस वीडियो है मोर।
Yes.
कैसे? बढ़िया। जस्ट वी हैड द पंप। अब हम लोग केस से कर रहे हैं। केस वाला जी, उसके बाद से दो। ओके। ये इन्होंने फ्रीज कर रखा है ना, अभी रुक जाओ। इनको पिन कर देना है और इनको को होस्ट बनाना पड़ेगा। मेक को होस्ट। ठीक है, ये हो गया। वो तो फ्रीज किया हुआ है ना, अभी अभी रुक जाइए, कोई जल्दी नहीं, हमने नहीं किया था। वो स्क्रीन फ्रीज कर, अभी रुक जाए, कोई बात नहीं, अभी हम देख लें पहले, अभी थोड़ी देर में चालू करेंगे, 5 मिनट में। कहाँ पे आ रहा है? ठीक है, तो ये भी अपना काम हो गया। अब हमें केस वाला रेडी रखना है बस। लोग लास्ट मोमेंट में भी चेंज करेंगे कितने मिनट, तो कैसे हो सकता है? हम्म। So Lalit ji, we can maybe we are starting with the next session in 2 minutes. So So, good afternoon, everybody, and we'll continue with the next session, which is going to focus on case conundrums. And hope you all had a very wonderful discussion with regards to the insulin pump. I'll now be handing over to Dr. Nimisha to introduce the chairpersons and who will take over the session from there.
Thank you, sir. Good afternoon, everyone. Welcome to 6th APS. Now, we'll invite Dr. Anamika Saha, pediatrician from Dhaka, and Professor Manisha Maurya, Department of Pediatrics, Prayagraj. I request you both to kindly join us on the dais. Mm. Now we'll begin with one of the most intellectually engaging segment of the day, the case conundrum. We'll start with our first case, which is hypothyroidism, polyuria, and metabolic alkalosis, presented by Dr. Arpita Bhriguvanshi, Additional Professor, Pediatrics, KGMU, Lucknow. Welcome, ma'am.
So Dr. Arpita needs no introduction to this audience. She has been part of our programs now for a long time, and she is now working as a pediatric endocrinologist at KGMU and has done a lot of training. And she has always had a wonderful lot of cases to share. And this was a very, very interesting case, which I thought should definitely be discussed. And welcome, Dr. Arpita.
I can use the
You can use
first
this.
third of.
You can use like this or like this.
Okay, I'll try.
Whatever. Yeah.
Thank you. Thank you so much, sir, for those kind words. So I'll be presenting a very interesting case where the diagnosis was masked and misleading. A curious case of persistent electrolyte disturbance with poor growth. So a 6-year-old male child came to our center initially with the common complaint of short stature for a long-standing time. However, he was symptomatic since the age of 18 months with failure to thrive, progressive bowing of legs, and difficulty in ambulation due to that. There was also a history of excessive thirst and frequent urination around the same time. Around 3 years of age, he was diagnosed with primary hypothyroidism and was already on levothyroxine. There was no history of vomiting, diarrhea, bone fractures. There was no history of respiratory distress, nocturia, or any blood transfusion. No history of nephrotoxic drug or any family history of renal and metabolic diseases. He was a full-term normal vaginal delivery with an average birth weight, and his antenatal and developmental history was uneventful, and there was no history of consanguinity in the family. On examination, his vitals were normal and his BP was at normal centiles. He had mild pallor and angular cheilitis. However, there was no icterus, clubbing, cyanosis, edema, or lymphadenopathy. There were signs of florid rickets, as you can see in the picture. There was frontal bossing, depressed nasal bridge, widening of the wrist, double malleoli, chest deformity, as well as bilateral genu valgum, which was very much pronounced. Systemic examination was unremarkable except for mild hepatomegaly, and rest of the general systemic examination was within normal limit. On examination, his height was very, very much affected at minus 5.3 SDS. Weight was around 0.3.7 SDS. BMI, however, was normal at between median to +1 standard deviation. Bone age was delayed with the age of 2 years, 8 months, and he was chronological age 6 years. And as you can see in this X-ray left hand, he had all the radiological features of rickets in the form of cupping, fraying, and metaphyseal widening, and everything was there. So with these clinical possibilities, we had certain differentials which we considered. The first was renal tubular acidosis, because the predominant symptoms were polyuria, polydipsia, growth failure, and rickets. The next possibility was chronic kidney disease, because of the same polyuria, rickets, and growth failure. Celiac disease was also considered because of growth failure, rickets, as well as autoimmune hypothyroidism, which is a known association in celiac disease. Nephrogenic DI was also in our differential because of predominant polyuria and polydipsia. However, there were no dehydration in the child, and rickets also is not explainable by DI. Growth hormone deficiency, primary hypothyroidism was also kept because he was already a diagnosed case of primary hypothyroidism, but other features present in this child were not explainable entirely by these diagnosis. So on further investigations, it was revealed that he had anemia of nutritional origin. The renal function and liver function tests were normal with an elevated serum alkaline phosphatase. On biochemistry, there was mild hyponatremia and hypokalemia and hypophosphatemia, and vitamin D was in the deficiency range. On ABG, because RT was our differential diagnosis, it revealed a metabolic alkalosis picture with a bicarb of 30 and pH of 7.5 with a normal anion gap. Serum osmolality was normal with a dilute urine. TSH was elevated on our first visit, showing that it was not properly controlled with a low free T4. Cortisol was normal, and total IgA and IgA-TTG for celiac was normal. So essentially, the RTA, which was our first differentials, was ruled out in view of alkalosis. CKD was ruled out. Celiac disease was ruled out because the TTG was normal. Nephrogenic DI was ruled out because the serum osmolality was normal and there was no hypernatremia associated. So the initial management in this child was as per malnutrition and vitamin D deficiency. So vitamin D as well as calcium was prescribed at appropriate doses for 3 months. Levothyroxine dose was optimized, and nutritional rehabilitation in the form of multivitamin and micro and macronutrient supplementation was ensured. High calorie and high protein diet was included, and iron supplementation was ensured. Growth monitoring was done. However, he was lost to follow up for certain time, and he came again at 3 months. At that time, we repeated the X-ray of the left hand to look at the radiological healing, which was not there in this child, and the growth velocity was also suboptimal. So we decided to investigate the child further by admitting this child. The hemoglobin had normalized. However, there was severe hyponatremia and hypokalemia on this admission, with severe hypocalcemia as well as severe hypophosphatemia. ABG was repeated further, which showed more pronounced metabolic alkalosis with a bicarb of 32.4 and pH of 7.5. Serum osmolality was still normal, and the urine was still dilute. However, the thyroid function was optimized at this visit, and cortisol was essentially normal. We did a further urinalysis because of severe hyponatremia and hypokalemia. There was increased urinary sodium and potassium losses in the form of increased transtubular potassium gradient, as well as the urinary sodium and potassium was high. The spot urine calcium and creatinine ratio was normal. Other urine biochemistry was normal, except for certain glucose urea, which was present. So now with This child having short stature, refractory rickets, persistent hypokalemia and hyponatremia in the background of metabolic alkalosis with early onset hypothyroidism, we revised our differentials. So Bartter syndrome was considered as our first differential. However, the absence of hypercalciuria, the presence of rickets were not explainable. Renal tubular acidosis, even in the presence of acidosis, was still considered, and a newer possibility of cystinosis was considered at this time because of proximal tubulopathy, early onset hypothyroidism, and rickets. At this time, the management was essentially to correct the electrolyte abnormalities. So IV and oral potassium supplementation and sodium chloride was supplemented in this child, continuing with the micro and macronutrient supplementation along with levothyroxine. Because Barter's was our first differential and there was hyponatremia, hypokalemia, and metabolic alkalosis, indomethacin therapy was started. However, it was stopped only after 2 doses because the child developed generalized edema only after a while of its start. Further investigations were done. So neck ultrasonography revealed thyroid lobes of normal size, but heterogeneous ecotexture was seen, basically telling us that it was infiltrative or autoimmune thyroid pathology. Renal ultrasonography showed normal size kidney without any structural anomalies or nephrocalcinosis, and slit lamp examination revealed, actually it clinched the diagnosis at this point. It revealed the presence of cystine crystals as shown in the figure. Further genetic workup was also sent in the form of whole exome sequencing, which revealed a nonsense mutation in the exon 9 of CTNS gene. We all know that cystinosis is having an autosomal recessive inheritance, and a biallele genetic mutation is required for the diagnosis. However, with the clinical spectrum and the biochemical evidence, we went on with this diagnosis and we didn't do further genetic workup. So the management at this point, we considered oral cysteamine, which is the cornerstone of treatment. However, because of the cost issues and this drug not being
Dr.
available in...
You just have left 2 minutes. Eight minutes
Yeah.
have passed.
Thank you. So it was considered, but due to cost issues, it could not be procured for this child. So the management was essentially supportive with sodium bicarbonate, potassium at 3 milliequivalent per kg per day, phosphate at 1.5 millimoles per kg, and levothyroxine was continued. Okay, and the child is under multidisciplinary follow-up with endocrine, nephrology, nutrition, and pediatric ortho consultation. And after optimization, the orthopedic correction of genivalgum will be considered. So with that, we come to the cystinosis background. We know it is a rare autosomal recessive lysosomal storage disorder with the mutation happening in the CTNS gene, and there's a defective cystine transporter leading to intralysosomal cystine accumulation, leading to the end organ damage. It is of 3 types: infantile nephropathic, which is our patient, juvenile, and ocular. Key clinical features essentially are presence of Fanconi syndrome, growth failure, hypothyroidism.
Dr. Arpita, time is over.
Okay. And the diagnosis is essentially slit lamp examination and genetic confirmation. The thing about metabolic alkalosis and cystinosis, which was not explainable in this child, we know that proximal tubular dysfunction leads to bicarbonate wasting, and we expect acidosis. We further explored what could be the reason in this child. It can be due to distal sodium increased delivery, which causes enhanced sodium reabsorption with potassium and hydrogen loss, leading to alkalosis. Secondary hyperaldosteronism, contraction alkalosis, as well as severe hypokalemia may all contribute to this alkalosis. A further literature review was done, which showed a handful of cystinosis cases similar to ours, having early onset with Barter's like.
So I think this was a very interesting case. The main message was that even if you have alkalosis, you still have to think of a possibility of cystinosis. We always find that. The other thing to remember is that acidosis in proximal artery is variable. You can often miss it. So that could be the message. So the chairperson's, your thoughts on this?
Yes, this was a very interesting case. I think renal tubular acidosis was your diagnosis, but still We had alkalosis at that time. So I think sir said we should be thinking, even if it is alkalosis, we should be thinking RTA if everything is favoring RTA. We also had one case, Lowy syndrome was diagnosed in that, proximal renal tubular, with mental retardation and rickets. Rickets clinched the diagnosis.
Right.
And I think the most important clue which was there in your case was glucosuria. So I always say don't look at blood gas in a child with proximal RTA. Look at other things, glucosuria, amino acid urea. Those will be the ones which will give you a clue. Thanks a lot, Dr. Arpita. I request Dr. Nimisha to hand over a memento to Dr. Arpita, please.
Rajib.
Okay, next presenter is Dr. Rajiv Das, Associate Professor, Bardhaman Medical College, West Bengal.
Dr. Rajib is very active in pediatric endocrinology in our group. He has all the more complicated cases. So we thought he will present one of those here.
Today, good afternoon. Today I am presenting a very interesting case. It is a case of dark complex child. A 5-year and 2-month-old boy presented in my OPD with progressive darkening of the child's skin for last 7 months. And there was multiple episode of loose stool and few episode of vomiting for last 3 days. There was history of hypoglycemic convulsion, 1 episode. There is also history of anorexia, lethargy, and weakness was present. But there was no history of any polyuria, salt craving, and no history of any abdominal pain, postural giddiness, and no history of weight loss. And there is no history of any difficulty in deglutation, and dry eyes was present. And no past history of any hospital admission or chronic illness or intake of any drugs. Developmental wise, all spectrum of development like gross motor, fine motor, social and language was normal. And regarding birth history, antenatal, natal and postnatal history was uneventful. There in family history, there was no history of any sibling death, and patient is immunized as per national immunization schedule. Now coming to the general examination, patient is alert, conscious, cooperative. There is no pallor, cyanosis, jaundice, no edema, no seborrhea. There is no spasticity, no dry eyes. But there is generalized hyperpigmentation, more marked in the oral mucosa, knuckles, nail. In genitals, there is no features of DSD. Regarding vitals, patient vital is stable. The heart rate is 65 per minute, respiratory rate is 22 per minute, and BP with a normal limit. Regarding anthropometric measurement, the boy is tall statured. The height is plus 3.03 standard deviation, and weight is also plus 0.47 standard deviation. On systemic examination, patient having no organomegaly. There is no hepatosplenomegaly, and there are no CNS findings, like there is no spasticity, there is no features of neuroregression or any cranial nerve palsy. Now coming to the investigation, as you see in the slide, the routine blood sugar is 115, which is normal. There is no hyperkalemia or hyponatremia. But here the serum cortisol level is very low and ACTH level is greater than 1250 picogram per ml. The LFT, liver function tests are within normal limit, and urea creatine is also normal, and calcium level is not high. We have also done the lipid profile, which is not displayed here, which is also normal. And CT adrenal, there is no hyperplasia or hypoplasia, and it is normal. It is the report of our hospital. Now coming to the summary of my case. It is a 5-year and 2-month-old male child born out of non-consanguineous marriage with normal antenatal perinatal period, presented with weakness and history of hypoglycemic convulsion and generalized hyperpigmentation all over the body and mucosa, with a height of greater than 95th percentile in CDC growth chart. On investigation, serum sodium and potassium are within normal limit, but serum cortisol level is very low and ACTH is sky high. Now, what should be the probable diagnosis? From the history and clinical examination, it is obvious that we are dealing with a case of adrenal insufficiency. Now, adrenal insufficiency may be due to central cause, or due to primary adrenal problem, or due to receptor defect. In case of central cause, there may be genetic etiology, or there may be infiltrative disorder, trauma, or radiation. Regarding genetic etiology, it may be due to MPSD or may be due to isolated ACTH deficiency. In case of isolated ACTH deficiency, mostly 3 genes are implicated: TPIT, POMC, or pro-convertage. Or in case of MPSD, if the early genes like SOX3 or HESX1 or LHX3 or LHX4 if involved, then there are not only pituitary manifestations, but there are also extrapituitary features like cranial involvement, like eye, ears, or tooth anomalies. But if the lateral gene like PROP1 or POW1F1 if involved, then only pituitary manifestation is present. Now coming to our case, in case of secondary adrenal problem, the serum potassium level will be normal because RAS system is not involved, and there will be no pigmentation because ACTH will not be so much high, because to be pigmented, ACTH should be greater than 1000. In case of primary adrenal problem, there may be due to defect of the steroidogenesis or primary congenital adrenal hypoplasia, or there may be some hemorrhage, infiltration, or some intake of drugs. But in case of primary adrenal insufficiency, there should be severe hyperkalemia and hyponatremia along with pigmentation, which is not present in our case. Now coming to the third category, that is the ACTH resistance case. In that case, patient may generally present with hypoglycemic convulsion, and serum sodium may be normal or mildly low, and serum potassium will be normal, and there will be marked pigmentation, which is present in my index case. So, number 3 points to my case, that is the ACTH resistance case. And also the age of onset favors my diagnosis, because if the age of onset is less than 1 year, then we can think about the CH variants and other DAX anomalies. And if the age of onset is greater than 5 years, then we can think about the autoimmune causes like Addison's or APES type 2. But age of my child is 5 years, it is between 1 to 6 years, then we can think about the ALD or about the ACTH resistance case. But in case of ALD, there should be patient having spasticity, there may be white matter degeneration, there will be spasticity, and as it is a X-linked recessive disorder, there may be involvement of other maternal uncles or any boys may be affected in the family. But here, and there will be a severe hyperkalemia, which is absent in this case. So we are left with the one diagnosis, that is the ACTH resistance case. And among the ACTH resistance case, there are 2 types, triple A syndrome and FGT. Now, in case of triple A syndrome, 3A stands for alachremia, achalasia cardia, and adrenal insufficiency. Triple A syndrome generally patient presents with feeding difficulty. After admission, then you can get the dry eyes. But here it is absent. So we are left with the one diagnosis, that is the FGD, either 1 or 2. But my provisional diagnosis is FGD type 1, because in a FGD type 1, there is defect of the MC2 receptor. If MC2 receptor is defective, then ACTH level will be high. This ACTH will act on the chondrocyte, and low cortisol act on the IGF-BP5. So it can cause tall stature. But in case of FGD2, MRFE is defective. So patient may present in neonatal period, and so growth will not be an issue. But it is not universal. FGD one can present with tall stature. Genetics will tell all this, but due to financial constraint and familial issue, patient got DRB. Now patient is asked to come in the later visit.
8 minutes over.
Okay. So from the clinical scenario, history and clinical presentation, my provisional diagnosis is FGD type 1. Thank you, sir.
So how are you going to treat the child?
Sir, if the patient is present, then I will treat with Hyson tablet, hydrocortisone.
Would you be giving fludrocortisone here?
Sir, I will give hydrocortisone only.
So I think this is a very interesting thing, and lot of thing to remember that you mentioned that they may be less likely like DAX1 and star defect. We are seeing those patients in the non-classical form, they may present later on. So genetics, of course, cost consideration is there. So most important is to treat. But once it's available, we should get it done because we may find something unique from there. Dr. Anamika, your inputs.
So, thank you, presenter, for your insightful presentation. And it's really interesting case. And I also appreciate your methodical approach, how you explain why it's not central, why it's not peripheral cause. So I want to know one thing. Can you say after giving hydrocortisone, is there any change in pigmentation?
Yes, but patient got DRB, we cannot treat the patient.
Okay.
So if the patient comes, then.
But we do expect a dramatic
Okay.
response in that. And in fact, we say that even if you don't do ACTH, you look at the child, you will say he's now better, his color is lighter, and then it becomes darker, he is pigmented. So I think that's the way it goes on that.
But sir, in case of central insufficiency, we can look.
In central, of course, there will be no pigmentation. So central is a different ball game altogether. Thank you, Dr. Rajib. I'll request Dr. Vibha to kindly hand over a memento to Dr. Rajib.
Next, I will call Dr. Balaji Chinnaswamy, Professor Pediatrics, SRM Hospital, Chennai, to present his case.
So Dr. Balaji is very active. He is doing, in fact, a PhD in pediatric endocrinology on mini puberty in boys. So he has been really interested in pediatric endocrinology, and he always has got those fascinating cases. Over to you, Dr. Balaji.
Thank you, sir. So we have an interesting case of neonatal hypoglycemia. At the outset, I'd like to thank Dr. Ashok. He is our neonatologist who took care of the case and we gave the inputs. And also thanks to Dr. Anurag sir. So whatever in endocrinology I'm talking is all the teachings from Dr. Anurag sir. So we have a day 1 male baby born through LSCS with birth weight of 2.53 kg. The indication for LSCS was gestational hypertension. Maternal history was insignificant except for mother being hypertensive on labetalol. The baby was preterm delivery and immediately cried after birth. Apgar was good, 8/10, 9/10. Normal transition at birth and vitamin K was given. The chief complaint was persistent asymptomatic hypoglycemia since birth. Regards to examination, anthropometry was fine. The baby was not SGA or LGA, no RH incompatibility, no signs suggestive of panhypopituitarism. Genitalia were normal, no midline defects, no dysmorphism, no hyperpigmentation or no signs suggestive of Beckwith-Weidman, no amphlocele. Abdomen, just liver was 2 cm below the costal margin. So regarding the hypoglycemia management, initially the RBS was, blood sugar was low and dextrose bolus 10% was given, followed by maintenance fluids with 10D. Baby was also simultaneously initiated direct breastfeed and express breast milk. Serial CBG monitoring was persisting with the asymptomatic hypoglycemia, hence the GIR was increased to 12.5%. And since hypoglycemia was persisting, we sent the critical samples for ketones, pH, lactate GH, insulin, cortisol, C-peptide, and acyl carnitine and organic acids. And simultaneously for the sepsis workup, cultures were sterile, but still we continued antibiotics for 2 weeks. Investigations were, basic investigations were normal. There were no evidence of infection. Electrolytes, there was no evidence of hyperkalemia. And indirect bilirubin not needing phototherapy was there. Regarding the screening for inborn errors, the amino acid profile through TMS came out normal. The acyl carnitine profile for fatty acid oxidation was normal. And the screening test for galactosemia came normal. But before that, the critical sample values gave us the clue. So the
cortisol levels were normal, but the ketones was low, less than 0.5. Insulin levels were elevated, 52.56. So the critical sample results were suggestive of hyperinsulinemia. Management of hyperinsulinemia, as per the protocol, diazoxide was started to start with, but in spite on diazoxide, the hypoglycemic episodes were persisting. So we continued with, we added octreotide to that. In addition, for the diazoxide, thiazide was added. So octreotide was added from day 6 of life. And then the baby started tolerating. So IV fluids was tapered and breastfed, and diazoxide and octreotide was given. And meanwhile, we sent for whole exome sequencing. So the whole exome sequencing suggested ABCC8 mutation, heterozygous, which is one of the important cause for hyperinsulinism, affecting the potassium channel, potassium ATP channel. So in view of the genetic testing indicating a diazoxide resistant pattern, so we tapered and stopped the diazoxide and thiazide, and we increased the octreotide to 3 microgram per kilogram per dose TDS. And after 1 month of hospital stay, the baby was discharged on octreotide. So we gave the injections to the mother to take, and plan was to shift to the long-acting octreotide. But by 8th week, the baby was brought with history of yellowish discoloration of the sclera and high-colored urine. So the baby presented with neonatal cholestasis. But there were no pale-colored stools. Abdominal distension was not there. And baby was evaluated for neonatal cholestasis. The culture came normal, urine culture was normal, HbA1c was non-reactive, CMV PCR was negative. So ultrasound was not suggestive of any surgical cause for cholestasis, biliary atresia, choledochosis were negative. Relevant investigation, the direct bilirubin was high. SGOT was elevated compared to the SGPT, and ALK phos was elevated. So with regards to the management, the baby was admitted. Again, the blood sugar was on the borderline level. So IV fluids was given, and sugar was maintained, and fat soluble vitamins and other supportives like UDCA was added, ursodeoxycholic acid was added. So since SGOT was disproportionately elevated to SGPT, so it was suggestive of drug-induced liver injury. So the baby was taking octreotide. So could it be octreotide associated cholestasis? So we looked into the case reports. Octreotide is known to cause gallbladder stasis. But few reports are also there where SGOT and SGPT are elevated. So one part is octreotide. But when we looked into the history, the mother was also giving weekly some native medications. So could it be native medication induced, drug-induced liver injury? So we are not sure which one was, but high possibility that the native medication could have caused the liver injury. But still, since case reports were there with octreotide, so we stopped the octreotide. So we took gastroenterology opinion and what to add. So other evaluation for cholestasis was negative. So only supportive we added was cornstarch. Although it is recommended around 2 to 3 months, still we tried to support the baby with cornstarch with breast milk. We had to stop octreotide, and already diazoxide was not given. So plan was, if hypoglycemia persisted, to evaluate further, to do the dopa PET and sirolimus alternative therapy we can try. And if hypoglycemia is there, to give glucagon. So discussion, so ketotic versus non-ketotic hypoglycemia. So I think the ketotic hypoglycemia is more worse because ketones are also not there. So hyperinsulinemia is more dangerous than other forms of hypoglycemia. And when the sugar is less than 50 milligram per deciliter, any detectable insulin is abnormal. And persistence of hypoglycemia beyond 48 hours, which is the normal transition time, is mostly pathological, and we need to evaluate. And critical sample is the one which is important, and we have to send investigations for ketones, pH, sodium, potassium, lactate, and hormones like cortisol, insulin, growth hormone, C-peptide. And also for fatty acid oxidation disorders, the acyl carnitine profile and organic acid. Also for the urine for reducing substance is important. So when will we, usually we expect the ketones to be more than 2, lactate to be less than 2, insulin to be not detectable, and growth hormone to be more than 10 and cortisol more than 550. So any deviation, it suggests that abnormality. So hyperinsulinism should be suspected in any child with hypotomegaly when the increased requirement of GIR of more than 12 milligram per kilogram per minute is needed, and ketones are low and free fatty acids are low, and detectable insulin in the situation of hypoglycemia. And response to glucagon is also a clue for hyperinsulinism. So this is the main mechanisms.
8 minutes.
So this is the main mechanisms. So the potassium ATP channel is mostly not responding. So ABCC8 mutation and KCN11 mutation will usually not respond to diazoxide, whereas the glucokinase or GDH mutation or SCHAD pathway usually respond to diazoxide. And when you know that it is not responding to diazoxide, so we have to see whether it is focal or not. This hyperinsulinemia is focal or not. One clue is checking for the paternal mutation. So if paternal mutation is there, then it is focal and we can go for resection. So here in this child also paternal mutation has come positive. And the basic trial is start with diazoxide. If responding, well and good. Not responding, then go for the dopa PET to see whether it is focal or not, so that the resection we can plan accordingly. So the final practice points is think hypoglycemia in all sick neonates. Hypoglycemia beyond 48 hours is significant. Ketone is the most important investigation, and we should do immediate treatment for symptomatic cases. Response to diazoxide is the clue whether what type of hyperinsulinism we are dealing with. And also we should look into the side effect profile of the drugs octreotide. Thank you.
I think there was a very interesting case and there are a lot of issues to learn from there. One aspect is that ABCC8 is emerging as an important cause of hyperinsulinism, and while they may not respond, they may also respond. So diazoxide trial, I think, should be the first, as you showed in your algorithm. That is something, and octreotide is not that safe that we should just not start octreotide. Often we have seen many problems in that regards. Dr. Manisha?
It was a very interesting case, especially the side effect of octreotide, which has been shown in this case. And the clue, I think, was there. It was very high insulin requirement. It pointed towards the hyperinsulinism, and low ketone, we have only few causes. So the diagnosis, although it's what goes, the side effect profile was interesting.
I request Dr. Alappan to kindly hand over a memento to Dr. Balaji. And thanks, Dr. Balaji, for this wonderful presentation.
Well, I would like to invite Dr. Gayatri Priyadarshini, Assistant Professor, Department of Pediatrics, SRM Hospital, Chennai.
So we have Dr. Gayatri from the same institution as Dr. Balaji, and both of them have the same zeal for clinical practice. They have a lot of interesting cases. So this was a very, very interesting case. A lot of issues also there. So I think this deserves special attention, Dr. Gayatri.
Good afternoon to one and all here. Special thanks to Dr. Subhash sir for referring this child for and having hope on us, and he's our HOD pediatrics, and also a special mention about Dr. Anurag sir for mentoring us a lot. Thank you. And it's a case of precocious puberty. The child actually initially treated elsewhere, and we received the child from around 4.5 years. So this 6-year-old male child presented with increase in the pubic hair and mistake from 3 years of age. And he also had behavioral issue and disproportionate increase in the external genitalia and frequent penile erections, acne, change in voice since 3 years of age. So antenatal history was uneventful. Birth history was normal with a birth weight of 3.2 kg, and there was no birth history, birth asphyxia. Postnatal history, there was no stormy course of postnatal, and everything was uneventful. And even the past history was not much significant, with no emergencies landing up into an hospital. Developmental history was appropriate for the age. Family history, and there was no significant family history. The parents are a third degree non-consanguineous marriage, and parents were short, including the sibling. So past history, there was no, as I said, there was no stormy course, and he was not admitted for any of the emergencies. And he's diagnosed as a central precocious puberty and was started on Luprolide, which was like Luprolide 3.75 mics for the first 4 months, and then followed by increasing the dose around 7.25 for the next 1 year. And from our follow-up, we are on to like 11.25 microgram for the past 1.5 years. So small detail about the parents' anthropometry. As I mentioned, they were also short and below the -3 SD, and mother was really short, which was 144 centimeter, and father is okayish kind of thing, and which was 155 centimeter. There was a history of maternal relation who were also short here. Okay. Child anthropometry, when he came here, he was always in the +2 standard deviation, and height was, weight was +2 standard deviation, and height was 122 centimeter, which was +1 standard deviation. And upper segment and lower segment was proportionate. So on examination, head-to-toe examination, on the face, he had a hair and mustache with a prominent forehead, and limbs was having a short 4th and 5th metatarsal bones, and short stubby fingers in the hands. Genitalia, he had a pubic hair, and the tanner was like P3. Pubic hair was stage 3, and stretch penile length was 8.5 centimeter. Testicular volume bilaterally was 8 cc. There was no neurocutaneous marker here to rule out peripheral cause. And this is a child showing he has the short fingers, and then 4th metatarsal is very short. Okay, so from the time we have seen this child, we have been following with the height, velocity, and bone age, and keeping it as a central precocious puberty. And initially, he had a enormous growth, and it was very difficult for us to suppress his precocious puberty also. Every time the blood pressure was normal. So height, velocity, height when he presented to us was 109 centimeter, and within 1 year he could reach up to 12 centimeter. And further then, like since the last few years, he's almost gaining height velocity of 1.5 centimeter for the 6 months. So last from January till this May, we had around 1.5 centimeter for the past 6 months. And the tanner, when he presented, it was around 4 to 5 ml of testicular volume, and he was always in the P3, and stretch penile length was 8 to 8.5. And now, latest thing is he is progressively growing with a testicular volume of 8 cc, and stretch penile length was 9 centimeter. So this was his growth chart and the bone age. And this was the initial investigation that was earlier done. So at the time of diagnosis of the precocious puberty, his testosterone was very high, which was 799. And LH was, baseline was 9.85, and on stimulation, it was 20.65. And ruling out the other causes before you make it as a idiopathic central precocious puberty, it is important to make out, are we not dealing with the peripheral cause? So definitely LH above 0.3 is definitely ruled out. So here we have having a huge enormous LH, and still the clinician had made an attempt to rule out other things, like 17-OHP was 2.2, and cortisol was normal, and beta HCG, because we couldn't suppress the thing. So we thought about this, and 0.55, which was low, and thiosulfate is also normal. And IGF, which was done at the earlier point, it is 321, which is good. So a general approach to a precocious puberty with the LH, if it is more than 0.2, LH is more than 0.2, generally we take it as a central precocious puberty, and ideally we have to do the MRI head. Because boys will always have an organic pathology lot, so always do MRI head. In our case, we did a MRI head, which was also normal here. Okay, and then if it is between 0.1 to 0.2, GnRH stimulation test has to be done. If it is less than 0.1, again it is considered to be a peripheral cause. So if on GnRH stimulation test, when it is more than 5 milliunit per liter, it is again considered to be a central cause. So, and if it is less than 5 milliunits per liter, it is considered to be a adrenal mass. It is considered to be a peripheral cause. And most important thing that we have to remember is the adrenal mass for in case of adrenal cause for a peripheral precocious puberty. So always rule out the adrenal cause with CT adrenal. And if there is if we are not dealing with CAH, so 17 OHP levels and the adrenal imaging has to be done. In our case, it is again pretty normal. 17 OHP was normal, and if it is normal, again we consider for the HCG, and HCG was again normal here. If it is elevated, we think about the HCG secreting tumors, and if it is normal, again we are thinking about the LHCG receptor defect, which is completely not happening in our case. We ended up having a idiopathic central precocious puberty. So as this child had syndromic features like brachydactyly, prominent forehead, and MRI also came out to be normal, we wanted to do a clinical exam sequencing. And I'll just go back. Yeah. So this was the kind of investigation, and the luprolide was given. We even ended up having a 12 weekly injection has turned out to be a 8 weekly injection, and we are continuing with the same session, but the LH suppression is not happening. In spite of that, testicular volume is also
2 minutes
growing.
left.
So we wanted to have, is there any genetic background on that? So we found that this child had a ACAN mutation. So ACAN mutation, regarding ACAN mutation, it is a genetic defect in the aggregan. Okay, so aggregan is a jelly-like substance. It codes for a jelly-like substance where the bone stability could be maintained. So if a child, this aggregan has got 25 pathological mutation, and they present with these kind of dysmorphic features like facial hypoplasia, macrocephaly, and flat nasal bridge, frontal bruising, and brachydactyly. And the most important thing is all of their familiar short stature will be there along with the advanced bone age. So we got something like, these are the 25 mutation that was all present. And in our case, we had a lesion in the exon 11. ACAN mutation. So we was thinking like, is this an idiopathic precocious puberty, central precocious puberty with ACAN mutation, which was aggregated because of the already bone age was delayed with predisposing ACAN mutation, or is the ACAN mutation per se presenting as a precocious puberty? Because most of the literature were not telling anything about that, but there was one study which stated that this there may be coincidental precocious puberty with the short stature, where in the study they have mentioned that parents had short stature and the father was having a ACAN mutation as well. So we thought like we will do a parental genetic as well, and probably this child will require a growth hormone therapy along with GnRH analog. And thank you.
So I think that's a very, very interesting case. I think the key thing was that the initial testo was very high. Like that level of testo is very, very rarely seen in central precocious puberty alone. And usually the bone age advancement is also not that much, that at 3 years you have 12 years. So there is something else going on, and we know ACAN is basically increasing the bone age. So maybe what is happening here is that there is a child with ACAN mutation and precocious puberty is superimposed on that. And that is why the thing is progressing. But very, very interesting. Your inputs, chairpersons, please.
Thank you, Dr. Gayatri. It's really interesting case. So a 6-year-old male boy with central precocious puberty who have MRI also normal. So it's a interesting thing that after diagnosis of central precocious puberty, we should track the syndromic features and go through it to find out more things are there Okay,
But the
thank
good
you.
part was your bone age did not advance that much. You said from 12 to 13 only. So that is at least controlled.
Yes.
But he would need GH if you want to salvage the height. That is very sure. I'll request Dr. Sandeep to kindly hand over memento to Dr. Gayatri. So there is a slight change in the schedule. Actually, Dr. Shweta will be presenting the case instead of Dr. Pradeep. So Dr. Shweta is in Patna and she has been actively involved with our program as well. So Dr. Shweta is there? Yeah, please. So she is currently working as an assistant professor in Netaji Subhash Medical College. She was with AIIMS Patna and where she found this interesting case.
A very good afternoon to all of you. I would be presenting a case of hypogonadotropic hypogonadism. First, I would like to thank Dr. Pradeep sir at AIIMS Patna, under whom I managed this case, and Dr. Anurag sir, from whom I learned the basic nuances of the subject. So coming to my case, a 14-year-old boy presented to AIIMS Patna OPD with chief complaints of small phallic size since birth, and the testicular size was also small, and there was no history of anosmia. On examination, the weight of the child was more than 90th centile. The height was 175 centimeter, which was more than 90th centile. SPL was 4 centimeter. SMR, bilateral testicular volume was 2 ml, and pubic hair was P2. Testis was soft in consistency, and there was no cleft lip or palate, no renal agenesis, and no syndactyly. So coming to the investigation, we screened the child for systemic diseases like CBC, KFT, LFT, anti-TTG. Then infections were ruled out for tuberculosis. So all were normal. Then in initial workup, karyotype was done to rule out Klinefelter syndrome, which came to be normal. So, and bone age was 14 to 15 years. Serum testosterone level was 18.46, which was less than 20 nanogram per deciliter. FSH was 0.58. LH was less than 0.2, which was 0.19 microunit per L. Serum prolactin was 4.76 nanogram per liter. To rule out any kind of neurological insult, MRI brain was done, which showed a normal study. So for confirmation of the diagnosis, patient was started on injection testosterone once monthly. Total 3 doses were given. After 3 doses of testosterone, the child was evaluated again. SPL was increased to 6 centimeter and pubic hair came to P4. However, bilateral testicular volume remained same. It was 2 ml. GnRH, to further rule out, GnRH stimulation test was planned along with inhibin levels. GnRH stimulation test did not increase the LH level, which came to less than 5 mu per liter, which was 0.7, and inhibin was less than 35 picogram per ml, which was, in our case, 18 picogram per ml. So actually, these tests were done to rule out between CDGP and permanent hypogonadism. So coming to the management of case, testosterone was started initially in the form of injection testosterone IM. 50 mg was given monthly, which was gradually increased to adult dose of 250 mg 3 weekly. So this was associated with increase in penile length and pubic hair, but not in testicular volume, which remained at 2 ml, which indicated irreversibility. So genetic test was to rule out, since we had ruled out all other causes, we wanted to go for genetic testing, and the whole exome sequencing was done, and patient was further counseled about fertility induction. Genetic report showed likely pathogenic variant of hypogonadotropic hypogonadism with defect in FGFR1 gene. So this is the whole exome sequencing report of our patient, which showed a deletion in FGFR1 gene, which was located at exon 9, and it was likely pathogenic, and the inheritance was autosomal dominant. So our disease was hypogonadotropic hypogonadism with or without anosmia. However, our patient did not have any anosmia. So segregation analysis, we did not do any segregation analysis further because there was no history in the family. So we thought that it must have been a de novo mutation. So this was the variant interpretation, heterozygous 4 base pair deletion in exon 9 of the FGFR1 gene was found, which resulted in a frame shift and premature truncation of the protein downstream to codon 367 was detected. So coming to the discussion, this is a child approach to a child with delayed puberty. First, any child who would present to us with delayed puberty, that is testicular size not increased by 14 years of age, we will first rule out any systemic cause or any infection. So CBC, LFT, KFT, anti-DTG, then thyroid profile, electrolyte should be done. Then we should see the gonadotropin level. If the gonadotropin levels are high, then testosterone should be evaluated. So this is the hypergonadotropic hypogonadism arm. So if the testosterone is high, we should check for dihydrotestosterone. If it is high, then it goes in the favor of AIS. If it is low, then 5-alpha reductase deficiency type 2. However, if the testosterone is low, we should go for karyotype, and which should see other metabolites to rule out any steroidogenic defect. If this gonadotropin initially are low, we should go for prolactin and see any pointers to hypogonadotropic hypogonadism like micropenis, undescendant testis, anosmia, synkinesia, and any CNS features. In our patient, there was micropenis present. If the pointers and prolactin level is high, we should rule out GnRH deficiency, and MRI head should be done to see any CNS insult. However, if these pointers are not present and prolactin is low, we should see the morning testosterone. If the morning testosterone is more than 20, then it goes in the favor of constitutional delay in growth and puberty. However, if it is less than 20, then we should see the LH level. If it is less than 0.3, then GnRH stimulation should be done. In our patient, it was less than 0.2, and we went for GnRH stimulation. However, after GnRH stimulation, if the level is less than 5, then it is GnRH deficiency, and if it is more than 5, it goes in the favor of CDGP. Same happened in our case. After GnRH stimulation, it was less than 5, and inhibin B level also we had done, it was less 35, so it ruled out any CDGP or SLDP. So the differential diagnosis of our case, it could have been CDGP or SLDP. Systemic illnesses like any kidney disease, any liver disease, celiac disease, tuberculosis, we have to rule out these diseases. Pituitary defect, it could be acquired or it could be genetic. There can be multiple genetic defects in the form of HESX1, which present as septo-optic dysplasia, PROP1, in which the pituitary size increases, and there are other multiple pituitary hormone defects, POW1F1, in which the pituitary size is small, LHX3, in which there is stiff spine. Hyperprolactinemia should be ruled out because prolactin level inhibits the GnRH neurons. Then other genetic GnRH defect in the form of Kalman syndrome, FGFR1, KIS1 receptor defect, GnRH receptor defect, DAX1, TAC3 and TAC3 are receptor defects, should be ruled out.
8
in our
minutes over,
case,
8 minutes over.
Okay. So in our case, it was FGFR1 defect. Acquired GnRH defect in the form of any mass lesion, infiltration, or radiation should be ruled out. So coming to the genetic causes of hypogonadotropic hypogonadism, if there's Kalman syndrome, then it can present with anosmia, synkinesia, hearing loss, and X-linked Cal1 gene can be affected. FGFR1 defect can present as skeletal dysplasia, synkinesia. However, our patient did not present with any of these features. He only had micropenis and there was no anosmia. KIS1 and KIS1 receptor defect can present as an isolated GnRH deficiency defect. GnRH receptor defect can present with variable presentation. DAX1 defect can present with adrenal hypoplasia congenita. Coming to some case reports regarding novel FGFR1 mutation, Gamez et al. Reported a case in which 3 novel mutations were identified, and however, they presented with normosomic hypogonadotropic hypogonadism without any non-reproductive phenotype. Our case also was anosmic type. Non-anosmic type. Then another case report from Shinta et al. Presented with different novel FGFR and GNRHR. There were 2 mutation involved. Along with FGFR1, there was also GNRHR receptor defect. Then there was a case series presented by Min9 in which there were 29 FGFR1 mutations were found, and 18 patients were given fertility promoting therapy, and it worked very well with them. So coming to the summary, ruling out SLDP and systemic illness is first step in patient regarding with presenting with delayed puberty. Detailed history, especially anosmia, synkinesia, and facial defects are important. Testicular volume and texture are important for making differential diagnosis of delayed puberty in boys. Inhibin B, GnRH stimulation test, and response to testosterone are important for differentiating between SLDP and hypogonadotropic hypogonadism, and genetic test plays important role in treatment, prognosis, and future fertility option.
So I think very interesting case, and that brings out with a very important issue whether genetics can be or should be done in everybody with hypo. That's a debatable topic, but if affording, we can get it done because this will give you a guidance, and FGF is a very important scenario in that regard. I'll request Dr. Nimisha to kindly hand over a memento to Dr. Sweta. And also a round of applause to Dr. Pradeep, who was a mentor for this case. Inputs from the chairpersons, please.
I think it was very interesting case. I think this child had initially presented with P2. So I think in this, if any of the pubic hair is present, CDGP is already ruled out. So
I think that was a very important point brought up there. I'd like to thank the chairpersons for this session. Dr. Manisha Maurya, who is a professor at ML in Allahabad. I'll request Dr. Vibha to kindly hand over memento to Dr. Manisha. And Dr. Anamika Saha, who is the working as a pediatrician at Dhaka in Bangladesh. So Dr. Vibha, kindly hand over the mementos to both of them. So we have covered a case conundrum session, and before we hand to the other session, the lunch will be more like a working lunch. So miss out and in between, you can get your meals and continue because we want to continue with the session. And I'll over to Dr. Nimisha for the further conduct of the session.
I would now like to invite Dr. Arpita Braghuvanshi, Additional Professor, Pediatrics, KGMU, Lucknow, and Dr. Hari Mangtani, Pediatric Endocrinologist, Nagpur, to the dais. Welcome, ma'am, and welcome, sir. We'll start with our next session, State of Art. I would like to invite Dr. Vijay Jaiswal. Yeah, I would like to invite Dr. Vijay Jaiswal, sir. Please come on the stage.
So Dr. Vijay Jaiswal is one of the oldest persons associated with Grow Society and Medi classes. And right, we had the first program in 2011. Since then, Dr. Vijay Jaiswal has been coming, and every time he has made it a point to come. All the advanced pediatric endocrine course, practical courses everywhere, he has been involved. Dr. Vijay Jaiswal is a well-known pediatric endocrinologist, and he is practicing in Meerut and in Noida as well. He is currently the HOD of Medical College at Saharanpur. And he has been working a lot. He's part of our executive committee of the Indian Society of Pediatric Endocrinology. We got a lot of executive council members who are here. So, he has been the torch bearer, I would say, in that region. So we will be starting off with his session on a very, very important topic of thyrotoxicosis, which is a common problem, which often has a lot of challenges in terms of diagnosis and management. So, Dr. Vijay, we can, stage is all yours.
Thank you, sir. I request all of you to just clap for Anurag sir and the team for a wonderful thing. Just to start that, we started under Anurag sir years back, and now this is a journey. And we are really interested to see so many faces. और ये जो कैंडल जलाया एंडोक्रिनोलॉजी का, because initially pediatric endocrinology was like decoding, वो जादू है, क्या होगा नहीं होगा. Now you are at least quite confirmed that how we can approach and these children can be treated. So not wasting any time, we are very well versed for treatment of hypothyroidism. But yes, if this hormone is beyond the normal, then what we are going to do? So I am at all the presentation and interesting cases. The base is the European Thyroid Association. So we are going to deal with. So this picture, I have taken the permission to the parents for displaying this. So to start with the case, that 12-year-old girl presented with tremor. So high FT4, you can see, very low TSS, no thyroid swelling, no eye signs, tremor is there, and with high FT4. So what can be the diagnosis? Since I have already told that I am going to talk about thyrotoxicosis, so how we are going to approach if thyroid hormone is on the higher level with low TSH, no swellings, no eye signs, then probably before treatment, if facilities available, then go for scanning. At the scan, you can see that uniform increased uptake is there. So it is proving that this is a Graves' disease. So this is the thyrotoxicosis, which can present with so many things, that is weight loss, hyperdefecation, tremor, eye signs, periodic paralysis, polyuria can be there. So coming to again, so this treatment, methimazole, 12-year girl, PTU, radioactive iodine. So we will discuss in the next slide that we don't have any option for PTU. Problem is there. Okay. Yes. So we have to see what is the response to methimazole therapy. And this is a very good drug. Most of the patients are going to respond. But what are the subset of patient where you can think that probably this patient might not going to respond? That is large thyroid swelling, male patient, FT4 beyond 50 millimole per liter, and with high TRAB, that is TSH receptor antibody. So these are the patients where we have to think beyond medical management. And this, what I was talking about, that European Thyroid Association guideline, that patient with Graves' disease required prompt treatment. So this is one, that these patients to be treated, either methimazole or carbimazole. ATT drug, the dose is between 0.15 to 0.5 milligram per kg. And since it is a good half-life, it can be introduced once daily. So there are two methods, that is, one is dose titration approach and second is that block and replacement therapy. So block and replacement therapy usually seems easy because you are going to give the super high dose of this methimazole or carbimazole and you are making the patient hypothyroid and it will be easy to manage with L-troxin supplements. So, but at a cost of you are going to increase, you are giving high dose of this methimazole and maybe more side effects. So the best what you are, the society is saying that dose titration method to be practiced for management of thyrotoxicosis. So we can't say that we can't practice block and replacement. This is the individual approach, but if you think that your patient is going to compliant, then probably we have to practice dose titration approach. So these patients are going to have so many sympathetic symptoms. If that is there, that is tachycardia is there, hypertension is there, then for a short time beta blocker to be used. So patient with untreated grave disease can be severely unwell with marked signs of thyroid hormone excess and managed with high dependency or intensive care unit. So this is, you have to assess your patient that how it is doing. Yes. So if you have started the treatment, then what are the things? Because no drug is going to be without any side effect. So what is going to do that you have to track for this, because this is known to have this agranulocytosis. And so if the level is there, you have to see. But one more thing, that you don't have to routinely mark these things. Yes. So what is planned for this? So now patient is having sore throat. So this can be a presentation if the patient is on methimazole therapy, is having sore throat, or say skin rashes, or say jaundice. So these are the three things what you have to watch during methimazole therapy. And since this patient was having sore throat, so the first thing is that you have to stop the treatment. One. Second, you have to see what is the status of complete blood count, that is CBC, and what is the absolute neutrophil count. So that is divided in three parts, that is less than 1500 to 2000 and beyond that. So if there is problem, but okay, no problem. So if there is a sore throat, but counts are beyond, say, 3000 or 4000, we can restart the treatment with a normal sore throat, and we can have antibiotic and other things. But this is really important to understand that these are the things what we have to monitor. So when to suspect and what is the criteria? Usually what these side effects has been seen is in the initial 3-month period. So initially we have to do a very frequent follow-up. So what is frequent follow-up? That initially monthly for at least 3 months, then accordingly 2-month or 3-monthly interval we can see. Okay. Yes. So treatment regime may not require adjustment. So if we have started the treatment, what we are going to do, that we have to chase what are the things. That first, the thing which is going to normalize, that FT4 and FT3 can be relatively high, TSS normal. So dose estimate may not be there. So education about Graves' disease and especially its treatment is essential to optimize compliance with attention to developmental age. Yes, so we have discussed these things. Beta blockade, we have already discussed. Patient with untreated, yes. Yes, we have already discussed all the things. Yes, that was the sore throat. Beyond 1500 per, so continue the treatment we have already done. So we have discussed all the things and restarted the treatment. We have discussed that first 3 months are important to see mostly the side effects. Yes, so follow up FT4, 12 picomole, TSS still less than 0.01. What is the plan? So we should know the timeline that when to do the dose adjustment. So if TSS T4 both TSS is high and T4 is low, we have to reduce the drug by 75% at the first visit and later by 25 to 50%. If TSS has been normalized, that is normal, and FT4, then also we have to reduce the dose first at first visit by 75%. Because if we are not going to reduce the dose, probably we are going to make this patient hypothyroid. The third situation can be that TSS is normal, FT4 is normal, then reduce dose by 50%, and in the subsequent visit, you don't have to reduce. If TSS is low, FT4 is normal, then reduce by 25 to 50%. If TSS is low and again FT4 is high, it means that whatever dose you are giving is not right. So probably you have to escalate the dose by 25%. And in the later visit, if the same scenario is there, then probably you have to increase by 25 to 50%. So in this case, we have reduced the dose to 20 milligram. Repeat after 2 months and what we have to do. So we have already discussed that how to start the treatment. Dose titration method is probably better if you can practice, if your patient is going to comply. So be guided by thyroid hormone concentration as well as TSS concentration beyond 4 to 6 months. If TSS concentration remain persistently suppressed in the presence of a normal FT4, this may reflect elevated FT3. Consider increasing the dose of anti-thyroid drug a little bit. So arrange TSS above local laboratory normal range despite minimal daily of ATD together doses. This is a good news. You have to see that TSS receptor antibody. If it is on declining or normalizing trend, probably the patient has already gone in remission or it is time to stop the drug at least. Yes, so the third case, that is 15-year-old girl presented with thyrotoxicosis with high FT4, low TSH, large goiter, and now eye signs. Yes, so how to go? So we have seen the risk factor that large goiter, male FT4 beyond 50, and TRAB high. So these, if any question, response to methimazole, no. So age is obviously, it is beyond 5, that is 15 years, and good size of swelling. So probably we have to think for alternative, that is permanent cure, that is surgery. But before surgery, what you have to do, that you have to normalize the level. So the overall remission rate after ATD treatment is pediatric disease is between 20 and 30% after 2 years and may increase with continuous antithyroid duration. Normally administered for at least 3 years and only stopped when TSH receptor antibody level have been low for several months. Longer course, that is beyond 5 years, should be considered if likelihood of remission is low on the basis of disease characteristic at presentation, what we have already discussed. Yes. So definitive treatment we have discussed, the 3 criteria were there. So overall remission after ATD in pediatric disease, Graves' disease is 20 to 30%. So we have discussed this. So what is the objective? Once you are going to deal that when to start this radioactive iodine and what is going to do? Yes. So the treatment is complete thyroid ablation. This is to prevent relapse and future development of thyroid cancer. So radioactive iodine to be avoided in patient younger than 5 years and only used 5 to 10 years when surgery is not a realistic option. Contraindication, that is orbitopathy, they say that you should avoid that. So definitive treatment, thyroidectomy we have discussed. So orbitopathy I'm not going to discuss. So this is interesting case, that is 17-year-old girl with neck pain, high T4 and low TSS. Neck pain is there, so you have to see no goiter, no eye signs. Yes. ESR is raised. So you have to see that this is not always that is autoimmune disorder. Then can be some inflammatory cases. So this patient was not treated with the long term of methimazole therapy, but probably they responded very well to antibiotic therapy and local measures. So this came to be subacute thyroiditis. So all high level of thyroid hormones doesn't need methimazole therapy. That was the reason. Yes, the last case, and this is very really important, that day 4 infant of Graves' mother was on this methimazole therapy, and this was the level. So why this patient was hypothyroid? So, and if this is hypothyroid, this is what the scenario, then how to approach this case? Yes, so you can see that there are two things. One is TSS receptor antibodies, which has been formed in the mother's womb and which is going to cross the placenta. It is going to affect the baby. One. Second, that is the effect of your drug. So this probably after weaning. So we have observed this baby and let us see after 14 days what is going to happen. So day 14, you can see here that FT4 is rising and your TSS is going to be low. So what happened? That is waning off of the methimazole drug effect. And now we can see here that this baby was managed with methimazole and beta blocker therapy. So what is the take home? That hyperthyroidism caused by Graves' disease is a relatively rare disease in children. Though treatment options are the same as in adult, that is ATD, radioactive iodine and thyroid surgery, no role of PTU. The benefit and risk of each modality are different in the young. So we should take a call, that is behavioral changes or subtle declining academic performance can be a subtle presentation. So management depend on the presentation and the follow-up. Thank you so much.
Thanks a lot, Dr. Vijay, for such a wonderful summary. Any expert comments? And meanwhile, I'll request Dr. Alappan to give a moment of appreciation. Dr. Hari?
Congratulations, Dr. Jaiswal, for the wonderful presentation. And I mean, you presented all the 5 cases. You covered all the possible this thing. But I don't know, after so many years of practice, it's not this watertight always. There's always some fluctuations, and few questions are really important. One is in front of a thyrotoxic mother, how long this child will, although the antibody levels, it is said that they are going to decrease. But I have come across a patient who was initially a child of of a thyrotoxic mother. Now, still the child is receiving the
How old?
thyroid suppression. Now,
How old now?
Now 1.5 year old.
So this should be a TSH receptor mutation then, because the antibody cause will go off maximum by 6 months. So this is a genetic, this is a well-known entity. If it is persisting beyond 6 months, you should look for the TSH receptor mutation.
So it has been persisting. I am working on it, but there's some same affording things.
So, and they would need a definitive treatment, because that they will, this is going to persist for life then.
Persist for life, yes. And another, that block replace, you said. So whether we can start with a big dose and not replace, but to come down in doses, what you said, that you reduce the dose by 75?
Yes.
Rather than, I mean, building up the dose.
That is fine. But we have to see that what is RM, and we have to quantify the patient. That whether your patient is coming to you for a regular follow-up, they are ready to do a frequent checkup, then only we can escalate or de-escalate the dose. But the problem is that may not be patient is coming, Dr. Sahab आराम आ गया था तो अभी फिर, if you are thinking that slot of patient, it is always better to give a high dose of methimazole therapy and we have to make hypothyroid and block and replacement therapy. For that case, may be better, but standard of care is again dose titration method.
Most people will now not give block replacement because it has got you're giving exposing to high dose of antithyroid drugs, then you're not getting any benefit in terms of remission. So most all of us, I think everybody is using a dose titration rather than block replacement. So Dr. Alapan, please hand over a memento of appreciation to Dr. Jaiswal.
Next, I would like to call upon Dr. Vibha Yadav, who would be speaking about gender dysphoria.
So we have had a lot of interesting talks by our fellows, ex-fellows, Dr. Chetan, Dr. Sajali is already there, and then we had with Dr. Manoj. Now Dr. Vibha is another of our fellows who has now joined as a consultant in our team. So she's going to talk about a very difficult topic of gender dysphoria, which is now becoming common. So how do we really manage these cases? So Dr. Vibha, your practical advice.
Thank you, sir. As sir has mentioned, gender dysphoria now has become common, and we all should, as a endocrinologist, be aware of what are the facts and how should we approach, what are the legal documents required during the management, and what is the role of psychiatrists and other faculties. So starting with the this was the first case that I have seen during my fellowship period. So she was a 22-year-old female who visited with the complaints of she was very discomfort with the body since childhood, and she identifies gender identity definitely not as female. She expresses consistent feelings aligned with the more masculine identity, and these stress was so much it causes a psychological distress because she has a development of breast, she has menstruation, and the voice that she perceived is more of a feminine voice, and she was being misgendered as female by others, which she did not like. So exactly, this was my condition. What to do? What documents are required? How to start investigation, and how to take the help of psychology? What to ask the psychologist? What we want in written, and many other issues. So starting with whether is it gender dysphoria or not. So evaluation and diagnosis is most important before starting the treatment, and it is done by basically a trained mental health practitioner, not us. We don't diagnose it. He should be competent in using the DSM criteria or the ICD criteria for diagnostic purposes, and able to diagnose the gender dysphoria and able to distinguish it from other similar psychiatric conditions like homosexual and etc. So what is DSM-5 criteria? It says if there is a continuous distress feeling or the patient is uncomfortable with the present body for more than 6 months, and at least 6 of the following in which there one must be present, that is a strong desire or insistence to be of the other gender, presence of cross-dressing. This is basically for the children, and we have a different DSM criteria for the adults in preference for cross-dressing boys or masculine attire by girls, preference for cross-gender roles to in pretend play like kitchen house set by preferred by the boys and doll by the cricket by the girls, preference for toys, games, activities of the other gender, preference for playmates of the other gender, rejection of gender typical toys and activities, dislike of one's sexual anatomy, desire for sexual characteristics of the experienced gender, plus significant distress or functional impairment due to all these feelings. Now coming to the DSM criteria for the adolescent, it has to be for more than, the feeling should be more than or equal to 6 months, and at least two of the following features should be present. That is incongruence between the experienced gender and the sex characteristics, desire to get rid of the sex characteristics that the individual is having, desire for sex characteristics of the other gender, desire to be of the other gender, and to be treated as of the other gender. There's conviction of having typical feelings of the other gender, plus they all causes significant distress or functional impairment that they are not able to work in their workplace. So this is the questionnaire that we ask the psychiatrist to fill it for according to the patients. There is different for the female assigned at birth and male assigned at birth, and on the based of these questions they provide a score, and if the score is less than 3, then the individual is diagnosed to have a gender dysphoria. Now coming to our patient, does she fulfill the criteria for the treatment, or just she is confused like whether she should go for treatment or not? So criteria for gender affirming hormone therapy, which is a temporary one. In this also, the qualified mental health practitioner has to confirm that it is a long lasting and intense pattern of gender dysphoria, not the temporary one. And it has worsened with the onset of puberty, and there is no coexisting medical social problem that could interfere with the treatment. Only after the confirmation by the psychiatrist we will start the treatment, and the patient has a sufficient mental capacity to give informed consent to the treatment. And coming to the patient side, he or she should be informed of the effects and side effects of the treatment, that is loss of fertility or the other options to preserve the fertility, and he should be able to give the informed consent. Now, what is our role? We should agree with the indication that definitely there is an indication of GnRH agonist treatment, and it is started only after the confirmation of puberty that it has reached tenor stage more than B2 or G2, not before it. And there are no medical contraindication to the GnRH agonist treatment. Now, how should we approach? The first and foremost thing is the counseling. What the patient is dealing with, what is gender dysphoria, whether it has started recently or it is present since birth, what are the consequences and what will be the consequences after therapy, what is the permanent and what are the temporary changes that he or she will have during the treatment. So it has to be treated up, begin with the pubertal suppression after girls and boys exhibit physical changes, as I've mentioned, that tenor stage of G2 or B2, and GnRH analogs are used to suppress. And we generally use in this patient, we started with the leuprolide with the dose of 11.25 12 weekly. And coming to the monitoring, what we have to monitor during the treatment. Basically, when we give GnRH and agonist, it is a temporary suppression of the pubertal hormone. During the treatment, the patient still have the chance to think whether they want the gender change or not. It provides more time to explore their gender identity without experiencing ongoing incorrect pubertal development. And during the suppression of puberty, we examine anthropometry 3 to 6 monthly laboratory parameters of hormonal like LH, FSH, estrogen, and bone density using the DEXA. Now, what changes should we expect after the GnRH agonist? We have given GnRH agonist like for 3-4 5-6 doses, and we counseled her that during the treatment, after the treatment, her breast tissue will become atrophic and menses will stop. And in the boys, virilization will stop and the testicular volume will decrease. But what in the cases of boys, their voice remains the same. It does not change the harshness or broad jaw or thick eyebrows of the boys. So they have to be counseled regarding the treatment. Now comes to the permanent treatment, that is the sex hormone treatment. Again, there is a eligibility criteria for starting the sex hormone treatment, and there has to be the persistent gender dysphoria, and the patient should be able to estimate the consequences of partly irreversible treatment, what she had experienced during the generous agonist therapy, and he or she should be informed of the irreversible effect and the side effects of the sex hormone, because once that treatment is started, they are not going to reverse it. And the endocrinologist has to agree with the indication for the sex hormone treatment, and there are no medical contraindications. Now, how should we start? It is same as we start the pivotal induction, but before starting, all the medical risks associated with the sex hormone therapy should be informed to the patient, that is with the estrogen thromboembolic diseases, macroprolactinemia, in the boys with the testosterone erythrocytosis. So all these side effects should be well informed to the patient. In cases of transgender male is she is female assigned at birth but wants to be male. So that is transgender male. We start injectable testosterone. In the post-pubertal adolescent, we start with a 75 milligram 2 weekly for 6 months. Then we increase to 125 milligram for 2 weekly. And adult dose is the same, 100 to 200 milligram IM 2 weekly. For the induction of male puberty, it is same as we done the pubertal induction in other cases. And when the adult dose is reached, we switch to 1000 milligram of 12 weekly testosterone. And then the generous analog can be discontinued once the adult dose of testosterone has reached and individual is well virilized. If in case during the treatment, the uterine bleeding continues even with the testosterone, then medroxyprogesterone of 10 to 20 milligram ODO-BD can be added. In case of transgender female, means he was male at the birth but wants to consider himself as a female and wants to change the gender. Here we start the pubertal induction, same with a 10% dose of the adult dose, and we increase 6 monthly till in 2 years. And in the post-pubertal time, we give 1 milligram per day for 6 months, then 2 milligram per day, and as the adult dose is 2 to 6 milligram per day. The monitoring during the induction of puberty is important. We measure the anthropometry 3 to 6 monthly, and in the transgender males, hemoglobin, hematocrit, lipids, testosterone, other hormones are monitored, and in transgender females, prolactin, estradiol, 25 vitamin D is monitored, and bone density is measured in both the cases. And GnRH analogs are continued till gonadectomy in trans females also, and anti-androgen can also be used in place of GnRH agonist. Coming to the physical changes that we counsel and we expect after the sex hormone therapy, that is in masculinizing effects in the transgender males, skin oiliness, acne, facial body hairs, scalp hair loss, increased muscle strength, clitomegaly, cessation of menses, deepening of voice. And for the transgender female, redistribution of body fat, decrease in the muscle mass, softening of the skin, decreased spontaneous erections, breast growth, decreased testicular volume, spur production, that all present has to be present in the male normal. Now coming to the what should we monitor during the sex hormone therapy? In transgender male, we had to monitor that the virilization is appropriate and there is no adverse reactions. First 3 monthly, we monitor 3 monthly in the first year, then twice per year. And testosterone is monitored 3 monthly, that is midway between the two injections. We measure the hematocrit, hemoglobin at the baseline, then 3 monthly the first year. Monitor weight, blood pressure, and lipid profile 3 monthly. Screen for osteoporosis, and ovariectomy can be considered after the completion of the hormone transition. And we conduct subareolar and periolar annual examination if mastectomy done. If not, then mammograms are considered. In transgender females, we have to monitor whether the appropriate feminization is going on or not, and we have to look for any adverse reactions, and you have to see whether the testosterone is less than 50 or not, and estradiol has reached 100 to 200. If on spironolactone therapy, then serum electrolyte potassium is measured. Routine cancer screening is recommended and BMD at the baseline. Also, screening for the osteoporosis is done, and prolactin is monitored periodically. When should be gender affirming surgery be done? This is the last step, and after this, nothing could be changed. So there is a definite criteria, that is the persistent, well-documented gender dysphoria, legal
Dr.
age
Vibha,
of majority.
Dr. Vibha,
and
time is up.
yeah, that's last slide. Successful continuous full-time living in the new gender role for 12 months. And in the transgender male, gonadectomy and hysterectomy is done. Mastectomy, reconstructive genital surgery is done. In the transgender female, gonadectomy, removal of penis, genital reconstructive surgery, breast augmentation, removal of facial hairs, voice therapy, and endocrinologists should monitor transgender persons after gonadectomy for hormone replacement therapy. So coming to our case, the patient has fulfilled all the criteria. We have suppressed the puberty by leuprolide, and we have started the patient on the this testosterone. Now this surgical part is remaining. So thank you. That's all. And yeah, there is a one announcement to make. We are organizing this Kanpur organizing this tie-up program, that is a national conclave for type 1 diabetes, and it is being organized under the Dr. Rishi Shukla as the organizing chairperson and Dr. Anurag Bajpayee as the scientific chairman. So all are invited to join it and make it a huge success. Thank you.
Thanks a lot, Dr. Vibha. And I think the key message to remember that everybody who comes to us that they want to change the gender, we should be very thoroughly evaluating. Many times they are very happy just by cross-dressing. So it's not just that they want to change the gender. Sometimes GnRH suppression is sufficient. So we have to involve psychiatrists at every stage. So after you give GnRH, after you start androgens, every time we have to look into that. Dr. Hari?
So it is as presented, it's a multidisciplinary approach with endocrinologist having a definitive but limited role after the diagnosis has been confirmed. That is a very important thing because a lot of medico-legal issues are pertaining to it. So I would say that it is more of a institutional thing rather than an individual thing. So.
And there are a lot of legal issues also which are there, which we have to be considering. So I'll request Dr. Sandeep to hand over a memento of appreciation to Dr. Vibha. So we'll move to the next talk, Dr. Arpita.
I would like to call upon Dr. Ravindra Rajput, sir, who will be talking about late effects of cancer treatment. And we know that he is the Secretary of Space Society and also professor in Hindu Rao Hospital, Delhi.
Dr. Ravindra is a passionate endocrinologist and he's been working for decades now in this field, and he is working a lot in children with diabetes and also as far as management of cancer patients as well. Follow-up is there. So it's great to have Dr. Ravindra here. Welcome.
Thank you, Anurag sir. First of all, good afternoon, everyone, or rather good noon, everyone. You are the die-hard supporter of pediatric endocrinology. And thank you, Dr. Anurag, because thinking about such a advanced symposium of pediatric endocrinology, that too in Kanpur. Although I agree Kanpur is not a small city, but even that it is not that big city to hold the advanced endocrine symposium, and that for sixth year, 6 times. So please, he deserves a big applause from all of you. Apart from that, I have a very big news also. He was keen, and he is so keen about pediatric endocrinology that he started DNB in pediatric endocrinology, that too at Kanpur Regency. That's an amazing work. Starting DNB in pediatric endocrinology means it's like starting DM, because he was working in a hospital. That is why it is a DNB. Otherwise, it would have been DM in pediatric endocrinology. So Dr. Anurag deserves a very big applause. And I am happy that he is my president also, president of our society. So he is having, all these feather in his cap. Thank you, Anurag. Thank you very much. And now we will be talking about the endocrine effects of these cancer treatment. Although most of you may not be dealing with these effects very frequently, apart from those who are working in a hospital, number one, or number two, who is working as a consultant in some oncology hospital, because usually we don't get it in our daily day-to-day practice. However, if you see what we'll be discussing in next slides, these effects are the same as you see in your day-to-day practice with thyroid disorder or growth disorder or puberty disorder. So before we start, let we all pray to God to give us strength and knowledge to treat all these very critically ill patients, because they are having very big problem of oncology rather than all these endocrine effects which is being superimposed on that. So if coming to the endocrine effect, these are the very most common, late effect of oncology treatment. And with the evolving therapy and surveillance, it is up to maybe 50% or even more than that. Number two, there is a meta-analysis has been done by the Child Cancer Survivor Society, and out of 15,000 kids, what they have found, that 50% were having at least one endocrine abnormality, and 6% they were having more than three, which is, a very, very big amount. And these often result the common problems: poor growth, fertility disorders, pubertal disorders, thyroid disorders, and metabolic disease, all the 4 pillars of the endocrinology. And who are the patients who are having the risk of developing all these patients? Number one, who has been given radiotherapy or very high doses of alkyl electing agents. And what are the tumors or oncology situations where all these endocrine effects are much more? That is the central, if the CNS tumors or orbital or facial sarcomas, because the surgery has been done and pituitary is right located over there. Hodgkin's lymphoma, many times radiotherapy has been given to the cranial irradiations, and conditions requiring hematopoietic cell transplantation. Although these are not the malignant disorder in truth, rather these are the bone marrow failures like Fanconi anemia or a megakaryocyte, thrombocytopenia, thalassemias, all these disorders. So these are all the situations where we see leukemia, lymphoma, solid tumors, neuroblastoma, and all these things, where now the treatment is available. And since treatment is being given, life has been saved. So now we see the complication. And these are all affected right from the GH releasing hormone receptor or pathways, then thyroid pathways, then dopamine pathways, and this is ACTH and cortisol, and then GnRH pathways. All these pathways are being affected. Can we have this, media people, can we have this pic on the other side? Can we have this pic on the other side? Please, if possible. Now, let us discuss first case. Now, this is a 7.5-year-old male girl, a follow-up case of ALL, and they have been given a cranial radiation with the doses of 20 gray. Because of, ALL, some must be having some CNS metastasis, because of that has been given. Now, there is a thelarchy, and B3. So what is the diagnosis? Anyone, please come on. What is the diagnosis? 7.5-year-old girl, Thelarchy and B3. So what is the diagnosis? Very simple, precocious puberty. So now you have taken the height, which is 116 centimeter, and growth velocity 6 centimeter per year. But why it is happening? Height is just 10 to 25 centile, and growth velocity is so low. If it is really precocious puberty, you know there has to be a spurt in the growth. So it means something more is happening apart from precocious puberty. So let us investigate this case. If you know oncology or malignancy is not very common in pediatric age group, just 1 to 5% of the all cases. However, endocrine effects are very, very more, as we have just discussed, up to the tune of 50%. And survival, if you look at the developed region, somewhere 1 in 500 of oncology cases. Because of why? Because now you have more and more evolving therapies, and you have the surveillance, long-term surveillance is available. So you know this life is being saved, however, not at the cost of some or other morbidity or complications. So leukemia treatment, prophylactic radiotherapy, nowadays it has been reduced. I don't think it is being given at all. If there is a CNS metastasis or gonadal metastasis, only then it is, direct radiotherapy is being given. And yes, steroids and cyclophosphamides, they are being used. So it means must have been given in this case also. And what is the effect? Sir, ye pick to pareshan karegi, idhar se udhar se. Anyway, so if this has been given, I think affecting the pituitary when if the dose is more than 12 gray, it has been, behind our pick. And if it is more than that, it will affect the growth hormone pathway, number one, and it will affect the puberty pathway, GnRH pathway. However, very interestingly, it will suppress or disturb the growth hormone pathway, but it will stimulate the GnRH. So this GnRH, pituitary, anterior pituitary, hypothalamus will start the secretion of GnRH in a pulsatility fashion. So it will cause precocious puberty. ACTH, FSH, and TSH pathway will be affected if the radiation is more than 30 gray. Means there will be deficiency of ACTH, so the cortisol. There will be deficiency of SH and LHS. If anterior pituitary will not be able to secrete, so patient will have a delayed puberty and thyroid TSH deficiency because TRH hormone will not be released. So if the radiation is somewhere close to the 12 to 18 gray, it will cause precocious puberty. However, if it is more than 30, it will cause delayed puberty. Then the effect on thyroid of these radiation, this is not very common in terms of malignancy. Papillary carcinoma, although has been reported if it has been given more than 30 gray, but not that common. Then comes the effect on the gonads. Yes, if radiotherapy or cyclophosphamide, both of them, they may affect if it is the direct radiation to the gonads or cyclophosphamide more than 200 milligram per kg body weight. Germ cell dysfunction will happen even if a very minor dose has been given, which is just 2 gray. And germ cells and Sertoli cells, what they do, they are helping in spermatogenesis, and they forms a volume of the testes. So testicular volume will be low. This has to be very, very important. What is the case which has been presented just by Dr. Pradeep from AIIMS Patna, your student? The testicular volume was low. Why? Because must have been some problem with the seminiferous tubule despite having very high testosterone, because testosterone is being produced from the Leydig cells, not because from the Sertoli cells or germ cells. Leydig cells will be affected if it is the radiation is more than 20 gray and the incidence is quite high, somewhere close to 10 to 15%. So patient will not be entering into the puberty, or if patient is pubertal, then puberty will be arrested. Normal puberty, because ovary is not affected much. However, still there may be effect on the ovary. If fracture at the onset, maybe because of the steroid has been given, or you have to be very cautious because in ALL, there may be fracture at the onset. And yes, insulin resistance on obesity, it increases when all these things or all these treatment has been given in the later age of the life. Now, let us again revise this effect of radiation or hypothalamic pituitary axis. So if the radiation has been given, it will affect the pituitary. So if this radiation is more than 12 gray, it will hamper this GHRH releasing hormone pathway so there will be deficiency of GH. If it is more than 18 gray, it will stimulate the GnRH. It will result in the early puberty, means precocious puberty. If the dose is low, it is just more than 18 gray. If it is more than 20 gray, it will cause the ACTH deficiency, CRH will not be released. So there will be deficiency of cortisol, which may be asymptomatic, but when patient is in a serious or stressful position, then will develop and will collapse and will develop shock. Or if it is more than 30 gray has been given, so it means it will disturb the thyroid axis and patient will have a features of hypothyroidism. So more than 30 gray has been given, high dose will cause the delayed puberty. So more than 30 gray will affect ACTH, TSH and FSH and LH. All these three will be reduced. This is again a summary of all this. More than 12 gray will cause, less than 12 gray, nothing, no serious side effect, except if this is direct radiation to the gonads will affect the germ cells, which I have just told on a very minimal dose. If it is 12 to 18 gray, it will stimulate the growth hormone GnRH and will cause the GHD, growth hormone deficiency. 18 to 24 gray will stimulate GnRH, cause central precocious puberty. 24 to 30 gray will cause ACTH deficiency and so the cortisol. And if more than 30 gray will cause the TSH deficiency and GnRH deficiency both. This is the axis of GnRH and GH axis. If you think how the growth is being affected, GH releasing hormone secreted from the hypothalamus acts on the anterior pituitary through GHRH releasing hormone. From where GH is produced, it will act through GH receptor along with the IGF-1, which is secreting from the liver, and the acid labile unit. Both of these, they act on the growth plate of the bone and growth occurs. So if anything is this being disturbed, patient will have growth failure. So malignant treatment will have malignant effect and non-malignant also, because if radiation is directly on the bone, it will affect the growth plate of the bone. So it will affect the growth. So if there is a high dose of steroid has been given or radiation has been given, actually it is again behind the picture, or there is a direct irradiation to the vertebrae. So it will be going, suppose craniospinal radiation has been given. So vertebrae are a very important thing in the growth. So all these growth plate of the vertebrae will be affected and patient will have a growth failure. Or TKI, tyrosine kinase inhibitor has been used, which is again will cause the growth failure. This is more in younger, depend upon the dose and duration, how much the dose and for how long it has been given. Spinal growth will be affected if it is the spinal radiation. And IGF-1 and GHRH is unreliable. Why? Because already, because of the cranial radiation, this GHRH is being affected, and IGF-1 or IGF-BP3, which usually you are doing as a surrogate marker for growth hormone deficiency. But this will be unreliable in cases where radiation has been given. So please don't rely on that. And what you have to do, assessment, how you will do the assessment of GH deficiency? You do the growth hormone stimulation test. And how you do the growth hormone stimulation test? So you should not use the GHRH. Although in India, no one using is the GHRH. So what are the other agents which are used for GHR stimulation? Can anybody please bata sakta? Dr. Anurag will give prize. Yes, yes, ma'am. Insulin, yes, ITT, which is a gold standard, but I don't think anyone is using it because it may have the serious side effect in the form of hypoglycemia, although it is a gold standard. Apart from then, clonidine and glucagon, these are the most common tests used. If someone can use insulin, okay, it's okay, fine. But one has to be very careful. I don't use because of the, once having the fatal hypoglycemia and it becomes disastrous. Management, GH after 1 year of phase. If not on TKI, means GH deficiency is there, you can start the GH, but GH only after 1 year of the treatment. In the same way, hypothalamic pituitary gonadal axis, GnRH, secreted from the hypothalamus, acting on the anterior pituitary, LH and FH is being produced, acting on the ovary, giving the estradiol, acting on the testes, giving the testosterone, and so the secondary sexual character. So if there is a tumor of this hypothalamus or of that region, or rather optic glioma, which is just next to the pituitary, will hamper all these pathways and will cause deficiency of that, or it may stimulate GnRH and patient may have precocious puberty, or radiation has been given somewhere 18 to 30 gray, even may happen even couple of years after the therapy. Incidence is somewhere 10 to 15%, and growth acceleration may be missed if there is a concomitant growth hormone deficiency. High LH is reliable. The assessment, because again, LH may be high, but because of the Sertoli cells and germ cells, they are being affected. Testicular volume will be low. Assessment has to be done by the LH testosterone and GnRH test. Again, the same case which we are discussing, put on the leuprolide because of the precocious puberty, but still growth was very, very low. Why? Because there was the concomitant GH deficiency. So it has to be treated along with the GH also. Reason being, all these radiation has been given. So apart from stimulation of GnRH, they have disturbed this growth hormone releasing hormone pathway also. This is the second case. Cervical radiation has been given. Follow-up of Hodgkin's lymphoma, T4 is low, 12 picomole, and TSS is just borderline, 6.6, TPO negative. So why it is happening? Radiotherapy has been given, or these alkylizing agents has been used, as in case of Hodgkin's lymphoma. If it is 20 to 30 gray, it will cause hypothyroidism. If it is more than 35, it will cause hyperthyroidism, thyrotoxicosis. Why? There is a radiation-induced thyroiditis. Because of that, more and more release of hormone. 20 to 30 gray, neoplasm. Although it is very, very rare, papillary carcinoma. Just couple of minutes. So it may be combined central and peripheral if it is cranial and spinal, both of radiation. Because cranial will affect the pituitary, so will be very, very less TSH production, and cranial and this neck, cervical will affect the thyroid gland directly. So radiation, if it is scattered effect, means nearby area has been given, or direct radiation like cervical radiation, or TKI has been used, or radioactive iodine, as Dr. Vijay was just using. If someone is having thyrotoxicosis, you give radioactive iodine and ablate the thyroid, or busulfan. Hypothyroidism incidence is much more, 60 to 70%. Progressive, has to be treated and early detected. Otherwise will result in growth failure also. Thyrotoxicosis, if it has been given more than 35 gray because of the radiation-induced thyroiditis, transient, and it may be because of the hematopoietic cell cell, as far as in thalassemia or Fanconi's anemia. Because of the abnormal B and T cell, they will be transferred and patient may have thyrotoxicosis. Thyroid nodule, although very rare, but if it is there, usually having a biphasic presentation, peak will be 20 to 30 gray. Neck palpation is a very important method rather than the ultrasound. Reason being, on an ultrasound examination, many a times you will get the thyroid nodule. I'll keep just 1 or 2 minutes more. because I have praised Dr. Anurag very much, so at least I should get 2 minutes more. And ultrasound is controversial, reason being, many times you find the ultrasound on nodule, you will do the exhaustive investigation and ultimately you will not find anything. So don't go for ultrasound examination, else you will unnecessarily be entangled in all these investigations. Management is as per the usual guideline. Now, case 2, cervical radiation, TPO negative, no treatment has given you. However, on follow-up nodule was found, which when was investigated was having, unfortunately, papillary cell carcinoma, although this is a very, very rare presentation, not very common. Third, 10-year-old boy, follow-up LL,
Sir,
radiation and cyclophosphamide.
2 minutes extra done.
Okay. Concern about puberty, just okay, इस केस को डिस्कस कर लेते हैं. SPL is 8 centimeter, testicle volume is 3 ml with pH 2, pubic hair 2. So why this is 3 ml? And because radiation and cyclophosphamide both has been used, reassured. Why the TB is low? We know germ cell is very much affected even with a very minimal dose. So as you know, testes having leading germ cell and Sertoli cell. Sertoli and germ cell will make the testicular volume. Leydig cell will secrete the testosterone. Radiation scattered either has been given to the inguinal region or direct to the gonads. Spermatogenesis is caused by the Sertoli cells and germ cells. Our aim is to preserve the testicular function. Smaller testicular size may be because these germ cells has been affected. Alkalizing agents, if more than 200 has been used, as we said, assessment has to be done by assessment. LH, testosterone and spermatogenesis, look for only sperm analysis. No other FSH or AMH will be helpful in that. Management, obviously, testosterone. Although there are few more cases because time is very less and our chairperson is very strict, so we'll stop here. Thank you very much.
20 minutes and my time, my job.
Thanks a lot, Dr. Ravind. You have done wonderful. It's a very big topic, but I think you have sensitized it very well that there are key issues which are there which need to be followed up. And it's not that it's unique, it's endocrinology. So you follow normal endocrinology and keep following, that will be there. I'll request Dr. Sandeep to kindly come up and provide a memento of appreciation to Dr. Ravindra. And thanks a lot. And we will continue with the next session.
I would like to call upon our next speaker, Dr. Pradeep Kumar, and he'll be talking about evaluation of XY-DST. He is an additional professor, Department of Pediatrics, AIIMS, Patna, and a former fellow of SIR. I welcome you, Dr. Pradeep.
So Dr. Pradeep has been involved with us for a long, long time, and he has been really dynamic in a number of areas and done a lot of work in that region. So he's going to give a talk on disorder of sexual development in boys, especially XY-DST.
Thank you, sir. Thank you, Dr. Arpita. Okay, so good afternoon, everyone. I'll try to make it case-based and make you all understand disorder of sexual differentiation or development in boys in very simple manner. So let's start with the case. Here is a 15-year-old girl who presented with delayed puberty, but there was palpable inguinal gonad, and on ultrasound there was no Mullerian structure. FSH was high, but the karyotype was 46XY, and the testosterone was very low, very low. Electrolyte showed normal but slightly potassium lower side, but here what we noticed that hypertension was there. Both systolic and diastolic blood pressure was high. So what is the diagnosis? So in this sort of case, what step we should follow to reach a diagnosis? So what is DSD? DSD is basically your discordance between your chromosome, gene, gonads, and your external appearance. So DSD is basically different, the discordance between These all 4 components. So any patient who presents with atypical genitalia, pinoscrotal hyposphagia, bilateral inguinal mass in girl, or cryptorchidism or undescended testis in boy, or any girl who presents with primary amenorrhea, we should suspect DSD. But what is not DSD? Any patient who is having isolated micropenis only or penile hyposphagia, those patients are not DSD. So let's go through a bit of pathophysiology. As we all know that urogenital ridge, all the gonads, etc., adrenal, kidney, those all develop from urogenital ridge, starting from 4 to 6 weeks of gestation. NR5A and CBX2 gene are involved in gonads and adrenal development, which is further stimulated by SRY, presence of SRY gene, which stimulates SOX9 and FGF9, ultimately develops testis. From testis, Sertoli cell AMH is secreted and there is a regression of Wolffian duct. From this side, GATA4 or WT1 is responsible for the development of gonad and renal. And further, it stimulates FOXL2 especially and DAX2 to make it ovary. Now, why we are discussing this? Because when we work up for DSD, the concept of this is very, very much important. Any patient who's in gonadal dysgenesis, if the problem is in NR5A1, the patient will develop with the problem in gonads as well as adrenals. If the patient is having WT1 problem, the child will have renal and gonadal failure. If SRY gene is involved, SRY sex reversal is there. If any child who is in intrauterine period, some insult has happened and the testis has gone, there will be no AMH and the child will present with DSD. The AMH itself can either present with AMH resistance or deficiency will go through with case. We should also have concept of how testis descends, what are the factors which are responsible apart from mechanical factors, hormonal factor, role of genitofemoral nerve, so that we can identify where the arrest has happened and what is the diagnosis. So especially here to mention the role of AMH, the testis which descends initially, the role of insulin-like factor 3 and AMH is there, but AMH especially plays role in canalicular descent in testis. So any testis which is at the level of this canal, so the problem may be in AMH production or action. Now for every endocrinologist, if you remember this pathway, your most of the problem is solved. So isko Gita ki part ki tarah, you in all endocrine clinic, you put it there. Go and go through it again and again. So I will not go through the detail. You know that limb, the production of aldosterone is there. This is especially for glucocorticoid. This is for sex steroid. But the important thing is that you must know the role of feedbacks. The cortisol is the main feedback which causes either enlargement of adrenals or no enlargement of adrenal. If only that limb is involved, so the patient will present with hypertension. Defect is in this side, so the patient will present with isolated DSD. So if the problem is in, proximal, so nothing is happening, so this child will present with both XY or XX DSD. If the problem is there in 3 beta HSD level, this patient, child can present with 46 XY or XX DSD. If the problem is in that 17 hydroxylase pathway, that aldosterone will form, but here it will not form. So this patient will especially present with hypertension, no androgen, no estrogen, nothing will be there. If the problem is at 17 beta hydroxylase dehydrogenase deficiency defect, the child will present with testosterone defect now, but that depends on how much the enzyme is affected. Beyond that, 5-alpha reductase deficiency and your receptor level defect. So again, this child, we go back to the child again. This child had hypertension. So what is the diagnosis? So this is likely 17 hydroxylase deficiency. So these 17 hydroxylase deficiency patient will present with 46 XY DSD, especially the children will have hypertension, no androgen will form, and because feedback is not there, so high FSH will be there in this patient. The second case, a 2-month-old child who specially presented with micropenis and had failure to thrive. The birth weight was initially 2.5 kg, now it is 2.7 kg. Had bilateral gonads palpable, 1 ml of testis, and SPL was 1.6 centimeter. The karyotype was done, which was 46XY. So the genetic sex is XY, but and on USG, there was no Mullerian structure. Now what you see, next step is to see electrolyte. What is there? This is especially salt losing. Sodium is low, potassium is high, as well as you have to see the on examination what is the dysmorphology. So the child had upturned nares, long philtrum, and syndactyly. So the question is how we should work up and what is the diagnosis likely. So again, we go back to this steroidogenic pathway. Any child who is having extreme proximal defect, the 7 dehydrocholesterol reductase deficiency, these patients will present with Smith-Lemli-Opitz syndrome. And here a clue is when you send lipid profile, the lipid profile will be low because no cholesterol is forming, and we know that cholesterol is the mother of all the steroids. So if there is no cholesterol, nothing will happen. So this patient is a case of Smith-Lemli-Opitz syndrome. For etiology, when we are working for XY DSD, the first is your all gonadal development problem, which we had discussed in the first slide. And the second is all the steroidogenic pathway and action defects. So in gonadal development problem, all the genetic problems like SRY gene defect, NR5A1, DAX1, W2N, and the clue will be other organs will also be affected. Either adrenal or kidney will be affected, or complete anorchia will be there. In gonadal action defect, there are 2 limbs, the production defect and the action defect. In production defect, you have to see whether it is salt losing or all isolated defect is there. So if it is isolated defect, 7 beta hydroxy dehydrogenase defect will be there, or at extreme proximal LHCG defect, where LH is high, but at receptor level it is not working. So further it will not respond to Leydig cell and testosterone will be not produced, and these patient will especially will have androgen defect. Another is if the child is having adrenal involvement and salt losing is there, proximal defect like star side chain cleavage enzyme or 3 beta HSD defect will be there. And if hypertension is there, 17 hydroxylase will be defect will be there. On action, there are 2 important diagnoses, 5 alpha reductase 2 defect or androgen insensitivity syndrome. So this child's 16-year-old girl who presented with primary amenorrhea, she had B1, P1, and gonads was not there. Genetics was done 46XY. Now the child had been reared as girl and karyotype is 46XY. Uterus was also present. So genetically the child was diagnosed as XY DSD. Now what should be the approach of a child who presents with XY DSD? So the first and foremost thing is you palpate the gonad, squeeze from lateral side towards the scrotum. And if it is present, maybe it is present or absent. So next step is to go with the ultrasound and see Mullerian structure. If Mullerian structure is there, so you go in that pathway, especially for 46XX DSD in this limb. And if the child is having 46XY and Mullerian structure is present, that means in the beginning something has happened. When the AMH was supposed to be secreted and act, it has not acted. So either the AMH resistance problem is there or AMH production problem is there. If gonad is present and Mullerian structure is absent, so again we have to see the action defect like 5 alpha reductase 2 defect or androgen insensitivity defect. If it is low, testosterone is low, we have to see the salt status. So salt losing condition is there, so we have to see proximal steroidogenic defect. Otherwise, if hypertension is there, we have to see, or we have to make 17 hydroxylase defect. If everything is normal and if it is supposed to be isolated, it is either LHCG receptor defect or 17 beta HSD defect. So this girl who was not having gonads P1, B1, karyotype 46XY, so gonads absent, Mullerian structure was present. So this is extreme form where gonadal dysgenesis is there. Why it happened? The child had SRY. So the child's genetic sex was 46XY, but here the SRY positive, it was SRY positive, but it was not functional. So gonadal dysgenesis is the diagnosis. The second case, 15-year-old girl who presented with primary amenorrhea, height was okay, weight was okay, B4, P2, and there was inguinal gonads palpable. Pardon me, forget that is error. So inguinal gonad was there. On ultrasonography, uterus was present and karyotype was 46XX. Testo was high, DSTY high. So we go with the algorithm. Gonad present, Mullerian structure absent, testo was there. So likely diagnosis is either 5-alpha reductase deficiency or androgen insensitivity syndrome. So here what we see, testo and DST both are high, and we see the ratio. So it is likely complete androgen insensitivity syndrome. So for etiology, what we have to see, we have to either see either it is gonadal defect, development defect, or androgen production or action defect, or AMH production or action defect, or LHCGR defect. So in gonadal, the disorder of testosterone production, the testosterone will be low, feedback will not be there, so gonadotropins will be high, Mullerian structure will not be there, present there, and AMH will be normal in these patients. So in combined adrenotesticular defect like SLO star and side cell cleavage defect, these production, testosterone production will not be there, and there will be low endostenedione. In 17 beta hydroxysteroid dehydrogenase defect, it will present with isolated defect, endostenedione will be high and testosterone will be low. As we have discussed, the testo will only be produced when LH acts on LHCG receptor. So here testo will be low and the sky high LH will be there. Since Sertoli cell function is normal, so FSH will be normal. Here extreme, since testo is not there, nothing is there. So the child's genitalia will be female, but gonads will be palpable. In action defect, 5-alpha reductase defect, the testo and DST ratio will be more than 10. If receptor resistance is there, so testo and DST both will be high. It can present as, depending upon the ratio of enzyme affected, either it complete androgen insensitivity syndrome or partial androgen insensitivity syndrome. So how to be, these are very common problems we encounter in our day-to-day practice. So how do we differentiate between 5-alpha reductase deficiency and androgen insensitivity syndrome? Okay, so the crux is that when you start treatment in 5-alpha reductase defect, virilization is there. While in androgen insensitivity syndrome, if you give testo, it will get converted into estrogen, so feminization will be there. Gender of rearing, since it responds to testo, so more likely male rearing is there, and in this case there is no option, so you have to rear as female. AMH action we have discussed. Okay, how do we assess? So for assessment, since it's a medical emergency, you have to counsel the parents and you have to take decision about sex rearing of the child. Okay. So for examination, Prader scale, you always write on the paper what is this Prader scale and endogenital ratio. For diagnostic workup, the first step is to put and make the genetic diagnosis 46XY or 46XX, and we have to name the DSD like that. Then we have to rule out steroidogenetic defect, then test to 1 DST ratio. And at last, we have to go for genetics, because that is very, very important. Even nowadays, the debate is going on whether we should invest for biochemical test or straightforward go for genetic test. It does not seem logical that we should go for biochemical test. But as we know that even biochemical test we do, most of the times we are wrong when we go for genetic test. It comes, something different. So that is very much important. So this child I managed with long way back, I think 5 years back, 6-month-old child who presented with bilateral swelling. The external genitalia was female. Karyotype when we did, it was 46XY, and this imaging showed blind vaginal pouch. The differentials were 3 beta SSD defect, complete androgen insensitivity syndrome, and LHCGI defect. Biochemical test did not give any clue what was the diagnosis. So we sent whole exome sequencing. The fascinating word came 5-6 saal pehle. So we sent this, but nothing came. The tests were negative for, give anything, any diagnosis. So what we missed, what we should have, done. So as we say, next step, there are lots of, this whole exome sequencing only detects this expressing gene areas like exons. It misses introns, promoter sequences, enhancer, and all the UTRs and other areas of the gene. So we should have either gone for whole genome sequencing, or we could have done for, okay. So this paper showed that even if you do molecular test, more than 50% are still not diagnosed. So don't get frustrated. Case to case basis, see the response of treatment and you manage the case, because even after you do all the molecular tests, 50% of cases you cannot make the diagnosis. So I'll leave it, sir. Thank you.
You have done very well to cover. This is one of the most complicated parts of endocrinology. XY-DSD, he has given clear-cut message, gonadal abnormality, testosterone synthetic defect, resistance. And then I think we are moving towards genetics. We all saw so many cases yesterday on DSD, and we found that in those cases, genetics gave some other diagnosis. So you are thinking of, okay, this looks like LHCG receptor defect. It is showing something like that it is 17 beta HSD. So all differences can be there, but genetics is something which is becoming very important. Thanks a lot, Dr. Pradeep, for the wonderful presentation. I'll request Dr. Sandeep to give a memento of appreciation to Dr. Pradeep, and Dr. Hari, if you have any comments on this topic.
Yeah. So it is the most important take home will be it's a social emergency. Once you know the sex of rearing, then other things can happen. So that is the most important thing. The rest, the workup will continue. And XYDSD genetics is really important. That is the truth.
Next talk.
I would like to call upon Dr. Sejili Mehta, who will be talking about genetic obesity. She is a consultant pediatric endocrinologist in Pune and former fellow of Dr. Anurag Bajpai.
So Dr. Sajali was here with us, I think, around the COVID time, when there was the peak time. And it was a very good time, and we had discussed a lot of good cases. And now she is practicing in Dinanath Mangeshkar as well as the your KEM Pune as well as pediatric endocrinologist. And the topic is quite interesting of genetic obesity. Over to you, Sajali.
Thank you, sir. At the onset, I'd like to thank sir and the entire CDR team for giving me this opportunity. And thank you, Chair. I'll finish my session in 15 minutes. Okay. So let's begin. So this is a case of a 7-year-old female child who came with complaints of rapid weight gain noticed since last 8 to 10 months. She had history of hyperphagia, and mother also complained that the child was snoring. And because of the weight gain, the parents considered that she was lethargic. So this is her growth chart. If you look at the growth chart, you can see that at 7 years, she weighed only 32. At 5 years, she weighed 16 kgs. At 6 years, she weighed 20 kgs. And in the last 1 year, she gained around 12 kgs. So is this a lifestyle-induced obesity or is it a pathological obesity? Okay. So let's understand obesity. So we know that obesity is physiological. That is basically a lifestyle-induced obesity which has normal growth development. Pathological obesities can be genetic, they can be secondary to due to hypothalamic damage, or they can be endocrine. So how do we differentiate them are the genetic obesities can be monogenic or syndromic, and they are associated with hyperphagia, that is non-satiable hunger, vision problems. They may have pubertal or developmental problems. Secondary hypothalamic obesity is basically because of will have features of hyperphagia, and they may have a history of CNS insult. Endocrine obesity normally will be affecting the growth, so the child will be short and obese, which we always know. So, what is pathological obesity on the growth chart? If you see, like we discussed, that short and obese child has endocrine cause of obesity. But if the child is also crossing two central lines of the weight in a short period of span, also is pathological. Even if you look at this child, she was obese and she had crossed two central lines in a short period of time. So you have to consider pathological causes in this condition. So when do we evaluate for genetic obesity? So the guidelines suggest that any child who is gaining rapidly weight in the first 5 years of life, or has any features of genetic obesity syndromes, which we know of like Prader-Willi or Bardet-Biedl, we should evaluate for obesity. And also, if there is a strong family history of obesity, and not just obesity and extreme obesity, in that conditions we need to evaluate for genetic causes of obesity. So the pointers will be early onset obesity. Normally they present with obesity before 2 or 3 years of age itself. They may have a non-selective hypophagia. That means they will eat anything that is given to them. They will not be choosy like seen in lifestyle obesity. So that is non-selective, and it is very important marker of pathological obesity. They may have dysmorphic faces or developmental delay, as we discussed. So what is basically happening in monogenic or syndromic obesity is we know that there are many pathways which regulate our diet and satiety or appetite. One is homeostatic, one is hedonic, which is basically your choices, and the amygdala is a pleasure eating. So, and also there are multiple hormones which play a role. But if you look at this, the most important factor in monogenic or syndromic obesity is the issue with the satiety, and which results in hypophagia. So this is a complex side of hunger and satiety, but just to summarize, the signals from the stomach and intestine causes hunger, and which acts on the CNS resulting in hunger sensations, and the leptin and the pancreatic hormones through various pathways act on the hypothalamus to cause satiety. So these are pathways that are very strictly regulated, and any defect in the genes along this pathway can cause monogenic obesities. So let's share genetic obesity causes. So in monogenic obesity, the most common cause is leptin deficiency. In addition to that, there are many genes which can be involved along the pathway, like there can be leptin resistance or POMC defect and many more. Similarly, there are some other genes which can have monogenic obesity along with developmental delay like BDNF SM1 or TRKB1. Syndromic causes, as if you look at, there are 27 to 28 syndromic obesity causes that have been documented, but the most common are the Prader-Willi and Bardet-Biedl syndrome, Down syndrome, and others. So let's go back to the case. So this was a 7-year-old child who had rapid weight gain. So if you look at her history, she had daytime sleepiness. There was no affection of vision. There were no headaches. And we had worked up for the rapid weight gain, which was normal. And her whole exam was also sent. On follow-up after 2 months, when the whole exome reports came, the child came for follow-up. The whole exome was negative. The child was almost drowsy. She was continuously sleeping even in the OPD. She had irregular breathing, and when we checked her pulse saturation, she had hypoxia as well. Her saturations were maintained between 80 to 90. So clinically, the child was fitting a picture of a condition known as Rohart syndrome. So we did a polysomnography which showed central apnea. So what is Rohart syndrome? Basically, it's a syndrome of rapid onset obesity, hypothalamic dysfunction, autonomic dysregulation, and hypoventilation. So one should be aware that this can appear anytime, and one should know that it is associated with hypoventilation, which can be life-threatening. And in this condition, one needs to treat it symptomatically, and they may need long-term CPAP support for apnea. And obesity as such, there are no treatment for obesity, only lifestyle management along with restrictive diet. So let's go to this second case. This is a 6-month-old female child, came with complaints of weight gain. Development was normal as per parents. There was no hyperphagia as per parents, but being a 6-month-old female child, she was exclusively breastfed. breastfed. So there were no proper idea about hyperphagia. She had normal vision. At least she was making eye contact with the parents. The only history here relevant was she was born of third degree consanguineous marriage and she had polydactyly, a post-axial polydactyly. If you look at her parameters, growth parameters, her birth weight was 2.5 kgs, but at 6 months she was around 10 kgs. So she was rapidly gaining weight, and we do encounter these situations. So what is this? Is it a pathological condition? So yes, early onset obesity is pathological. So we did a genetic study in this child and it turned out to be a Bardet-Biedl syndrome, a homozygous type. So Bardet-Biedl syndrome has rod cone dystrophy, abdominal obesity. If you look at the parameters or the studies on Bardet-Biedl, you will see that there is only 89% chance of obesity in pediatrics and they present over time. So if you look at this table, I have highlighted that even in less than 2 years, only 39 were overweight and 27 were obese. The rest of the patients, like 53 patients, were normal. So the weight may not be the early marker of Bardet-Biedl, but yes, dysmorphism and then affection of the rod cone may be a marker of Bardet-Biedl syndrome. So one needs to take a detailed history and understand that the syndromic obesity features may evolve on time, and so we need to keep an eye on these patients. So basically, the management in Bardet-Biedl is very difficult. Most of the times, the management is lifestyle based, and when the patients have more BMI, there have been pharmacotherapy which has been done in patients older, like orlistat or topiramate. And also there have been some talks about bariatric surgery in these patients when they develop complications in adulthood. The recent study on setmelanotide has shown that the setmelanotide has an effective role in decreasing hunger as well as reducing the body weight in Bardet-Biedl syndrome and Alstrom syndrome. So it may be the future treatment for patients with Bardet-Biedl syndrome. As of now, we don't have it in India. So let's go to the next case. This is a case of a 2-year-old male child who was referred by a pediatric surgeon for the complaints of left undescended testes and small-looking genitals. He had mild developmental delay in the form of motor delay, which parents didn't highlight that. And he was also looking obese. He was born appropriate for gestational age, and on asking, the parents gave history of neonatal feeding difficulties during the neonatal period. So this is a classical case of Prader-Willi syndrome, and the genetics confirmed. But what happened in this child was he was seen by an endocrinologist before, who had evaluated the child and advised whole exome sequence, which was normal. So one needs to understand that in Prader-Willi, it is a methylation defect, and one needs to do methylation studies or MLPA studies so that to have proper diagnosis. So Prader-Willi syndrome evolves over time. As I described previously, the conditions evolve over time. So in the first year of life, they have hypotonia, feeding difficulties, failure to thrive. And over a period of time of 1 or 2 years, they switch to excess appetite, hyperphagia, food addiction, and weight gain. Along with that, they have behavioral disorders and intellectual disabilities, learning disabilities, and they also have hypothalamic pituitary disturbances, hypogonadism, and a typical features of almond-shaped eyes and small stubby fingers. So in this condition, the only recommended therapy is growth hormone therapy, which also not only improves the weight, but also improves the cognitive affection. So this is my other case. This was a 2-year-old female child who came with complaints of excess weight. Non-satiable hunger. Every 15-20 minutes, the child used to ask for feeds. The parents were very frustrated with the feeding problems, and the child was very irritable. At 2 years, she weighed around 25 kgs. She had motor delay. Because of the weight, she was not able to actually walk or do any other activities. So she was a classical case of congenital leptin deficiency, and her leptin levels were evaluated, which showed low. So basically, leptin deficiency is a monogenic form of obesity, which is caused by a defect in the leptin receptor. It is associated with hyperphagia and early onset obesity. And as leptin also plays an important role in your pubertal axis, these patients have hypogonadism along with it. These are very rare cases, or maybe not diagnosed because of non-easy availability of the genetics. And the treatment here is mettereptin, which does show significant results, but we have not tried. So this was a study in the NHS which has showed that before leptin, the child was so heavy, and post leptin, he lost a lot of weight. So monogenic obesities, as I discussed, are very rare, but they can be because of multiple defects. Actually, if you have any child who comes with unsatiable hunger and early onset obesity, then only we think about monogenic obesity. And there are 2-3 classical findings where we can see that the patients can have adrenal insufficiency in conditions like POMC deficiency, or sometimes they may be tall also. So most of the common monogenic obesity defects may not have developmental delays, but some like BNP factor gene or TRP factor may have a cognitive impairment along with that. The only drug which has been approved for in this conditions is setmelanotide, which has been approved. It's a MC4 receptor agonist, has been approved for POMC defects or proconvertase defect, and also has been studied in Bardet and Biddle. So this looks like a promising molecule for our patients with monogenic obesity and Bardet Biddle as we described previously. So approach, we know that if the obesity, if a child comes with obesity and he has normal growth, puberty, this is mostly a exogenous cause. If the child is growing slow, it is endocrine cause. And if the child has developmental delay, dysmorphism, we know that it is either genetic or metabolic cause, genetic or monogenic obesity. So accordingly, we need to decide on what test to be done so that we can diagnose them at the earliest. Thank you. Any questions?
Thanks for surgery, and you have covered in very expeditely in that regard. Please stay on. So, I think this is very important. So, if you have 4S, we always talk about severe, syndromic, soon, and segregating. So, it's happening too early. There is a syndromic feature. If there is a family history and it's very severe, you do a genetic test, whether it is obesity, whether it is precocious puberty, diabetes, everywhere. The same logic goes on that regard. I'll request Dr. Sandeep to please hand over a moment of appreciation to Dr. Sajali.
Only comment I have this, though we are able to diagnose it, unfortunately, very less number of therapeutic options.
So I think therapeutic options are a big problem. The cost is extensive.
Yes.
But that is a big problem.
But then only nutritional.
Yeah, and I think nutrition, and I think coming up with GLP-1, and I'll be talking a bit about GLP-1 analogs. They are becoming now more accessible, and probably they have a role in many of these conditions as well. So I'm talking about obesity and GLP-1. I'll talk a bit about Elstrom and other where the studies have been done. So we'll move to the next and final talk of this session.
I would like to call upon Dr. Aisha Ahmed, ma'am, who is a professor in the Department of Pediatrics, Aligarh Muslim University, and she'll be talking about immune endocrinopathy. I welcome you, ma'am.
Welcome, Dr. Aisha. And Dr. Aisha has been there in each and every program that we have done till now. I think all the APES, PPEC, and we have conducted programs also in AMU along with that. So please.
Thank you so much, sir. And good afternoon, everyone. And so this brings us to the last talk of the session on immune endocrinopathy. So to begin with, what is immune endocrinopathy? So as you can see, as the name implies, it is a rare condition where till now we have been talking about involvement of a single endocrine organ. But this condition, it encompasses a rare condition where a multiple endocrine glands may be involved and which are mistakenly identified and targeted by the immune system of the body. So just a quick run through of why does this happen? Okay, so what happens in immune endocrinopathy? The body protective immune mechanism, the cytotoxic T cells, which are produced in the bone marrow and they are stored in the thymus. So normally what happens, even there are cells which recognize autoantigens, but they are prevented from being released into the circulation so that the normal body cells are not destroyed. And this is regulated by ARI, this is autoimmune regulator gene. Okay, so whenever there is mutation in this gene, what happens, these cells which recognize, these cytotoxic T cells which recognize autoantigens, they are not removed and they are released into the circulation and they cause all the havoc. So different endocrine organs at different types are involved and they may lead to a varied presentation. And this could also be because of antigenic variation, like in certain tumors and in certain infections, like there are presence of autoantigens. So the body recognizes these as foreign and they are targeted, and thus all the hormonal imbalances, this is ensured. So talking about the presentation, how do they present? That will depend upon the which endocrine gland has been involved. So as I said, not more than one glands are involved, but not always, that it takes time. So the presentation will depend upon which gland and in what time of presentation has been involved, but definitely there would be some or other pointers which will present towards the gland that has been involved. And another point to remember here would be, apart from endocrine hormonal imbalances and the clinical features, because of that, there will also be associated non-endocrine pointers, like you may have vitiligo. I'm not sure if it's quite visible. Like you may have vitiligo, you may have alopecia, you may have involvement of hemolytic system like hemolytic anemias, especially pernicious anemia. Then you may have involvement of GI tract. So you may have endocrine and non-endocrine presentations and pointers in a child who has immune endocrinopathy. So so this is a repetition of the same. So to make it understand better, I would quickly take you all through the certain case vignettes. So you'll be in a better position to understand. So here we talk about the first case. This is about a 3-year-old boy who was brought with complaints of oral candidiasis, and he had history of recurrent thrush. So the T cell subset, which had been checked, they were absolutely normal. And the child was started for on fluconazole for his candidiasis, which was not very easily responding to treatment. And on follow-up, this child was brought one day with seizures. So what is the plan? So on baseline biochemical investigations, the calcium was low, the phosphate was on the higher side, and the parathormone was low. So this is typically the child has seizures because of hypocalcemia, and this was a case of hypoparathyroidism. So what should be the plan? A child having recurrent thrush and having a metabolic abnormality, hypocalcemia leading to seizures. So does that ring a bell to anybody? So always, yeah. Anyone? Okay, so always think of autoimmune because it's the topic here. So autoimmune polyglandular syndrome. So presence of any hormonal abnormality, any metabolic abnormality in present of any other non-endocrine feature, always suspect underlying immune dysregulation. So APS1, it is not a very common disorder, but seen in children. Especially in the early years of life, in the 2 to 5 years. So the main presentation of this condition, like this child in question, was candidiasis. About 70 to 100% of children will have candidiasis not in the oral cavity, but also in the nails and also skin as the most common manifestations. Then after infancy, in the first decade, you may have hypoparathyroidism, which can be seen is in children as high as 70 to 90% of cases. And then after the first decade, you have, so this is the clinical triad of APS1, and you may have adrenal crisis or even Addison's disease, as the presentation can be seen in 60 to 100% of cases. So apart from that, there can be involvement of non-endocrine glands like hepatic involvement seen in 10 to 40% of cases. Then the clinical pointer would be a child who has urticaria, who has fever with rashes, which is unexplained. So always think about and try to diagnose APS here. And non-specific GI symptoms, which can be seen in as high as 50% of children. So endocrine plus non-endocrine, unspecified symptoms, always think of underlying immune dysregulation syndrome. Apart from that, there can be involvement of almost any organ of the body. They may present with keratoconjunctivitis, they may have pneumonitis, and even nephritis, interstitial nephritis can be seen. So talking about the boy again, he had recurrent thrush, T cell subset was normal. He was started on fluconazole, and on follow-up, he had seizures. He was diagnosed subsequently as a case of hypoparathyroidism. And coming to the pointers, so you have features of hypoparathyroidism. So as I said, biochemically, now here you have two issues. You have to treat the symptoms and the condition with which the child has presented. And in addition, you have to keep in mind and keep investigating for other associated endocrine as well as non-endocrine involvement that can happen. Okay, so depending upon the presentation, you have to take the case forward and manage him accordingly. So here the pointers were hypocalcemia and low parathormones. You have the reason. It's a case of hypoparathyroidism and falls under APES 1. So we followed up this child and he again kept having hypocalcemia again and again, so that the calcium and the calcitriol had to be increased to the higher dose. So what could be the reason for that? The reason for this increased requirement of calcium could be, as I said, many other organs can also be involved. So this child had gastropathy, had malabsorption, and the dose of calcium and also the calcitriol had to be increased. So their calcium and calcitriol requirement are high for maintaining normocalcemia. So this was the on follow-up 2 years later. So the child was doing well for 2 years. Then again, after 2 years, the child presented with vomiting. Then what happened then? So the calcium on the higher side, 11.4, phosphate was on the lower side. The sodium was 128 and potassium. So does this ring a bell here? Pardon? Adrenal, very, very good. So as I said, keep presence of one autoimmune disorder, one endocrine gland abnormality, keep thinking, keep monitoring. So this is what happened with this child. So cortisol levels, which were low. So definitely the child had pigmentation and candidiasis, which was recurrent. So this was a clear-cut case of APES 1 and was managed accordingly. So this is the biochemical investigations will depend, as I said, upon the target organ that has been involved. So going to the second case, so this is about a 12-year-old girl who was a diagnosed case of type 1 diabetes, who was on MDI at the rate of 1 unit per kg per day. And despite having euglycemia, she complained of weakness, lethargy, and hypoglycemia. Okay, so the insulin dose was decreased and she was having weight loss, persistent weight loss. And one day she was brought with the complaints of shock and she had a salt wasting crisis. So again, we had type 1 diabetes and we had a child who had associated adrenal. Okay, adrenal crisis here. So immune workup for type 1 diabetes, as you know, this is a autoimmune condition. So every week, every 6 weeks, it has to be, they have to be monitored for involvement of thyroid gland with TPO and TSH levels. And if there are no symptoms, then they have to be monitored and checked annually for development of hypo or even hyperthyroidism, as the case may be. Then they may have other GI involvement, like in case of celiac disease. So they have to be checked for celiac disease with a baseline TTG and has to be done annually for at least 5 years. And even if the TTG, the biochemical levels are normal, but the suspicion is quite high, the symptoms are there. So definitely endoscopy, biopsy, the threshold for biopsy should be low in such a scenario. For adrenals, if the child has hypoglycemia or presents in shock-like crisis like the child in question, so definitely think of hypoadrenal as the cause. And also for especially type 1 and also in type 2 APS, you may have gonadal failure. So the children, they may present with primary ovarian failure or they may present with delayed puberty. Okay, so just a flow chart of how to progress and how to approach a child who presents with immune polyendocrinopathy. So basically, broadly, they have been divided into two types, 1 and 2, and what decides the etiology, the reason, the mutation of the gene, and also the type of organs that have been involved. Like for APS 1, the main we have is hypoparathyroidism and adrenal, and it is caused due to mutation in AIRE gene, as I said, autoimmune regulator gene. So because of mutation, this is a monogenic form of polyendocrinopathy. Then you may have candidiasis, which is seen in the first initial years of life, especially in infancy, which is recurrent, then followed by hypoparathyroidism. And after the first decade of life, most of the children, they present with adrenal insufficiency. Then you have APS 2 and 3 which is polygenic and which is because of the alteration in the MHC and which is seen in certain haplotypes of certain HLA specific haplotypes. And the difference between 2 and 3 is they both have, the most common is the type 1 diabetes, and they may have hypo as well as hyperthyroidism. And the difference between type 2 and type 3 is between presence and absence of adrenal insufficiency. So in type 3, which is also known as type 2B, you do not see adrenal insufficiency. This is the more common type, but seen in adolescent and adults. Then another very uncommon, rare, I would say, is X-mediated type. This is APEX complex, which is again very rarely seen, but has a very, very grave prognosis. And the children, they have severe enteropathy and also the skin manifestations. And most of the cases, they succumb in the initial years of life. So how do you approach as per pointers? As I said, it is very non-specific. Any of the endocrine gland may be involved and they may have associated non-endocrine presentation also. So as per the pointers in the case, that case has to be investigated and approached. So you have to go for biochemical parameters. As you see, Addison's disease, hypoparathyroidism, and thyroid and diabetes. These are the most commonly involved endocrine glands. So these baseline investigations need to be done to confirm and presence of multiple organs. Just suspect and think and investigate on the lines of APS. So in hypoparathyroidism, and for APS, like for hypoparathyroidism, you have to check for the regular calcium phosphate and all the parathormone and those biochemical parameters. Then there is one antibody, if you can see, interferon alpha and omega. This is somewhat pathognomic because it's an autoimmune condition. So it is seen in about 90 to 95% cases. You may have this interferon alpha and omega antibodies, which can be measured biochemically. So this is one of the pointers. So you may check for these antibodies, and it is also said that in cases in families where children have in diagnosed cases of APS1, you should, this is a very good screening tool, presence of these antibodies against alpha and omega interferons, which is a very good screening tool for knowing if the other children, they may have this APS in future. Adrenal failure, again, depending upon the presentation, you have to go for cortisol levels, ACTH levels, and the investigation and management is the same as in any other condition, except for you have to manage multiple things. You may have to manage multiple abnormalities in the same go. Type 1 diabetes, again, you have to check for TSH levels, but that holds true for any autoimmune endocrine disorder. So this picture again shows the same thing. So the main difference between is in the age of presentation and the type of gland that has been involved. So APS2 is more common, but seen in adolescent and adulthood. APS1 is less common, and it's seen more commonly in children. Here you have more of candidiasis, more involvement of hypoparathyroidism and thyroid gland. APS2, type 1 diabetes is most common, followed by thyroid and any of the endocrine organs. And IPEX, again, is a very rare, but has a very bad prognosis. So coming to the second case, this is about the same girl that we're talking about. So cortisol levels, she was on MDI, multiple daily injections. Despite that, she had symptoms of weakness, lethargy, weight loss. So the cortisol levels were low. So she was a case of APS. She had hypoglycemia, so fitting into category 2 glands have been involved. So I'm sorry, it's not APS1, but rather, though those both features can be seen in both kind of APS, but type 1 diabetes and also adrenal insufficiency is seen more commonly in APS2. So coming to the third case, there we have a 10-year-old boy who is a diagnosed case of adrenal insufficiency and who has been started on hydrocot at 15 milligram per meter square. He still complains of lethargy, weight loss. So you have to look for other underlying conditions. The sodium levels are low, potassium levels are high. So think of adrenal. Again, so features, it's a adrenal insufficiency as a part of immune polyendocrinopathy. It is not very common. It has a gradual onset, and the antibody levels, as I said, for adrenal, the specific antibody levels would be 21 hydroxylase. So NT21 hydroxylase is a specific antibody, and also this SCC, that is side chain cleavage antibody. So this can be checked for knowing the underlying autoimmune etiology of the adrenal insufficiency here. Association, they may have thyroid disorders, they may have diabetes, and they may have any gland involvement under the sun. So I'll go through the next case. I think this is clear here.
Yeah,
So this was the case of APS 2.
Time does
Time
not
is up?
allow. Yes.
So I think
I'm really sorry for that.
I'll just go to the last slide, just some of the take-home message. Okay.
Yeah, take home message.
So non-endocrine predators, this is the same thing. Especially pernicious anemia. Okay, so you should think about APS. So I'll go to the last slide then.
Yeah.
About just a slide about the management. So the management would be two prongs. One is you have to treat the hormonal imbalance. In addition, you have to take care of the autoimmunity, for which we have only available option is the either steroids, IVIG, or immunomodulatory drugs. So that is the treatment option we have. And this is the last slide. Okay.
Thank you so much, ma'am.
Okay.
Thanks a lot, Dr. Aisha, and you covered it very well. I think the main message is we often read APS 1, APS 2, 3, but a patient, when he comes to you, he does not come, I am APS 1. He will come to you with hypoparathyroidism. He'll come to you, APS 2 will come to you with ovarian insufficiency. So it's not that they're labeled. So then this methodological approach that you gave as to what workup should be done in what case is very, very relevant. And always think that when there is one endocrinopathy because of immunity, the second will be lying somewhere in the corner. And type 1, as we discussed, is extremely important. So I'll request Dr. Nimisha to kindly hand over a memento to Dr. Aisha. Thanks a lot. I'd like to thank Dr. Hari and Dr. Arpita, who have been deprived of lunch while everybody was feasting. So I'll request Dr. Sandeep to kindly hand over mementos to them, and please proceed for lunch from there. Dr. Arpita, please. I think you got the wrong one. This is the name. Okay. Thank you. Thank you. Thank you. This is the name one. Okay. So we'll move to the next session. Over to Nimisha for the next session.
To our next session, I would like to invite Dr. Rajiv Das, Associate Professor, Budhman Medical College, West Bengal. Dr. Balaji Chinnaswamy, Professor of Pediatrics, SRM Hospital, Chennai. Dr. Delhi Kumar, Additional Professor, Pediatrics, Chipmar, Pondicherry. Our first session is on diagnostic crosstalks by Dr. Anurag Bajpayee sir and Vibha Yadav ma'am.
So we had just a slight change in the schedule. So the first talk has been shifted towards technological innovation in pediatric endocrinology. And so I'll be taking a bit of a talk, and then Dr. Vibha will be talking in between about the bone age assisted interpretation of growth, which she had helped validate, and we'll discuss about that. So we all know that pediatric endocrinology is one branch which is considered to be quite fascinating in terms of clinical scenario. And there are a lot of things a clinician has to do. So when a pediatric endocrinologist, they have to do is basically to diagnose the condition, to interpret a lot of reports, because then we write a lot of prescriptions, manage the conditions, and take a decision. Now, often this can be complicated because there is limited access as far as pediatric endocrinology is considered in that regards, and that results in a lot of confusion. So we have been working towards developing tools which can help in terms of technological improvement to provide point of care evaluation and management diagnostic guidance in that regard. We'll talk about some of these diagnostic tools. So we'll start off with this case, 12-year-old girl with height of 120 centimeters, weight of 15 kgs. This is a common scenario. Somebody comes to us with short stature. We know most of them are physiological. 80% are physiological, and around 10% will have a pathology. The role of a clinician is to not do unnecessary workup in these 80% while not missing out on this pathological cause. That becomes important from a clinical perspective. So what we did was that we have developed, the algorithms are there, they are everywhere as to how do you interpret, you look at the growth chart, the bone age, and you will get the right diagnosis. But is it happening in clinical practice? So what we did was that we took 250 cases from our own clinic, and based upon the findings, we gave it to specific people. We gave it to a pediatric endocrinologist, a pediatrician and a trainee to try to see how much are the errors which are happening in terms of evaluation of growth failure. And what we found was there were big problems in terms of one, pathologies were being missed. Otherwise, pathology was being overdiagnosed. So on one hand, workup was not being done, and other unnecessary workup was being done. So this was something which was quite problematic. So what we thought of that, this is the time of technology. We should start using technology. Morning, we had big sessions about technology. How can we help that we have a systematic evaluation of these disorders? So we use the automated decision tree. Now, when we talk about these things, we talk about AI, automated decision, and then we talk about assisted guidance. Now, artificial intelligence requires a large amount of data set to train it. So suppose you want to develop a tool for short stature, you would need at least 10,000 cases of short stature with all the workup. And then you would know that this is the diagnosis, and you feed all the data to AI, it will develop its own ways of reaching the diagnosis. That, of course, is not possible, at least at the moment. So what we decided on, we'll use a decision tree, which is the algorithms that we are talking about. They are implemented in the system. So automatically it is there. So this decision tree approach, what we did was that we built up a tool which will look into all these factors. So let's see how it works. So this is a 12-year-old girl, height is 132 centimeters, and we know this child is short. Now, if you look at the growth chart, she is short for the population, but she is not short for the family. So if you just interpret it properly, you will get the right diagnosis. This is familial short stature. But when we sent this case to many experts, we found everybody had different opinion altogether. So we need to have a rational approach, because one, you need to plot on the chart. Second, you need to look at a lot of databases to get that. So what we did was that we developed a growth interpreter, in which all you have to do is to just put the basic data, height, weight, date of birth, and you will get the interpretation based upon a number of parameters that we are looking at. So these are the scenarios which will look into these parameters, and based upon that, there are algorithms which are saying that this is familial short stature to guide the diagnosis. Then we validated this. This was published a few years ago in JPEM. And what we found was that the app had around 99% concordance rate with the clinical diagnosis. So of course, we're not saying that the app can replace it. It can provide objective assessment, and it will guide us that whether we need workup or not, and go forward from there. So this is in a way giving a guidance from that perspective. Now, we thought that once we have developed this for growth, we can go beyond for other disorders. So obesity, we just discussed about obesity, in which 98% is pathological. But still unnecessary workup is physiological, but still unnecessary workup is done in our other perspective. So we developed this algorithm based upon the standard guidelines from the International Obesity as well as IAP criteria, using simple things, using age, whether less than 5 years, more than 5 years, development, vision, dysmorphism, height, SDS, and based upon that, we developed an interpreter which just asks a very few things. It asks what is the height, what is the weight, development, and then it will give you whether it is constitutional obesity, pathological obesity. This is being under consideration in Pediatric Obesity Journal. And again, we found a high level of concordance in obesity interpreter. So obesity interpreter, let's go in this case, which is a very, very common case for pediatricians who are working up a child with obesity, and somebody find the TSH of just mild elevation 7.91, started on thyroxine. But if you really interpret the growth chart and evaluate, what you know that this child is also tall. So if you have an endocrine pattern, you have obesity and short stature. What we have put there is that we have put a BMI SDS criteria to say, and height SDS criteria to decide whether it's endocrine versus a nutritional. So this is saying you don't need to do that much workup from that regards, and this thyroid does not require any further evaluation. So using objective tools can help rational decision making in that regards. One of the cases which we discussed a lot, and Dr. Pradeep presented today, about XY DSD. Whenever we used to have a class on DSD, 15 minutes later, everybody forgot everything. And when a child comes in, we are again in a complicated situation. And that's not very important, because it is something which is an emergency requiring immediate care and gender of rearing. There are algorithms which are there. This is the algorithm which we have used in our DSD interpreter. But if you can see, this is how complicated this is. So many things cannot be expected from a pediatrician to understand. So what we did is that we developed a DSD interpreter in which you have to put in data. Like here you put the data about sodium, potassium. It will ask only whatever investigations are required. And then it will tell you this is 3-beta HSD deficiency. So this is how the diagnosis was made, and we have developed for all aspects. So this way we are cutting down on investigations and we are reaching the right diagnosis. And again, when we did this validation study, this is under publication in Journal of Pediatric Endocrinology and Metabolism, we found that the use of DSD interpreter could reduce discordance significantly in both experts as well as non-experts. So as far as diagnosis is concerned, this can guide in that perspective. Now we have got multiple interpreters, including puberty interpreter, hypoglycemia interpreter, calcium interpreter, electrolyte interpreter. Now calcium and electrolyte are very good because in electrolyte, based upon sodium, potassium, it will evaluate everything, whether it's hyponatremia, hypernatremia, hypokalemia, everything is in there in the one module, and you will be able to use that. So all of you can go and have a look in that perspective. Puberty again is a very common scenario in which there are a lot of problems which are there, and there are a lot of confusions. So we also have a puberty interpreter in which it will guide whether it is a precocious, peripheral, central, rapidly progressive, slowly progressive. So a basic guidance is there for the pediatrician to assess and manage from that perspective. Similarly, for boys, we know that if the testicular volume is enlarged, this is a central precocious puberty. So it's looking into those parameters like what is the bone age and what is the scenario in that perspective to look at in terms of the overall aspects of puberty interpreter, and that will give you the clue from that perspective. So we have got tools which are looking at in terms of evaluation of the puberty. Similarly, tools for diabetes evaluation in the terms of diabetes interpreter to classify diabetes in that perspective. Hypoglycemia. So based upon the GIR values, we had a full session on hypoglycemia in which so complicated cases were there. So whether ketone is present or not, those parameters will give us a clue. So there are tools which will guide towards nearly every aspect of pediatric endocrinology evaluation. So this will make diagnosis easy. We are not saying that we should rely blindly on these tools. Use your clinical judgment, but this will help you interpret results, make it much easier from that regards. The other important scenario is to interpret. So how do you interpret the data? So this was a case whom I saw recently. This was a child who was referred to us with short stature, and the bone age was reported as 14 years. Now, if you say this child's height is only 135 centimeter and bone age is 14 years, hardly anything can be done. The parents had been told that we should give growth hormone. Now, what we found when we reassessed the bone age, it was only 10.5 years. So assessment of bone age is largely having a lot of issues in terms of evaluation. So what is the problem there? Is that methods are there like GP method, Tanner Whitehouse and Bone Expert, but they are either not used widely, especially the pediatricians don't use that, the radiologists don't use that, or they are very expensive. So we have developed and published a novel way of assessing bone age using only 5 sites. It's a quick way. All you have to do is to compare 5 sites, which are basically the proximal middle finger, middle phalanx, proximal phalanx, looking into the radius, ulna and thumb. And if you compare that, you will get a validated bone age. And this tool now has been used extensively across the globe, and we are getting good feedbacks from there. Our own study showed that it was as good as Tanner Whitehouse method with less amount of inter and intra-individual variations, cutting down expert time from 5 minutes to 1.4 minutes. And for non-experts, when they were using Tanner Whitehouse, they were taking 8 minutes. It was cut down to 2 minutes. So this is a way in which we can rapidly expedite that. And it was quite accurate for both experts and non-experts. But now people don't even want to do the matching, and they are now talking about AI-based technology. So AI-based tools are already available, but they are available at a high cost at the moment. We are in the process of working on, and Vibha is collaborating with IIT Kanpur to develop a way of AI-based assessment of bone age, which hopefully should be available soon from that perspective. The other scenario, of course, is one function where people get often confused, the pediatricians, is the interpretation of thyroid hormones. So this was the case who presented with lethargy, and FT4 was 6 and TSH was 9. And this child was started on thyroxine and went into shock. So why did you think this happened? So FT4 is low, TSH should be sky high. The TSH was only 9, so this was suggestive that this is most likely a case of central and the cortisol was missed. So we have developed an interpreter which looks into this combination of FT4 and TSH. So if FT4 is low and TSH is above 20, this is primary. Less than 20, this is central. If FT4 is high, TSH is low, that is most likely going into the scenario of thyrotoxicosis. And if TSH is detectable, this is TSH adenoma. Now, this all is there everywhere. We teach about that, but still mistakes were happening. So what we did was that we have developed an interpreter in which one place you can put data, whether it is neonate, child, pregnant adult, non-pregnant adult, you will get interpretation as to whether this is normal, central, or whatever scenario. So had we done that in this case, we would have found it. If you put the data of TSH and FT4, it would have said consider central hypothyroidism. So at least there is a warning which is coming to the person that, okay, this is not something usual. The next step would be to incorporate this right in the lab reports. As soon as the lab reports are coming in the EMR, they should get a trigger that this is likely central hypothyroidism, which we are going to consider in that regards. Thyroid nodule is also a big problem, and often we find that thyroid nodule are missed and they will develop into malignancy. There are scoring systems based on ultrasound and other measures which are available, but still they are not being used in practice. So we have developed a thyroid nodule interpreter which, based upon the TSH level, the ultrasound finding and the size, will tell you whether FNA is required or not. And once you get the FNAC, what is the interpretation? So this is something which we developed on that. So now we have developed tools for growth, puberty, obesity, and bone age. We thought it's time to fuse all of them. And then we came up with a tool with bone age assisted interpretation of growth. Dr. Vibha, please, you can take over from here.
Thank you, sir. So we decided to combine all these four interpreters, and we came up with idea of BIG, that is the bone age assisted interpretation of growth. It is a web-based tool. All these are mobile apps, but this is a web-based tool. And we aim to form a more personalized, integrated point of care tool that could be used by the non-expert, and it would provide the instantaneous guidance. So we aim to develop and validate bone age assisted interpretation of growth, that is BIG. It is a web-based tool for the guidance of assessment of growth and pubertal disorders. It is a very simple tool. What you have to do, you just have to enter the basic anthropometric parameters. As you can see, the height, weight, parents' height, mother's height, date of birth, and you have to select the Steiner staging by comparing these images with the patient's pubertal status. Along with this, you can select the bone, you can give the bone age by selecting the 5 sites as given in this, or you can manually enter the bone age if you can calculate with the bone age X-ray. Then all these, the growth interpreters, the obesity interpreters, the puberty interpreters, both for girls and boys, all these logics have been uploaded in the web tool, and these all informations is processed by these complicated algorithms, and the data and the result is provided within a second. It will present this this pictorial chart where you will get the height age, this weight age, and also the bone age. And this is the whole explained guidance where we get corrected height SDS for bone age, corrected height SDS for bone age, which is more important and very important in classifying the patterns of growth failures. And here you can see it gives the growth interpretation along with the pubertal interpretation and what workup is required in these cases. So it gives a very detailed interpretation, and it is very useful in day-to-day and hectic clinical practice as well. So, and it provides the bone age, and it also provides this BMI chart, because in the previous interpreters, we get the centiles. So for the validation, what we had done, we included the patients who visited our pediatric endocrinology clinic between December 2022 to July 23, and 250 subjects were included in the study. Among 165 were normal, and remaining were endocrine, nutritional, physiological, familial, overweight. And in the puberty group, 85 were normal. Among it, 35 were physiological, 37 were precocious, and 13 were delayed. This is initial data. Now we have added more patients. And the details of all these patients were interpreted by the BIG, and the guidance provided by the BIG was compared with the guidance provided by the pediatric endocrinologist and the non-expert, that is the pediatric trainee and the pediatrician. And all these guidance were compared with the gold standard, which was the final clinical diagnosis and the management. And in the result, what we have seen that BIG has shown a higher concordance score, and with the use of BIG, the concordance rate has increased by 96%, or we can say there is a reduction in discordance by 96%. In the if we see the result, the discordance, the pediatricians, yes, the pediatricians, they have this prescribed more workup where workup was not required, like in around 20.4% cases, while the trainees, they have missed the pathologies in 20% cases. So, and the errors that we classified were normal patients, normal individuals were diagnosed as short or precocious puberty or overdiagnosis of the endocrine etiology. And BIG has provided reassurance or follow-up in 137, that is 54.8% cases, and it has misdiagnosis in only 6 cases. So if we see this 6.5-year-old boy with a growth concern, birth rate was 3.5 kg, full term gestation, and all these we have to provide this give the inputs in the BIG, and the height, weight, BMI, the pubertal status, mother height, father's height, and the bone age. We have given the bone age of 5 years, and if we enter all these details in the BIG web portal, then we can see we will get this detailed interpretation where it says the growth interpretation says that it is AGA and the growth failure is of nutritional pattern. All the baseline investigation that has to be done in this patient, the puberty is absolutely normal and no workup is required for the pubertal assessment. And here you can see the height age, the bone age, and the weight age. So we have a next case of the 16-year-old girl with growth concern. Birth rate was 3.5 kg. She was full term and her height was 142, weight 26. SMR was B5, P5, M1. And when we see the X-ray, all the bones were fused, that the bone age was around 15 years. And when we put all the inputs in the web portal, we found that the growth pattern was a familial kind of short stature along with underweight, and the pubertal status was normal and no workup was required in this case also. So with the use of BIG, we can avoid all the unnecessary workup and it will help in diagnosing more and more accurate cases.
Thanks a lot, Vibha. And Vibha was part of the Young Investigator Award team for the APES in that perspective. So now we've talked about how to diagnose and interpret. Now, once we diagnose, the next step, of course, is to manage a particular case. And management, of course, requires a lot of things, and we find complications if the management is not proper, particularly for DKA. This was a 4-year-old girl with DKA, received fluid and insulin outside, presented with hypokalemia, was given normal saline afterward, insulin was given, and then the child had arrhythmia and a very bad outcome. Now, we are told that diabetes is something which is rare in India, but actually we are missing a large number of cases, and this is something because the management is not being done properly. We did our own study in which we found that despite our written protocol and despite all the information available, there were large number of errors which were happening in management in our ICU, and this resulted in around 68% of preventable hypoglycemia, 42% of hypokalemia, and 66% of dehydration. There is something wrong. And if the first hour treatment is incorrect, you will have all the problems which are persisting. So what we thought, we will use the SPAD algorithm. We developed a complicated algorithm in which we loaded. So based upon that, if you just provide basic data, like what is the sugar, what is the pH, what is the CO2, dehydration, it will give you exactly how much food is to be given, over how much time, how to monitor, and then follow up also every 4 to 6 hours. You put the data and it will tell you what is the further management required. So this tool is very useful for peripheries in places, suppose where there is nothing, which is available easily in that regards. Other problem is how to daily manage insulin. So we have a free clinic in which we give, a lot of people have that, but the problem is that when they do not give proper sick day management, they go into DKA. And one DKA will cost them more than many years actually of their old therapy. So if we can prevent DKA, that is something which is there. So we have tools to decide about insulin bolus. This is already there for physicians for correction dose and diabetes sick day. Now, there have been artificial intelligence based systems which have been developed for deciding the dose of insulin. Hopefully, they will be available soon. So what we have developed now is that we have developed a mobile application, Diabuddy, which is going to guide in terms of the insulin dose based upon glucose, activity, and meal intake. So the biggest problem in India is carbohydrate counting. So what we have done, that we have a large database of around 8,000 Indian food items. All the child has to do is to, when they are deciding a bolus dose, is to feed what they are eating. Then they have to do is to basically tell the sugar, and they will get the right dose for bolus. This is under validation, and hopefully we will be able to come out with results soon on that. Now, all this effort has been recognized. We had multiple awards. For the bone age one, this is Dr. Riddhi, Dr. Sayan for the puberty interpreter, Dr. Alapan presented diabetes interpreter recently in APES. Dr. Dhwani won the first prize for the Young Investigator Award for the DSD interpreter. Dr. Vibha presented our big tool in the SP meeting, APES meeting, the bone age interpreters, thyroid interpreter in the Thyroid Association. There have been multiple presentations, multiple publications have already committed, and there are 3 more publications which are on the way. So hopefully we are trying to develop tools which can guide and help at every level. They are not just for, let's say, pediatricians. They're also going to help in terms of endocrinologists often, because interpreting complicated reports, you don't know the reference range. Sometimes the reference is different. That is also going to be help. And hopefully these things are going to help out in terms of management. At the end, I have to acknowledge the overall the entire team, especially our leaders, Professor PSN Menon and Professor Vardar, who have been involved. All the fellows, till now we have had around 13 fellows in the whole team, and a lot of them are here. 3 of them are here, and a lot of them are in the audience as well. They have been involved. Our tech team is there, and then we have a collaboration with IIT. So this is something which is going on in that regard. So I think we will now head forward to the next talk. Okay, so we will have the next session that will be the bone density. Before that, we'll have the feedback from the chairpersons, please. And any questions on the audience?
Thank you, Anurag sir, for your excellent work on mobile app. It will be really helpful for especially pediatricians and trainees. And it is very impressive to all these works and awards.
Thank you.
Thank you, sir. Any specific reason why it is web-based presentation that?
The big tool requires a lot of inputs actually. So it is difficult on a mobile app. So we have made it specifically web, and this allows the PDF report to be generated.
Okay.
So it's a personalized tool. It will keep the track for the child for all the time.
Okay.
And you can actually give a printed report on that. We are also working on similar personalized nutrition also. We'll talk about that.
Yeah.
The app was, you can't store the data in the app. So data will only be there. You will get for that particular time, but this will keep it for a long time.
Okay. That diabetes app, when it will be available?
Diabetes
it will
app
be very
is
useful
in the
because
current study right away. It's as we talk, it's being validated. Hopefully the result should be out in the next 3 to 6 months, and then we will make it available, because that's a health app being used by a child. That needs to be a proper validation has to be done before we really bring it out.
Yeah. Thank
So,
you, sir.
Yeah. So I think the next session is on BMD. So do we have the presentation? We have one mail or something.
Good morning, everybody. So I think the timer has already started. So we will try to. Bone is a very fascinating topic. I think everybody should be happy to have a copy of this. We can just hand it over to. So and assessment of bone mineral density by DEXA would be a very, very, very useful tool for all of us. So in this, we will try to interpret. I think on a practical note, most of us have access to DEXA machines which don't have a pediatric software, and interpretation of DEXA is very challenging. In different settings. So let us start off. We have 4 cases, and as the presentation is being loaded, we will see how it goes, and we'll start off that way. So case number 1, you can see this is a 17-year-old girl with 3 fragility fractures. 1 fractured tibia at 15 years, 1 at 16 years, both bones forearm at 17 years. So 3 low trauma fractures. All of us know this satisfies the criteria for osteoporosis in children. And looking at the clinical background, there is blue sclera, similar problem in the maternal uncle, etc., etc. You know the diagnosis. This is osteogenesis imperfecta. This child is a menstruating young girl, Stanners 5, height is normal, weight is normal. So you know this is a normal child who has undergone a DEXA scan. And this is the DEXA report you can see. It's a DEXA scan that has been done on GE Luna DPX machine. And you can see the BMD values which is there. And if you see the thank you. So you can see the raw value. The value is, if you can see, TBLH BMD is 0.808. So, and you can see the value is, it's a bone mineral density, but the unit is gram per centimeter square. Look at the unit, it is centimeter square. So you know this is areal bone mineral density. This is not volumetric bone mineral density. We'll go to that case and then come back. Okay, thank you. So I think now the presentation is there, we can start off from. So just a little bit of basics. You know low trauma fractures. You have children like this girl with overt low trauma and lot of chronic diseases with risk of low trauma. Both of them are important. And the diagnostic criteria for pediatric osteoporosis has evolved over time. And you know the criteria. Any single vertebral fracture without local disease, without local trauma is osteoporosis. 2 or more long bone fractures below 10 years, 3 or more long bone fractures about 10 to 19 years is osteoporosis. And lot of systemic diseases, anything you name, you have lot of chronic long-term diseases. The basic problem is you have inflammatory disorders, malignancies, endocrinopathies, muscle disorders, drugs which can cause osteoporosis. And these are the criteria which is there in standard literature. So low bone mineral density is not just based on DEXA, it is a holistic diagnosis. The clinical picture, the clinical context, the fracture history, the growth of the child, and the DEXA scan, everything should be taken into account to make a diagnosis of osteoporosis. And you have specific areas to look at to make a diagnosis. Predominantly, we will be focusing on the total body less head and spine in growing children. And below -2 Z scores, whenever the bone mineral density is below -2 Z score, you make a diagnosis of low bone mass. When it is associated with a significant fracture history, it comes to a diagnosis of osteoporosis. Okay, some quick questions. A 11-month-old child with recurrent fractures, would you do a DEXA scan?
So we would prefer to go for a DEXA scan, but for the age and practical issues with the kid.
Very good. Practical challenges. How would you do it for such a young infant? And there are no norms for a child below 1 year. An anorexia nervosa adolescent with 4 months of amenorrhea, would you do a DEXA scan?
So with anorexia nervosa, we should go with 6 months of amenorrhea.
Excellent. 13-year-old child, 1 fracture phalanx, 1 fracture tibia. Would you do a DEXA scan?
No, sir, because for more than 10 years, we need at least 2 long bone fractures, sir.
Three
long bone fractures.
long. And phalanges, skull, etc. are not included in the diagnosis. A child with ALL on pulse dexamethasone, X-ray shows a fracture, which was done because of osteoporosis, which was done because of low backache. Would you do a DEXA?
So DEXA, we will avoid in the active disease, sir. Actually.
Very good. In an acute fracture, you can defer, but definitely, yes, this qualifies to be labeled as osteoporosis. Celiac disease, well controlled without fractures. Would you do a DEXA?
So we basically need a baseline DEXA to compare, sir. And this patient is having a good catch up without fracture, so there is not indicated, sir.
Very good. And an 8-year-old football player with 2 fractures while playing, would you do a DEXA?
So 2 fractures in a football player. Football is an intense game, sir.
Excellent.
So it's difficult to.
Okay. So the point is, these highlight that the clinical context has to be decided and understood well. Okay. Right. So these are some cases. We will come back to those cases after a while. So norms. There are a lot of studies which are coming up with norms for bone mineral density. This was a very old one which came way back in 2011. Probably I'm not sure about the applicability, but that's the first one which came into the picture. The alphabet study. I think this is the gold standard which has a representation by Indian children living in the United Kingdom. I think this is what is very popularly used even in our work in this. And this is a recent publication in the Indian Pediatrics where IDEXA normative data has been published in a good cohort from 1 to 19 or 19 years. I think this is a very reasonably good sample of nearly about 1,200 children, healthy children. These norms are available. But remember, DEXA interpretation is machine specific. So if your machine is IDEXA, you can definitely consider using these norms. So interpretation of BMD would be look at the machine, look at the table, calculate the LMS value, look at the LMS value, calculate the Z-score, and then go in for interpretation. So this is the first case. Let's come back. This is a 17-year-old child with 3 fragility fractures. So you know this child qualifies to be labeled as osteoporosis, and you need a DEXA before starting treatment. So you do a DEXA scan. This, remember, the luxury of having a pediatric software to give you Z-score is a real luxury for very few centers. Most of the places, it has to be manually done by us and serially done in every visit because of economic reasons, I would say. And this child, the TBLH, that BMD value is said to be 0.808. This is a 17-year-old girl, GE Luna DPX. This is the machine. See, you have fan beam, pencil beam. So you have different technologies which are involved in a generation of the assessment of bone mineral density, and interpretation would be specific to that particular machine. You cannot do one day in a pencil beam and next year you do it in a fan beam and then say it is improving or deteriorating, etc. It has to be done in the same machine. So let us look at this. So what would you be your interpretation? So this is a 17-year-old girl, 17 years girl, healthy girl, otherwise no other issues. The TBLH value is 0.808. So first look at page number 22. Page number 22. TBLH values are there. You look at the figure. white and Asian female. This is an Asian female. The value is 0.808. Look at the x-axis. The age is, this girl is 17 years. Look at the y-axis. Find out 0.808 and see whether it is below -2 standard deviations. It's just below. It's just below. Are you able to make out? It starts off with minus 0.75. There are 4 divisions. It is just below the -2 standard deviation cutoff. So are you able to make a diagnosis of osteoporosis? Are you convinced? Okay. So yes, for a cross-sectional assessment, yes, you have made a diagnosis of low BMD, low bone mass because the Z-score is below, because it's below the 5th percentile, and also there is a significant fracture history, but you need a Z-score. You do need a Z-score. So how would you calculate the Z-score? If the pediatric software is there, it would calculate based on the normative data that has been fed in the machine. So look at page number 10. Look at page number 10. So you have LMS values for that particular machine. Match it for the age and sex. So you are looking at a child who is 17-year-old girl. So this is a Luna DPX machine. So that is why I'm telling you to look at that particular page. You're able to make out? Did you find out that page? Yes. So find out the LMS values. LMS. L value is are you able to find out? Locate it on the table. L value is -0.07. M value is 1.018. S value is 0.07. The formula that is used to calculate the Z-score, the value of BMD is 0.808. The formula to be used is 0.808 divided by 1.018 to the power -0.07 minus 1 divided by L into S, -0.07 into 0.07. Can you try it? You can just use a calculator. It doesn't take much time. We did it just before. It doesn't take much time. You can try it. The value of the BMD is 0.808. The LMS values, I have put it across for you. You can just use your mobile and try to calculate it. Why is the measure BMD 0.808? 0.808 divided by M, that is 1.018 to the power L. L is -0.01. Subtract 1 from that, divided by L divided by S, -0.07 minus 0 and 0.07. To the power, yeah, you'll have to look up your calculator. It allows you to do it. You try it. We did it. You're able to see the formula. Y by M. Y is the 0.808. Answer is given there, -3.3. Something. Y is 0.808, the value you have got here. 0.808. M is the value. M is the value which you looked up the table. To the power L. L is -0.07. Y is the value, the BMD which is there in the first page, 0.808. -1. Divided by -0.07 divided by -0.0 divided by 0.07 divide. Yeah, very good. I think I'm glad. Congratulations, you got it. Minus 3.2. Yeah, so the Z score is minus. I'm so happy you got it. So this just empowers you as a practitioner to arrive at the Z score. These are all non-copyrighted. They're all freely available for you on the net. So that alphabet study is a real fascinating study. It just shows how much of the researchers have worked for ordinary practitioners like us. So what is the now somebody may ask us, what is the reason for doing a Z score calculation? Because anyway, you have used a graph and made a diagnosis of osteoporosis. Why this minus 3.3? See, cross-sectionally, yes, this graph will tell you. But after 1 year, when you want to know whether you want to adjust the dose, continue bisphosphonates, stop bisphosphonates, you really need a recalculation of the Z score to see that minus 3.3 has become minus 2.1, minus 1.9. Second, lot of practical problems are faced by the parents. Can the child be sent for football? Can the child go to school, etc.? Those things, if you want to give a confident answer as a physician, the trend of Z scores is extremely important. Without that, you won't be able to give a confident answer. Okay. So this is an easy case because the child's height was normal, weight was normal. There was no delayed sexual maturation. Except for fracture history, there was no problem. But if you look at children with short stature, I think, remember, in extremes of height, as you know, you're looking at a two-dimensional assessment of a three-dimensional structure, and you make an erroneous interpretation of the DEXA scan, of the bone mineral density, by using a DEXA scan. So researchers have again looked into this, and they have given 3 approaches: a BMAD, which we will see what it is, BMD, Z score adjusted for height, and a Molgard's approach. So BMAD is you convert especially the lumbar spine from a 2-dimensional to 3-dimensional structure, and you arrive at what is called as bone mineral apparent density. It is a size validated, proven, efficient size adjustment technique. Second is Molgard correction, where you adjust the bone, you look at the bones in the perspective of the height, you look at the bone mineral content in the perspective of the height, and then you look at the bone mineral content for the bone area. So it is a validated tool to understand the BMD in small bones, or very big bones as well. And height correction equations. This I have put it in print for you on the 3rd page. These are validated regression equations which are used for you to arrive at correcting the height in short children. So let us try it out in a case. So let's come to the second case, a 14.5-year-old child with low backache. X-ray shows asymptomatic vertebral fractures. DEXA is in hologic. So it's a hologic machine. So now, previously you looked at a machine which was lunar DPX. Now you are going into a hologic machine. The place where I work, we have access to a hologic machine. So let us look at what it tells us. So I've kept it simple. It's just a vertebral fracture. So we are just looking at the lumbar vertebra for this particular case. So now let us look at what it says. Look at page number 20. The BMD that the machine has calculated and given it to you as 0.487. Look at page number 20. Look at page number 20 and plot it. What does it tell you? Page number 20. Page 20, is it below or above? You can probably go around and help them in case they're not able to find. Yeah, it's below. So what is the diagnosis? Low bone mass. In the context of fracture history, you make a diagnosis of low bone mineral density. Okay, very good. So now let us just calculate the Z score for this child as well. Look at page number 9. Look at page number 9. 14.5 years, and try to pick up the LMS values. Try to pick up the LMS values. What is it? What are the LMS values? Page number 9. Are you able to see? Excellent. 1.88, 0.12. Now please put it in the formula and calculate. The BMD is 0.487. The Y value is 0.487. I think here it will be easy because to the power is nothing. 0.487 divided by 0.88 -1. What are you getting? 0. Very good. She's got an answer of -3.7. So the adult machine gave you a BMD Z score of -4.1, but you have used a proper pediatric data and you have made a diagnosis of -3.7, isn't it? Right. So now it doesn't stop with that. Now let us look at this case carefully. Look at the height of this child. This child has a height of -2.07. This child is short. So you are comparing, when you arrive at a Z score of -3.7, you are comparing it with children who have the height closer to the 50th percentile. This child is short for the population. So you will have to compare it with height below the 3rd percentile population. So you have to do a correction. So we learned about 3 methods. What was the first method? BMAT. So let us calculate BMAT. How do you do that? Again, it's mentioned in the manuscript. BMC 1, 2, 3, 4 divided by area 1 to the power 1.5, area 2 to the power 1.5, area 3 to the power 1.5, area 4 to the power of power. Most of the machines give the BMAT by themselves, but I think here we have manually calculated, and I have arrived at the BMAT as 0.15. Okay. So now how do we interpret this BMAT? So now again, look at page number 17. Hologic. Remember, this is, you have to look at for the hologic machine. Page number 17. Look at BMAT. This is a 14.5-year-old girl. 14.5-year-old girl. BMAT is 0.15. How does it stand? Yeah. 14.5. BMAT is 0.15. Girl. Is it below the 5th percentile? So even if you correct for the height, this child has low bone mineral density. Are you convinced? This is very important. Now, let us calculate the Z score for this. Let us calculate the Z score for this BMAT. So look at page number 6. Look at page number 6. The BMAT is 0.15. What are the L, M, and S values for a 14.5-year-old girl? What are the LMS values? Okay, now can we calculate the Z score? The BMAT value is 0.15. 0.15 divided by 0.24 to the power 1 minus 1. BMAT is 0.15. 0.15 divided by 0.24 minus 1 divided by 0.11. How much are you? 3.40. Now look at the numbers very carefully. The machine gave you a Z score value of -4.1. You corrected for the height and compared it, and you got it as -3. This child still has osteoporosis, but look at the quantum. This is very important because after 2 years of bisphosphonate therapy, when you want to understand how the child's BMD is, at that time the child would have probably grown up a little bit more, isn't it? So you definitely will have to understand the concept. So when you compare the improvement in BMD, you always need to have a baseline. Are you convinced? Right. So now let us go to the last method of correction, or the second last method for the regression equation. These are regression equations. You look at page number 3, identify the regression equation. You have regression. This is, again, you look at the quantum of work done by researchers. It is really so fascinating, and we really find ourselves as a tiny drop. How much of work must have gone into development of these regression equations that we are seeing. You need to just feed the height for age Z score. You need to just feed the chronological age, and it will give you a correction factor, and you will have to subtract that correction factor and arrive at that BMD Z score. You are able to understand? This is a girl. You look at those regression equations, it gives you all the values for spine, for total body, less head, for etc. So you'll just have to, for males and females. And probably we have to look at the non-black population. Of course, this is Caucasian. This is not 100% flawless, yes, but the concept is there. You'll have to, probably in the future, we will get Indian regression equations as well. So you fill that and you get this. You understood the concept, and of course, the Moolgard approach. The child was short for the population. When you adjust for the shortness, you find that the bones are not that bad. This is something which should be inbuilt in the software. If you don't have access to that, you cannot manually make this sort of a calculation. Now, look, let's just summarize whatever we have learned. This child has fractures, pathological fractures. You know this is osteoporosis. The machine told the child's BMD Z-score was minus 4.1. But when you used the pediatric age and sex matched references, you understood that the Z-score was minus 3.7. When you used BMAD, you understood the Z-score was minus 3.4. And when you use the correction equations, you understood it was minus 2.8. So just telling you, when you correct for, when you use a pediatric software, when you use a pediatric ethnic reference data, there may be a variation in the interpretation. And when you correct for the height, there may be a much more variation. And this has to be done before embarking upon therapeutic decisions. Did you understand the concept in this case? Thank you. I think this will just go to the last case. I won't, it's there in these sheets itself. So this is the point. When you use it directly, the minus 4.1 told that the BMD Z-score was below the minus 2 SD line. But when you correct it and compare it with kids of the same height, age, and sex, the BMD was slightly better. That's the concept that we are trying to put forth. So which is the ideal correction equation? There is no answer for that. You know, there are pros and cons of all the correction factors. The final word cannot be answered, which is the best method to correct, whether it is Moolgard's approach, whether it is regression equations or BMAT. But BMAT seems to be the most preferred in most of the settings. And the third concept is delayed puberty. The concept of calculating Z-scores remains the same, but the thing is, you'll have to take into factor the bone age as well. This is a 15-year-old girl, case 3. Because of lack of time, I'll just run through it. She's a decision on hormone replacement therapy has to be done. A DEXA was done on hologic. A manual calculation was done both for the chronological age and for the bone age. If you look at the Z-scores, the machine gave you a Z-score was minus 1.7. But when you calculate it for the ethnic references for the chronological age, it was minus 0.9. And when you calculated it for the bone age, it ran up to 0.67. I think you can work up this BMD at your residence or when you have time. So this just proves one fact that if you adjust for height and if you adjust for sexual maturity and if you adjust for bone age, you are going to have a different interpretation. That is very valuable in children with varied endocrine problems. Is it clear? So before we wind up, a rapid set of rapid fire questions for Dr. Sandeep. Yeah, Dr. Sandeep, is PQCT, what is PQCT? Is it superior to DEXA scan?
Yes, sir, it is superior because it gives a 3-dimension volumetric BMD, sir.
Very good. PQCT is a newer tool to assess bone mineral density, very popular emerging diagnostic tool. It is assessment of volumetric bone mineral density, but norms for Indian population is something which remains a question mark. Infants, very young infants between 1 to 4 years, what would be your take on DEXA?
So now since we have new normative data, we can go, but keeping in mind the various factors like the sedation and all other factors we have to take care of.
Very good. Lot of Indian studies, one study from AIMS and one study from Pune has given normative values for young children with, for normal young children. But I think, yes, they are done on very small samples. One is on a pencil beam, one is on a fan beam. So this has to be factored. Probably that can be held as a baseline for comparison and serially you can compare it with it as a gold standard. Will doing X-ray help in osteoporosis?
Sir, X-ray will usually show when there is more than 30% of the bone loss. Secondly, we cannot compare it with the subsequent follow-ups.
Yeah, great, thank you. And is there a significant radiation exposure in DEXA?
Very low, sir, less than a annual exposure of environment, sir.
And how frequently can we repeat a DEXA?
So on treatment annually, sir, at least.
Okay, and DEXA should be, is it machine specific or it can be changed?
It has to be machines specific for better comparison, sir.
Very good. I think, thank you, Dr. Sandeep. I think
Thank you,
the
sir.
concept is DEXA, pediatric bone disorders is like a love bug. You know, once you read it, you fall in love with it, and you understand how fascinating DEXA scan interpretation is all about. Always remember, don't look at the DEXA scan report and take it in the face value. Always see what is the machine. Every piece of the puzzle is very, very important. So always remember, does the fracture history warrant evaluation? Is there an underlying disorder predisposing this child to osteoporosis? After seeing the DEXA scan report, see what is the pediatric software, what is the machine, what is the site, what is the Z score. Every piece of the puzzle is important. Every component of the DEXA scan is very, very important and interpreted judiciously. Height, sexual maturity, and bone age should always be factored and a decision be arrived at. And always remember, osteoporosis diagnosis is a holistic diagnosis, not just seeing a scan and making a diagnosis. Every piece of the puzzle is important. I think is whatever I have provided you is based on the alphabet study. The 4 cases you can try working out and arriving at a diagnosis. And probably when you see your set of patients in your center, you can attempt doing interpretation of the bone mineral density on a manual basis. Thank you. Thank you very much.
Thanks a lot, Dr. Hemchand, for making such a complicated topic very easy. And we all know that BMD is very important, but unfortunately, most machines which are available are with adult softwares. Actually, but if you look at it, if we talk to the hospital, the cost of the pediatric software is not that much. Because I remember that time when we installed, Dr. Rishi would remember, it was like, I think 1 lakh at that point of time. So it is a good investment for the overall time when we really put into it. But yes, this is a good way to really approach on that, and a lot of other issues have come up from there. So Dr. Balaji, Dr. Delhi, and Dr. Rajiv, your comments.
Thank you, Dr. Hemchand has been a teacher. We all saw it now. From a seminar, he converted it to a live workshop. And we could also see the resistance in doing the max also. But somehow we are learning. Thank you, sir. Thank you.
I think if you can put in an Excel, it may be easier also, the macro. And so if you put it in the Excel macro, it will be easy. You can load that on that. But it was a wonderful talk. I'll request Dr. Vibha to kindly give a moment of appreciation to Dr. Hemchand.
Thank you, Sandeep. We, myself and Sandeep, have been cross-checking all these numbers multiple times because we don't want to make a mistake. So I think you can have this as a ready reference and use it in case you want to use it.
So it's a wonderful resource. So again, a big round of applause to Dr. Hemchand. Over to the chairpersons for the next session. Yes. Please go ahead.
Has to be machine specific. But now you said that what Z score we are getting, we again have to calculate it with the height of the patient, with the SMR staging, and with the bone age.
I think height and sexual maturity and bone age are important confounders.
Because
which
these
can
3 parameters you just discussed, whatever Z score they were giving us, we have again to reevaluate that Z score. Although they were having a pediatric software and they have given according to that pediatric software.
You will have to work with the DEXA technician, see what are the data that you are filling into it. Because these DEXA machines, some of them, they do not allow you to go to the next stage without entry of a bone age, without entry of the height.
They don't put any bone age. They, patient, obviously no bone age. Who is putting bone age? Patient is 6 years, they will write 6 years. SMR staging, they will not bother. you know.
Height, weight, you will have to.
Height, weight, I don't know, they are taking, because I'm just asking them to get DEXA scan done. Obviously, I'm not going to, it is not available in my hospital, sending to some other center. So you mean to say the whole exercise which you have just taught us?
I think it is worthwhile to take this effort, because you really understand the bone health of your particular patient in the perspective of the normal population matched for age, sex, height, bone age, sexual maturity. On serial monitoring, when you give some form of therapy and you want to reassess the response to your therapy or give some practical advice, I think the improvement or deterioration in the Z scores will give you a lot of confidence as a clinician to guide
So
the
you
child.
mean to say it will differ? For example, it's a case of osteoporosis because patient is having vertebral fracture because of just tribal trauma, and I know it is a case of osteoporosis. You know, it is a diagnosis is just clinical. You have made a diagnosis. Then Z score by machine has given by minus 4 SD. You put patient on zoledronic acid. After a year, it has come to minus 3 SD, then minus 2. However, if I am calculating, may be different. So you mean to say that management will differ in both these cases?
See, that's such a specific question cannot be answered. But yes, you'll have to look at the overall context. How has been the growth of the child? How has been the fracture frequency? Has it been coming down?
So it means we have to take all these factors in the account.
Yeah.
And can we use the AI also? Because calculation was very difficult. Me and Vijay, Vijay has just run away. We were just struggling. Then I put in Chat GPT, although he has given me the correct answer. The LMS, I just put it because all these calculation was pretty difficult to me because being a doctor, otherwise I would have been an engineer or doing all these things. Anyway, thank you very much.
Thank you.
That's a very, very valid point, Dr. Ravind, you put up. There are 2 points. One is the which reference is that machine using. Most of them are using Western references. So that is one point. So that cannot be extrapolated directly. Second, especially if you have a short child, if you have somebody with celiac disease, with growth hormone deficiency, as Dr. Rahimchand very nicely said, the size is bone is less. BMD will be given more low. So that's why the correction becomes important. So I think suppose this child was given growth hormone and then 1 year later he gained 12 centimeters. So now you will falsely say his bone density has become high if you are not correcting for the height. These cases it will be relevant. From a treatment perspective, suppose somebody has been treated for, let's say, glucocorticoid induced osteoporosis, the height SDS is the same, the puberty is the same. Probably it will not make a huge difference. But ideally, yes. And I think these are very wonderful formulas. You can put it up in the Excel macro and they will give you automatic conversion also. That is something easy way to go forward on that. So we'll thanks a lot, Dr. Hemchand. Again, wonderful. He has been, Dr. Amit was talking about that maybe 10 years ago, Hemchand had done a talk on bone age. And that time he just understood everything and he's using the bone age on that. So that's why we get Hemchand for all these specific, these difficult topics. Hemchand is very good at. Thanks, Hemchand. We'll move to the third session.
Now, the next session is on imaging. I would like to request Dr. Saket sir and Alapun to come onto this stage.
So I have a great pleasure in inviting Dr. Saket Nigam, who is a well-known radiologist at Regency Hospital, Kanpur. He actually established the field of intervention radiology and has been working in that field. And he is our go-to man for a lot of other MRIs for pituitary. We always trouble him and he always has the right answers on that. And this is going to be more of a crosstalk sort of a situation. So because our fellow will talk to the radiologist, and then we will have answers on that based upon case scenarios. So over to Alapan. We'll just share the slide.
Thank you, sir. Good afternoon, everyone. I'm myself, Dr. Alapan. I'm pediatric endocrinology fellow here in Regency in CDER. So in the world of pediatric endocrinology, we are often deal with the lab values, hormonal assays, other clinical algorithms. But there is an important thing that we often complement our clinical diagnosis, that is imaging. So with us, Dr. Saket sir, who is a senior radiologist, and who will be teaching us what to do, when to do, what is the best modality, and how to interpret these images. Okay. So moving on to the first and the most important part that we used to do often regularly in our practice, that is the ultrasound. So I would like to know from the Saket sir, what is the principle of this ultrasound and how it will help to diagnose endocrine scenarios?
Ultrasound is mainly a principle which developed from the sonar principle. What the submarines do, like they send the sound waves and then receive it back. Depending on the density of the structure, they are changed. So with the crystal, the piezoelectric crystals which send the waves, receive them, and the kind of tissue they interact, they send the signal according to it. And those are then converted into, those sound waves are then converted into a electrical image, electrical signals, which are converted into the images. This is the thyroid. One of the commonest scan in endocrinology, the ultrasound is used for thyroid. This is what we do with the linear probe. This is what we do with the curvilinear probe. These are the two. When we have to look something superficial, we take a linear probe. When we have to look something into deep, we take a curvilinear probe. Thyroids, polycystic kidneys, adrenal hemorrhage.
So not as complicated as the principle it is. It is very simple tool, but it requires a lot of expertise to do on that scenario. Moving on to the next one, the CT scan. And I would like to know from the Saket sir the basic principle of the CT scan.
We started with the X-ray scan. What we started with was the X-ray scan, which means radiology. Then it went to tomography. Tomo is cut section. Graphy is the imaging part of the graph. So how it started was, an object was supposedly, we take it as brain. Multiple cuts were taken from the X-ray at different angles, and a combined image was made. That was a tomogram. It didn't last much. Means soon after as the tomogram came, something in 1960s, computer tomography came up. Now, what did the computer tomography there? We have a X-ray tube here and multiple detectors. Previously in tomogram, we had a detector here, we had a probe here, we had a X-ray source here and a detector here. Now we have a multiple array of detectors. So it rotates all around and takes a complete image of the structure of the body, the part to be scanned. The main advantage of CT scan is the bone visualization. There is no other modality which can visualize bone as better as CT scan.
So moving on to the next one.
And one more thing.
Okay, sure.
The calcification part. A case of, which I'm seeing here, it's a case of calcific pancreatitis. You can see multiple dots within the pancreas. Any other modality cannot locate this amounts of calcium in the pancreas.
So moving on to the next one, the MRI, the most commonly and widely used in the imaging tool in cases of endocrine practice. And I would like to know from the Saket sir the basic principle. And
MRI physics is difficult. So basically, hydrogen atoms, our body is made up of hydrogen atoms, the water molecules. So they are oriented differently. Once we put a high magnetic field, when the body is placed in a high magnetic field, they get oriented to a particular direction. Then we remove the magnetic field, they get relaxed. The degree of relaxation of different tissues and different pathologies is different. Depending on them, the images are formed. And this is one of the, when I said bone and calcification for CT, soft tissue is MRI. This is the best modality for soft tissue imaging. Only the cost factors makes it a little difficult. It's costly.
So moving on to the next one, the dynamic MRI, and I would like to know from the Saket sir why we need to do a dynamic MRI, especially in our endocrine practice, and why it is different from the normal MRI that we do in our routine practice.
Whenever you suspect, there are only two, there are multiple, mainly two things. One is liver, the other is sella. Whenever you ask for a scan for a sella to diagnose a microadenoma, it has to be a dynamic scan. Always, please, for every resident out here, please always write a dynamic MRI scan. What is a dynamic scan? Whenever we push an injection in a normal MRI, whenever we give a gadolinium injection, we come out of the room and then scan. That is after 1 minute or 30 seconds or 1 minute when we come out of the room. What happens with dynamic scan is, as soon as we start pushing it up, the nurse, when it starts pushing it up, she raises her hand, I am done. And we start the scans. And it is taken only for a small section. Like when we are taking the sella, we don't image the whole brain. We don't image the whole brain, we only scan the sella with multiple smart curves. 15 seconds, 0 second, 15 seconds, 30 seconds. If you start covering the whole brain, we won't be able to cover it up. Multiple small sections of the sella or liver, whichever we are targeting. Now, what's the importance of it? As soon as we give injection, the normal pituitary gland, in most of the cases, 80% of the cases, the normal pituitary gland enhances first and the nodule enhances later. Like when we say this scan. यार ये pointer कोई और मिल जाएगा क्या? यहाँ पे ये नहीं है. What we do is, when we injected it, a scan taken at 15 seconds, what do we see? We see the whole of the pituitary has enhanced. This non-enhancing area is the nodule. An image taken at 1 second, 1 minute, nothing is visualized. The whole thing is homogeneously enhancing now. So if we would have asked for a normal pituitary, normal sella MRI with contrast, we would have had this image. The dynamic scan made the difference. Another similar case, what we see here, we can see a microadenoma. Later, after 30 seconds or 45 seconds scan, it's homogeneous. So microadenoma always asks for a dynamic scan.
So moving on to the first part of our endocrine practice, the pituitary, the most important gland probably. As you all know, that pituitary remains inside a sella turcica or a bony cage, and the above portion is not covered with bone. And for this pituitary, we can use different modalities like X-ray, CT scan or MRI. But I would like to know from the Saket sir, method that has not been used for pituitary diagnosis, the X-ray of the pituitary, sir, how?
When I started my practice, or when I started my residency practically, sella was the first thing, X-ray sella lateral view was the one thing which came to diagnose acromegaly when the acromegaly was suspected, or any pituitary malformation. MRI was not available at least in my college at that time. CT was there. So a few things had to be kept in mind. The dorsum sella. Any pituitary macroadenoma will cause erosion of it. This is the tuberculum sella, the anteriorly. Posteriorly, it's the dorsum sella. Any mass lesion here, a macroadenoma would first cause erosion of it. There are other causes which cause erosion, like hydrocephalus, etc. But pituitary macroadenoma, for our purpose, is one of the most important things.
So apart from this, other diagnoses like LCH could be important, where we can use X-ray. This is a case of 2-year-old boy with a rash and polyuria, and you can see multiple solitary or punched out lesion that is seen in cases of X-ray skull. Moving on to the CT scan, I would like to know from the Saket sir why CT scan is important in cases of any pituitary diagnosis.
Main importance is the bony destruction it has caused. Like you can see, this is a case of pituitary macroadenoma, which has caused destruction of the dorsum sellae, the partial destruction of the dorsum sellae. The mass lesion has caused erosion of the anterior ethmoid wall of the anterior ethmoid sinus. Sorry, this sphenoid sinus, I'm wrong. The sphenoid sinus and the extension into bilateral paracellular spaces to involve the cavernous sinuses. When you see a bright spot in the anterior pituitary or the posterior pituitary in CT scan, a diagnosis of calcium or hemorrhage. Depending on how dense the lesion is, a diagnosis of pituitary apoplexy can be made. And what is this? A calcification in the pituitary mass. a curvilinear, arc-shaped calcification. The most common differential is a craniopharyngioma.
So moving on to the next modality, the most useful and most widely available modality, the MRI of the hypothalamic pituitary region. We will like to go through some important structures that we can see often in our pituitary imaging, that the hypothalamus remains there, optic chiasm, then the anterior pituitary, the bright spot of the posterior pituitary. If you do a coronal scan, we can see the chiasma.
Last one.
That's okay.
Where is this one? This one. This is the area of the hypothalamus, this whole area. So this is the chiasm which is pointing anteriorly. This is the part, the mammillary bodies. Just wanted to show it up. Okay.
And the coronal section, sir?
Coronal sections, you can see the pituitary, the chiasm, the stalk.
And the pituitary part. So the most important, one of the most important part of the pituitary is the pituitary stalk. We all know that pituitary remains inside the sella and it is hanging above from using a pituitary stalk. So when to diagnose a pituitary stalk thickening, how to do it, sir, and how we used to do in our clinical practice?
One is the dimensions. We can go to 4 to 6 mm. We take it as 4 to 6 mm, 4 mm dimension. In pediatrics, okay, it's slightly lower. The pituitary stalk thickening. In pediatrics cases, this is one of the adult images, I think. Yeah, this is the adult image. You can compare it with the basilar artery. The pituitary stalk is almost equal to the size of the basilar artery. This is the basilar artery. So if it is thicker than this one, thicker than the basilar artery, a diagnosis of stalk thickening can be made. In this case, a contrast enhanced CT MRI, what we see is enhancement in the pituitary stalk, and which is also thickened. Of all the causes, I tell you, of all the causes I have seen till date in pituitary stalk thickening and enhancing, the most common which came in my notice was tuberculosis. The granulomatous hypophysitis has been the most common causes, at least in the adult population, if I'm talking about. I'm not about the pediatric ones. As soon as we start ATT, the patient responds. The CSF is negative. What we find here is enhancing stalk thickening. We start ATT. It most of the time works. Sarcoid, although differentials, but in India, we can take it as tuberculosis as one of the diagnoses.
So other diagnoses like autoimmune hypophysitis, germinoma in cases of pediatric cases are also there. So moving on to our first case, a 18-year-old girl presented with headache to a neurologist, and the neurologist, after examination, he found that there is brisk deep tendon reflexes. He ordered a neuroimaging in this child, and neuroimaging is showing this. So in suspicion of a pituitary mass, the child was referred to us, and we go through the thorough history of this child. We found this child is short, having irregular periods, and we order for the routine investigation, which came normal apart from this thyroid value, which there is TSH was more than 582. Sir, what is your likely interpretation?
Anybody would like to put a guess? Pituitary macroedema, adenoma, or anything else? So it's a pituitary hyperplasia. How do you differentiate between the two? Radiologically. Radiologically, when you see an adenoma, we'll see it in further scans. We will see a lobulated structure. It will form a snowman form structure. What happens with the, sorry, come to the lights. What happens with the, when you see a pituitary hyperplasia, it has a central prominence, something also known as a nipple sign. It has a central prominence. It doesn't have a snowman appearance or a lobulated appearance. That is hyperplasia.
So this case is a case of pituitary hyperplasia due to primary hypothyroidism, a reactive and reversible case, and we usually treat with thyroxine, and gradually this swelling decreases as we follow up this child. Moving on to the next case, a 5-year-old girl.
So no, sir, it would have been more
primary tumor. Had it been a primary tumor,
sir, it would have been a lobulated one. It doesn't form peak like this one. Hyperplasia forms a peak. Its central is prominent,
Okay.
also known as the nipple sign. It is
Now,
of
we
this
were
shape.
trying to appreciate both of us, but somehow we could not. That's why I asked you.
It has a central prominence. Can you show them it? Sure. So it has a central prominence. ऐसे निकला हुआ है.
Yes. Yes, yes. Thank you. It is not as round.
Yes, sir. It is not a lobulated this one. This is a peak type.
Okay. Thank you.
And probably you don't see any separate pituitary as well. So if you see adenoma, it may be just a part and you see other pituitary part also there.
Okay.
Like here you are seeing only the diffuse pituitary. There's nothing else there. Carry on.
So moving on to the next case, a 5-year-old girl child presented with precocious puberty, breast test 2, PB gas test 2. Height was tall girl for her age. And when we do for the gonadotropin levels, it was quite high with estrogen level of 42 and bone age was 9 years. So a diagnosis was central precocious puberty has been made. Being a 5-year-old girl child, we have ordered for a neuroimaging in this case and we found this image. So Dr. Saket sir, I would like to know your diagnosis from this image.
Mass region here, which doesn't get enhanced on the contrast image. Everything is enhancing, the pituitary is enhancing, but this structure is not enhancing. The diagnosis is?
Anyone?
Anyone? Hematoma.
So though a pituitary, though a mass in the brain, we do not need to go for any surgery. We can easily go for the GnRH agonist in that scenario. Moving on to the next case, a 27-year-old boy presented with growth failure, height of 132 centimeter, testicular volume of 2 ml, and pH on 1. So it's a case of a delayed puberty. We found that the thyroid profile, the FT4 level was low and TSH level was normal. And the growth hormone stimulation test is also showing that there was no peak in growth hormone stimulation test with a undetectable gonadotropin level. So these are the images of that child, sir. Sir, your interpretation regarding this state.
One, sir. Thin rim of pituitary, yeah. What do we see here? The thin rim is posteriorly. Only the posterior pituitary is seen. The anterior pituitary is off. One of the things most confusing between, for a radiologist point of view, you people already have a diagnosis. For we have just looked into the images. So you have the clinical points too. So what is the main differentiating is empty cella and a partially empty cella. When we are dealing with partially empty cella, the patient's hormones are almost normal. Most of the time, patient with partial empty cella have normal hormones. Patient comes for some other thing, we diagnose it as partial empty cella also. I don't know the clinical significance, but for here, second image, you can see a thin rim of tissue along the cellular floor. This is the case of partial empty cella. Complete empty cella, a partial empty cella. Usually we don't even give contrast for a partial empty cella because we know it will enhance. This tissue is going to enhance. You can see this tissue which is flattened along the cellular floor. And differentiation. The cella does not enlarge in size. In empty cella, because of the CSF, you may find, depending on the age, the cella enlarges in size. Partial empty cella, you don't find it enlarged cella.
So a diagnosis of multiple pituitary hormone deficiency and probably due to the empty cella syndrome. And we moving on to the next case. A 12-year-old boy presented with polyuria for last 1 year. All the screening tests were normal. We found that the sodium level was 138 while urine osmolarity was 71. So we went for a water deprivation followed by a ABP response test which shown a positive response to ABP. And the imaging is showing this. So anybody could with the diagnosis. Awesome. So sir, would you like to elaborate on this?
Why does posterior pituitary has a bright spot? It is the vasopressin and the neurophysin, I think the precursor of it, the protein part, neurophysin. It has a bright signal on T1 weighted imaging. Whenever we are dealing with a T1 weighted imaging, if you find a bright spot anywhere in the brain or body, if you are seeing a bright spot, what things can be, which are the things which are possible? The commonest is fat. What you see here, the scalp fat. Fat is one thing. Second, blood. Anywhere, when apoplexy or intracranial hemorrhage, you find blood. The third is melanin. And the fourth is posterior pituitary. There is nothing else, no other thing. I mean, maybe foreign bodies may be there, which can appear bright. There may be gadolinium contrast, which appears bright. These are the paramagnetic substances. But routinely, these are the only four things. When you see bright somewhere, where a patient should not have blood or posterior pituitary or fat. So it's a diagnosis that says something abnormal out there.
So can you put some stress also on T2 weighted, because most
T2
of T1 and T2
T2, most of the pathologies are bright.
So
T2, most of the pathologies are bright.
if bright on T2 means pathology, if bright on T1 maybe fat, maybe blood,
Well,
maybe.
T2 almost T2 has a variety of things. T2 has multiple of things which are bright. T2 has multiple of things which are hypo also. But T1 has most of the things hypo, only four things which are bright. So any lesion in the brain also, you see, you know it's blood or a ruptured dermoid.
So a hormone that we can see radiologically, the ABP, as Sarah has excellently mentioned about this. And we move on to the next case, a 6-year-old boy presented with short stature, height of 100 centimeter, with normal screening investigations. The peak growth hormone level after clonidine stimulation was 1.2, while cortisol level was low. So a diagnosis of multiple pituitary hormone deficiency has been done, and we found imaging like this. So your opinion regarding this?
Yes. Something you are not able to see.
See, इसमें तो ICA भी नहीं दिखाई दे रही ठीक से हमें इतनी दूर से में भी
क्या चीज सर?
ICA
ICA ये दोनों हैं.
ये भी नहीं दिखाई दे रही सर
ये cavernous sinus के अंदर these are the two ICAs.
ठीक है, okay.
Any other pathology which we are not, any other normal thing which we are not able to see in pituitary? Stalk. We are not able to see stalk. We are not able to see stalk here. I agree. I should have taken a T2 image. I agree to that part. Yeah, it would be better.
The posterior pituitary, we can see it is a bit above. So a diagnosis of MPSD with PSIS. So pituitary stalk interruption syndrome, we all know that hypoplastic anterior pituitary stalk interruption followed and ectopic posterior pituitary is present.
Again, we could have taken a non-contrast image, because once the pituitary enhances, commenting on absent T,
yes.
I think we could have changed this slide. Yeah.
Moving on to the next case, a 16-year-old child with delayed puberty with a height of 144 centimeter. Gonadotropin levels were undetectable with estrogen level of 10. Prolactin was a bit higher on the 32 and cortisol level was 24, low level for this child. So we got neuroimaging and we found these two. First one is the MRI picture and second one was the CT scan of this child. So anybody with the diagnosis?
T1 hyper, a Rathkes, T1 hyper, or no, T1 hyper, sorry, I'm not a T1 hyper, something which is a bright on CT, a cystic lesion which is bright on CT, seen in the sella or the suprasellar region, is Rathkes cleft cyst. CT scan is confirmatory in it. MRI again has different signals, but usually because of it appears hyper on T2. This is the T2 image, it appears hyper. It appears hypo on T1.
Dear, why CT has been done in this case? Why CT has been done?
Sir,
This was
Why
just a part of sir.
No,
we
no,
didn't,
I mean, there must be some clue that is why
No, no,
you
no, no,
don't
no,
associate.
no. This was the image he brought up with us, MRI only. MRI has a, he did very wrong. I just wanted a normal scan of a patient. We had this one. I took my from my console and just placed it here to show it on CT. And what other things do you see when you see, call it a Rathke's cleft cyst, is a small T2 hypointense nodule in it. A T2 bright structure with a small hypointense nodule suggests or confirms a diagnosis of Rathke's cleft cyst. I just wanted to show how Rathke's cleft cyst appears on CT. It appears bright because of the inspissated secretions within it. It usually don't enhances.
So the diagnosis of Rathke's cyst. Moving on to the next case, a 14-year-old boy with headache. No focal neurodeficit was present, and MRI is showing a mass lesion with a prolactin level more than 80. So often the confusion creates whether it is a cellular lesion versus supracellular lesion. So I would like to know from Saket sir how to differentiate.
Sir, now when it's a pituitary macroadenoma, it has a figure of 8 appearance. It doesn't simply moves out. It first fills up the cella. Rishi sir. It first fills up the CSF, fills up the cella completely. Then it moves out to form a figure of 8 or a snowman's appearance. So that differentiates it from a hyperplasia, sir.
The differentiating point basically for the cellular lesion versus supracellular lesion, that the diabetes insipidus is more commonly an early manifestation of supracellular lesion, while hypopituitarism is more common in cases of cellular lesion, early presentation, and prolactin level is often low in cases of cellular mass, while except prolactinoma, and except it is high in cases of supracellular lesion due to the stalk compression. Moving on to the next case, 18-year-old boy with headache and visual field defect, a prolactin level of 440 with rest of the pituitary hormones were suppressed. And pituitary imaging is showing this image. Anybody with the diagnosis?
There is no cystic part, there is no calcification. It's primarily a cellular mass which is causing extension in supracellular region, having a figure of 8 appearance, extending bilateral paracellular regions to involve the cavernous sinus predominantly on this side. You can see the ICAs. This side it is filled, the mass lesion has filled up. It's a pituitary macroadenoma. Radiologically, it's a pituitary macroadenoma with both supra and paracellular expansion, compression over the optic chiasm. The optic chiasm is somewhere here. It has been displaced superiorly.
So with a prolactin level of 440, this is the most probably diagnosis of macroprolactinoma in this case. Moving on to the next case, a 5-year-old boy presented with polyuria and weight loss, normal screening test. Sodium was 146, but urine osmolarity shows 200. ABP response showing central DI and imaging of this.
Geminoma. Again, a radiological professor. I think I brought my radiology residents are also there. Okay, something for you. How do you differentiate between a germinoma and a pineocytoma or pineoblastoma? What happens is when you see the calcium in the center, with the pituitary gland is engulfed by the germinoma. In a germinoma, the the pineal gland is engulfed by the tumor. When it's a pineocytoma or pineoblastoma, the calcium is scattered everywhere. It has an amorphous form. It just displaces everywhere. It doesn't get confined to this part. When it's confined within the center of the lesion, it is germinoma.
The diagnosis of germinoma in this case causing a central DI. Moving on to the next case, a 26-year-old female child with secondary amenorrhea with other complaints like headache, visual complaints. She is having a polyuria, approximately 7 to 8 liter urine per day, and our neuroimaging is showing this. The next image is CT scan image, and again, anybody with the diagnosis? CT scan is showing something here, and
This time you can give your diagnosis. What you the commonest part is you have both a solid and cystic part. Craniopharyngioma cystic part is very common. You have an arc-shaped calcification, which you can see here. I just took the CT image. MR also you can see a periphery rim, and here you are confirmed that this is a arc-shaped calcification suggesting a craniopharyngioma.
So moving on to the next part of our imaging, the adrenal part, and I would like to know from Saket sir ki what are the modalities that we can use and how it looks like in a US ultrasound, CT scan or MRI.
Adrenal gland for a pediatrics or a newborn, the adrenals are enlarged in size. They can be seen on ultrasounds. But as the patient ages, the adrenal glands are usually not visualized on ultrasounds until and unless some pathology is there. They are situated, the suprarenal glands, so situated above the kidneys, and they have a typical Y-shaped configuration.
So this is the CT scan picture of adrenal gland, and this is
Just last minute. How do you say an adrenal gland is enlarged or small? Whenever it's bulky or it's a normal size adrenal gland. One is you can take a dimensions, but dimensions with the age or the height of the build of the patient is usually changes. So one of the best thing is you have a diaphragm here. This is the diaphragm. These are the two sleeves of diaphragm. You are seeing this part. This is the diaphragm. This is the diaphragm, and this is the adrenal. The adrenal and diaphragm, the limbs of the you can see this one. This is the diaphragm. This is the adrenal limbs. It should not be thicker than the diaphragm. The diaphragm is coming on this side, attaching here. It should not be thicker than the diaphragm. The limbs of the adrenal glands.
So this is normal MRI
Yes, sir?
picture.
But sir, looking adrenal Y-shaped, such a beautiful on ultrasound, I think it is a rarity because on ultrasound it is too difficult to pick up adrenal. That to such a beautiful, well, in transverse, but you have seen the Y-shaped because I have never seen it on ultrasound. Yeah, it is being reflected in his picture.
So moving on to the first case of our adrenal, 1 month old boy presented with failure to thrive with a low sodium and high potassium level with a normal genitalia and normal 17 OHP level. The USG is showing there is no adrenal gland present. So I don't have any image of that actually. So the diagnosis of so it is a diagnosis of congenital adrenal hypoplasia where adrenal glands are not present. 17 OHP level is normal. Moving on to the next case, a 7-year-old boy child with presented with early puberty. SPL length was 7 centimeter with TB 2 cc. The gonadotropic levels were suppressed with testosterone 20, probably suggesting a peripheral cause of precocious puberty, and showing a high DOC level with this imaging.
What do we see here? This is the kidney. This is the kidney and a mass lesion in the suprarenal region. Nothing else adrenal mass. Or something is a hypertrophy of the adrenal.
So this is a case of 11-hydroxylase deficiency, hypertension, peripheral precocious puberty in a boy child. Moving on to the next case, a 7-year-old boy child presented with peripheral precocious puberty. Again, same kind of picture with low 17 OHP and HCG level. And this is the imaging that we have found out. It is not a low 17 OHP, a borderline high 17 OHP was there. So, sir, how would I?
A large mass lesion which has a necrotic areas within it, which has outgrown its blood supply to get necrosed. Carcinoma.
So, as the diagnosis of adrenal carcinoma in this age with peripheral precocious puberty with this level of high testosterone, so you all know that adrenal mass could be benign or.
How do you differentiate between an adrenal, means radiology, again pure radiology? How do we differentiate between an adrenal which is benign or a malignant? Adenoma versus a malignancy. Adenomas usually are highly lipid laden. 70% of the constitution adenomas are lipid predominant. it will show a hypodensity within it, that is fat densities areas. Moreover, they don't, because of the lipid is there, they don't enhance very high. A fat won't enhance. So the enhancement is usually less than 10. If you see what we HU values, there's the Hounsfield value. We have Hounsfield value of each part. Like air, it's minus 1000, bone, it's 1000. So all the rest of the body parts vary between them. Blood is 70, calcium is something around 200. So every part has different. What we have here is when we take attenuation value, pre and post contrast, the difference is not more than 10 in 70% of the adenomas. In the rest 30% also, it's less than 20. While in any other tumor which has not necrosed, a solid tumor, a difference of 40 to 50 is normal. Or even the normal liver, if we say, you can see those two liver, the enhancement difference. This is quite bright.
30 minutes up.
So moving on to the next. 16-year-old female, the next case, severe abdominal pain, constipation, normal BP and electrolyte, and MRI showing a adrenal tumor. Already Sarah has described about this lesion, a myelolipoma, and we'll show a better images of adrenal myelolipoma.
Why I just added this particular image. Myelolipoma best diagnosed on MRI. T1 bright. This is T1. You see bright here. It can be fat or it can be blood. Once you put suppression on it, blood won't get suppressed. This is a suppressed image. You can say the subcutaneous fat has suppressed. So a diagnosis of fat within it, a myelolipoma. So it's not blood. There are only two things which can happen out here.
Moving on to the next case, a 15-year-old female presented with resistant hypertension with increased plasma metanephrine. You all know the diagnosis, the pheochromocytoma. This image has been taken from Sperling textbook of pediatrics. And moving on to the next, the thyroid, a basic part of thyroid, sir, if you like.
Thyroid has a homogeneous ecotexture on ultrasound with a hypoechoic rib. This is a normal thyroids. What we see here is intense vascularity, a diagnosis of thyrotoxicosis in this particular case. Move on. Let's move
So
on.
move on. One or two cases. First case, the day 7 child with a TSH of more than 100, USG showing this, and there was no presence of any thyroid gland in this case. So the diagnosis is thyroid agenesis, and we have to go for a lifelong therapy. Moving on to the next case, a 3-year-old female child presented with difficulty in swallowing, a mass present at the base of the tongue, and the thyroid profile is quite normal. We didn't find any thyroid gland in the USG. But when we go for the thyroid scan, we can find out the bright thyroid is present at the base of the tongue. So the diagnosis is a lingual thyroid, ectopic thyroid that is present. So moving on to the next case, a 7-day-old female child with maternal hypothyroidism, thyroid TSH showing more than 100, repeat showing a bit less, 88. So is it a transient or permanent? That was our question, and we moved on to the imaging part.
A homogeneously enlarged thyroid. That is what we can see.
So we took the history from the mother, and we found that the mother is a known case of hyperthyroidism, taking medicines. So probably a transient phenomena which occurs due to the maternal TSH blocking antibody. Moving on to the next one, 12-year-old female with neck swelling, soft goiter, thyroid profile normal, USG neck showing this.
Commonest thyroid cyst in the thyroid is colloid cyst.
So this is a case of colloid goiter. Moving on to the next one, 18-year-old female with classical symptoms of thyrotoxicosis, a presence of goiter present. We found that the FT4 level was high, though it was not mentioned, it was high, and TSH level was suppressed. And the imaging showing this.
Heterogeneous enhancement of the heterogeneous nature of the ecotexture of the thyroid. You can see multiple areas of nodules, multiple small nodules, and the amount of vascularity known as thyroid inferno. The whole thing burns up. A case of Graves' disease, thyrotoxicosis. This
Toxic nodule was the diagnosis based on this. Moving on to the next one, 25-year-old female with goiter presented with a picture of hypothyroidism, lethargy, weakness with polymenorrhea, and TSH level were 59. And we got this picture. So
again, a thyroid inferno and heterogeneous nature of the thyroid. So this is again a thyroiditis.
So moving on to our last case, a 12-year-old male with neck swelling, a diffuse goiter with bossulated surface. USG is showing this picture, sir.
When you say some punctate hyperintensities, these are tiny calcifications. A tiny calcification, a commonest feature is of papillary carcinoma.
The diagnosis of we made the diagnosis on the basis of FNAC, and it was papillary carcinoma of the thyroid. Thank you. Thank you.
Thank you, Sagat sir, for your lucid and informative lectures, and thank you, Alapan, for your nice presentation.
A very wonderful talk covering the entirety of radiology, especially pituitary, adrenal, thyroid, everything was covered. And I'm sure all of you must have been fascinated. So always when you get the film, just don't read the report, see the image, and then we can discuss with that. I'll request Dr. Rishi to kindly give a memento of appreciation to Dr. Saket, who has been one of our biggest asset in solving so many mysteries. Thanks a lot, Dr. Saket. Thanks, Alapan. I'd like to again thank the chairpersons, Dr. Balaji, Dr. Delhi, and Dr. Rajib Das. Dr. Balaji and Dr. Rajib have already received the mementos, I think. So I'll request Dr. Nimisha to kindly hand a memento to Dr. Delhi. Dr. Delhi has come all the way from Pondicherry. I'll hand over the mic to Dr. Nimisha to start the inaugural program.
Good evening, everyone. We are deeply honored to invite our distinguished dignitaries on the stage for the inauguration program. I would like to welcome Dr. R.N. Chaurasia, sir, Patron Grow Society. Dr. Ravindra Rajput, sir, Secretary SPA. Dr. Rishi Shukla, sir, Endocrinologist, Regency Healthcare. Dr. Anurag Bajpayee, sir, President SPA and Grow Society. And Dr. Yuthika Bajpayee, ma'am, Treasurer, Grow Society on the stage, please.
Please take a seat. Yeah. And I also request Dr. Rishi. Achha, Dr. Rishi is having tea. Don't know worries. Dr. Saurabh is there. Dr. Saurabh Uppal is not there. He is our treasurer. Dr. Vijay Kumar, very senior pediatric endocrinologist. And
I now request our esteemed guests to kindly come forward for the lighting of the ceremonial lamp.
I request Mrs. Rekha Sharma also to kindly come up to the stage.
Now I request Dr. Anurag Bajpayee sir to brief us about the GROW Society and the Advanced Pediatric Endocrinology Symposium program.
At the very offset, I like to thank all of you for coming from across the different parts of the country. And all the dignitaries who are there in the dais to have come here. I like to thank Dr. Rishi. Dr. Rishi, who has been involved with us from long time, right from the beginning. Dr. Chaurasia, who is our patron and working towards pediatric endocrinology. Dr. Chaurasia is the cornerstone as far as pediatrics is concerned in Kanpur. Dr. Vijay Kumar, who has come all the way from Calicut. Dr. Ravindra Kumar, who is the secretary of ISPE. Dr. Yuthika, who is the treasurer of this, and all the guests who have come from across the country and who have been participating in the on-site course now for so many days, and I'm sure it's been tiring. So that is a basic issue. Now, why we started with all that is that when we started, we had only not more than 100 pediatric endocrinologists in the country, and the burden was huge. So there were thousands of cases of pediatric endocrinology were there, but then there were very few to cater them. So what we thought that there was a need somehow to have bridge in between them to develop special interest in pediatricians and physicians, and then they can really match and manage the overall case. Since then, there have been definite improvements which have happened, and now so many new things have happened. But this was what when I started in 2007 in that regards. So we started off and we realized that awareness was a major problem. So whenever we talk of a disorder, we know that there are three things: awareness, accessibility, and affordability. Now, everybody says it's affordability, especially when it comes to hormones. They are expensive, more difficult to get, but it's actually awareness. So we started with pediatricians' awareness. This was in 2012, and we can see many of the people who are still there. Many of the faculty is the same from that time. It's continuing from there. And then we conducted a number of programs across the country. We developed 6 modules, which are still the base of many of our courses. Till now, we have conducted 120 workshops, 15 practical pediatric endocrine courses across the country, and 5 advanced pediatric endocrine symposium. This is the 6th one that we conducted. So this was the first one in 2017, and we can see Dr. Hemchand here. So he was there right away at that point of time. Again, Dr. Hemchand talked about bone age. We discussed about this. Then there was a couple of year gap because of COVID. Since then, we have been having annual events every year. Every time we have got very good people coming from across the country. Now, after conducting so many programs, what we realize that once you conduct the program, people forget about that. Whatever you teach, they will just don't remember. And it is too much effort to go in terms of money, in terms of time, manpower, and everything. So we thought of using the power of social media to highlight that, and we set up this channel, which is now one of the largest channels as far as pediatric endocrinology is concerned. And it has been viewed across the globe. It provides, there are over 400 videos and everything on pediatric endocrinology. So anything and everything, it's available there. We then thought of in terms of systematic approach in terms of pediatric endocrinology learning. So we started off with our fellowship program in 2017. And as Dr. Ravindra was saying, that we are now recognized by the National Board of Examination. And it was in fact a dream for the last 10, 15 years that we were pushing for pediatric endocrinology fellowships, which were not available from NB. And now finally the dream has come, and BJ Vadia and our center is now the 2 centers which are going to provide training in pediatric endocrinology. Now, what we realize that even physical fellowships, many people who have done training and who are in practice or doing some medical education, they are unable to really come in for 2 years because it's very difficult for them to join and leave the practice. So we started with online learning in terms of medi classes followed by books. And then we thought if you want to empower people to develop applications so that they can use, and we discussed some of the innovations just recently. Our fellowship started in 2017, and both of them are here. Dr. Neha and Dr. Chetan, they started with the first program. Dr. Riddhi and Dr. Sajali was also there in the second group. Dr. Pratik is currently in UK. Dr. Sayan and Dr. Naveen are now pursuing DM courses in PGI Chandigarh and at AIMS Delhi. Dr. Manoj was here. As we can see, Dr. Vibha has joined with us as a consultant. Dhwani is currently in Patna, so we have people across the country. And we have got Dr. Alapan and Sandeep who are still there, who are working. and Dr. Nimisha is the last one to join. So we've got 13 people who have joined, and hopefully very soon we will have the National Board Accredited Fellowship, which will start here. Our learning portal provides validated tools for evaluation, assessment, and pediatric endocrinology, including a full fellowship in pediatric endocrinology. So we launched around 3 years ago fellowship program in pediatric endocrinology, which was a very, I would say, a tough program. It has 2-year learning. Every 2 months, there are online exams. There are continuously lectures every week. Every 6 months, there is a 5 days program in which they come, they see a lot of patients, we discuss with them, and then this program happens. So there are 4 sessions which are there. We have developed a mobile application, which in fact is the most downloaded endocrinology app, and we talked about publications there. We are developing other tools like personalized intelligent EMR, which will help guide evaluation and management of pediatric endocrine disorders. We have developed BIG, the bone age assisted interpretation of growth, which recently Dr. Vibha was just talking about how it will help assess puberty, growth, bone age, and obesity at one single click. You will be able to get all the results. We are developing a personalized expert for nutrition, in which it will analyze all your meal items in terms of a lot of input which we don't know about glycemic load, all the other aspects. And then it will also provide, based upon the requirement, the recommended 7-day allowance. So automatic diet chart will come in for patients, which is coming up. We have already developed the Diabuddy app, which provides insulin dose guidance based upon glucose as well as carbohydrate counting, which is there inbuilt in the app. And this is being validated right away. So hopefully next time we would be launching it in a proper, for a general use in that perspective. We have got number of books, basic, pediatric, and advanced. So we have tried to do a lot in this area over the last decade or so. Many of our efforts have been recognized. As I showed, Dr. Riddhi won the award for Best Bone Age Presentation at Kolkata, Dr. Sayan for Puberty Interpreter, Dr. Alapan at APES, Dr. Dhwani won the Kaichi Kida Award for the DSD Interpreter, Bone Age Assisted Interpretation for Growth, Dr. Vibha. Then also, so all of presentations have been there. There are a number of publications coming out of our tools, which have been validated and developed. So our fellowship in pediatric endocrinology, as I said, is a comprehensive one. There are over 100 modules, approximately 1,000 hours of videos that people have to watch. Pre-test, post-test, live lectures are there. There are on-site 4 visits with hands-on exposure. Assessments are done bi-monthly, 6-monthly, and an exit exam. And then there are other opportunities to collaborate in terms of research, learning, and teaching. So we have had multiple, we have now 9 on-site courses. This happens every 6 months. Started from 2019. To date, we have had all these on-site courses, and we can see many of the places which are here also. So this was the last course which was done just in June 25. And all of them, I think most of them are here. And this was the extensive program in which we had 300 patients coming from growth, puberty, thyroid, electrolyte, all the disorders, and they were discussed in intensive fashion, and discussion was there. So till now, 48 people have been awarded fellowships in this program. Ongoing, 72 people are doing fellowship. There are many other courses also where people are enrolled. That number goes to thousands or something. 12 nationalities have been enrolled on that. So this is a way in which we are trying to increase the number of people who are working towards pediatric endocrinology. So I think at that point of time, I'll request Dr. Ravindra to share his views and the vision about pediatric endocrinology. Dr. Ravindra is the secretary of ISPE.
Thank you, Dr. Anurag sir, and dignitaries on the dais and off the dais. Already Anurag sir has way presented what is the future of pediatric endocrine, because you know this house full of delegates in pediatric endocrinology, CMEs, it was a rarity couple of years back. Now so many people, they are being interested in it. And as Dr. Anurag is now heading our organization, Indian Society for Pediatric and Adolescent Endocrinology. So along with him, we have the same vision, and he's already projected his vision. He has taught so many people. He has started ENB Pediatric Endocrinology, which is really a fabulous job. I'm amazed of such a small city as a Kanpur, but still, you know, only he has been given, while so many has applied for that. So he deserves a very big applause for that. And obviously, he is still, by online teaching, offline teaching, and on-site teaching. So many people have been trained in pediatric endocrinology because burden is too much. Type 1 diabetes, especially, which has been otherwise not being treated as per the standard regime, and so many other disorders. Thank you, sir. Thank you very much.
Uh,
Now I request Dr. Vijay Jaiswal sir to kindly come. Vijay Kumar. To Vijay Kumar sir to kindly come and say a few to say a few words.
Dr. Vijay Kumar is a close friend for so many years. He is in Calicut and he's doing a lot of work in type 1 diabetes in children and so many other work, Dr. Vijay. I think it's the first time you've come here.
Yeah, physically.
Yes.
First of all, my sincere gratitude to Dr. Anurag for inviting me for this session. Actually, we know each other for almost 2 decades. Actually, we started in Calicut. I think in Kerala, I think I was the first person to start pediatric endocrinology. Then it was a very few persons were there who were really interested in pediatric endocrinology. Now the things are changed, and I have to congratulate Dr. Anurag for this mammoth task. Lot of people are getting trained, and now we have good manpower, so we can manage lot of things. Actually, in Kerala, where I am coming from, I was the one, then came Riaz and so many people, and now many people are there from Kerala. And thanks to Dr. Anurag, many are did their fellowship from Kerala. And we are going as a team, and that is why all these our programs like Vitai program and all going with full swing. And now I am very happy that 2 fellows are here from my own institution. I think that will help me. And when I go out, they will be the torch bearers of our programs in Kerala. And I am coming here for the first time, but I was there as in a virtual platforms during our COVID seasons. I was a faculty 1 or 2 times. I was there actually. So all the best for all the program. Thank you so much once again for inviting me for this program. Thank you.
Thank you, Dr. Vijay. I'll request Dr. Saurabh, who is our dynamic treasurer, to kindly share his vision and thoughts. Dr. Saurabh has been here in all the programs pretty much, except for one, I think.
It has been a privilege to be here. It's a learning journey for all of us. All I want to say is that the leadership that you have shown over the years for pediatric endocrinology has not only helped the field to grow, it has created an institution in CDR itself, Mediclasses itself, and it's a proud moment that FNB has also stamped it. So our best wishes for more innovations and keep leading the way forward.
Thanks, Saurabh. I'll request Dr. Rishi, who has been long the source of inspiration and he has been part of our team for such a long time, to share a few words.
I think first of all, compliment Dr. Anurag for starting fellowship in national board. So again, compliments to him. He has been after this for a good number of years. So good thing has happened in our department. And he exactly joined 1.5 decades. I have finished my endocrinology. So, and he has finished more than 1.5. So it is 31, 32 years I've done endocrinology in the city. I lived a very nice and a fulfilled life. But certain things were missing, and one thing was my teaching. I was missing teaching. Basically, somehow I don't know how come I came into practice. Somehow you were also forced to come, but I was missing teaching, and that my last desire was fulfilled by you. So thank you very much. And my residues, whatever I worked on last 30 years, were done with his help and with the help of his fellows. So I could do so many good things. So keep growing, and I'll be happy to see you grow even more and more and more. And I'll keep clapping, sometimes from here and sometimes from up. Thank you.
Thank you, Dr. Rishi. I'll request Dr. Arun Chaurasia, who is the patron of Grow Society. In 2013, we set up Grow Society, which is a non-governmental force towards improving quality of life of children with diabetes. We have multiple support groups for diabetes, thyroid, celiac. We do a lot of programs. So Dr. Chaurasia is the behind all that, and he is a great encourager in that regards.
धन्यवाद डॉक्टर अनुराग। सर्वप्रथम तो मैं मंच पे आसीन सभी विभूतियों को नमस्कार करता हूँ। ग्रो सोसाइटी को इस लेवल पर देखकर जो खुशी मुझे हो रही है मैं शब्दों में व्यक्त नहीं कर सकता हूँ। इसकी शुरुआत के साथ और इसका ये सफ़र जो यहाँ तक पहुँचा है, ये कानपुर के लिए बहुत ही गौरव की बात है। जहाँ तक इसके जो मुख्य कर्ता हैं डॉक्टर अनुराग, आप सभी उनको बहुत बेहतर तरीके से जानते हैं। मैं भी उनको कुछ मायनों में जो मेरी जानकारी है मैं कहना चाहता हूँ आप सबके सामने। मरीजों के लिए एक बहुत ही बेहतरीन डॉक्टर, बहुत ही बढ़िया ओरेटर, बहुत ही बढ़िया टीचर और साथ में सोसाइटी के प्रति जो जागरूकता एक डॉक्टर के अंदर होनी चाहिए वो मौजूद है डॉक्टर साहब के पास। डॉक्टर अनुराग के ऊपर ईश्वर की महती कृपा है। ये जब विदेश छोड़कर कानपुर आए और कानपुर में बसे, फतेहपुर के बेसिकली रहने वाले हैं। मुझे बहुत शुरू में इनके घर जाने का और इनके माता पिता से मिलने का सौभाग्य प्राप्त रहा है और माता पिता के आशीर्वाद से आज ये और आप लोगों के प्यार से जिस मुकाम पर ये खड़े हैं, जिसमें हर किसी का दिल ये चाहता है कि हम इनको धन्यवाद दें और इनकी पहचान करें। जहाँ तक इनके सहयोगी डॉक्टर ऋषि शुक्ला का सवाल है, ये कानपुर के मेरी नज़र में पहले एंडोक्राइनोलॉजिस्ट हैं। मैं यहाँ पर आपको याद दिलाना चाहता हूँ कि 1975 में मैंने जब कैरियर शुरू किया था तो एंडोक्राइनोलॉजी को एक बहुत ही कॉम्प्लेक्स और कॉम्प्लिकेटेड सब्जेक्ट समझा जाता था और काफ़ी हद तक वो नेग्लेक्टेड भी रहता था क्योंकि बहुत से लोग उसमें नहीं दिलचस्पी लेते थे। लेकिन एक ऐसे सब्जेक्ट को इन ऊंचाइयों तक पहुंचाना, कानपुर से देश में ही नहीं पूरी दुनिया में इसको पहुंचा देने का जो कार्य डॉक्टर अनुराग और इनकी टीम ने किया है वो काबिले तारीफ है। मैं आप सब लोग बहुत दूर दूर से आए हैं, सबका हार्दिक स्वागत और अभिनंदन करता हूं। बहुमूल्य समय आपने दिया है, आशा करता हूं कि आप यहाँ से लाभान्वित होकर के जाएंगे और आप सबका मैं ग्रो इंडिया सोसाइटी की ओर से इस 6वें एडवांस पीडियाट्रिक एंडोक्राइनोलॉजी सिंपोजियम में आभार व्यक्त करता हूं। धन्यवाद।
I request Dr. Yutika and Dr. Rishi to kindly come up for certificates. And Dr. Yutika, vote of thanks we'll give at the end. So, and Prashant ji and let's start calling the delegates. Yeah. Aye. So we start with the certification, the awards.
I would like to call Dr. Sandeep.
So Dr. Sandeep. So Dr. Sandeep has finished fellowship with us. And he'll be moving to Maharashtra. So you can.
Thank you very much, sir. So it was my pleasure to be here. I would like to thank Dr. Anurag sir. I have been associated with him for almost like 3 to 4 years. Initially, I did a online fellowship with sir, and now I have physically completed fellowship with sir. So, sir, thank you very much for guiding me in all aspects, sir. Secondly, I would like to thank you, Rishi sir, for guiding us about various aspects about adult endocrinology in the OPD and very interesting Saturday clinic, sir. Ma'am, I would like to thank you also, ma'am, for providing all the guidances. And last but not the least, I would like to thank my all colleagues, my senior, Dr. Vibha ma'am, Dr. Alapan, Dr. Nimisha, Prashant ji, Aditya bhaiya, Hariom bhaiya, and Nikhil. Thank you very much. Thank you very much, sir.
Yeah, so I would like to call Dr. Alappan for the certification. Please come on the
So
stage.
Dr. Halappan has not yet finished, but he wants to go get the certificate. Fear of missing out. But he has finished his 2 years already. Yeah. So
Thank you. So I'll keep my talk for the later part when I finish it. So now for now, right now, thank you, Anurag sir, for your continuous guidance in this. I have left my home 2 years back, leaving behind my parents and my family. But I think few months after this, I'll be happy having this fellowship award again. And I'd like to thank Rishi sir for his excellent guidance in adult diabetes and other endocrinology part. The Saturday part, Sandeep sir has already talked about. I'll add on the Wednesday part that I'll want to continue after this when Sandeep sir leave. And Itika ma'am, thank you so much for your guidance. I'd like to thank my senior, Dr. Bibha ma'am, always my support in every aspect of my life. And Dr. Sandeep sir, my big brother, and Dr. Nimisa, thank you so much. Entire the CDR team, Dr. Adit Bhaiya, Hariom Bhaiya, Prasant ji, Nikhil Bhaiya, and everyone who was working with us. My parents and my wife, who are being there always behind me. My wife, she's not here today. I want to see her here. I'm missing her badly right now. Thank you so much.
Now I would like to call Dr. Anil Kumar. He's completed advanced diploma course. Dr.
Dr.
Anil
Anil
Kumar.
Kumar is there?
Dr. Anil Kumar, if he is available, so please come on the stage.
I think he's not there.
Yeah. So next, I would like to call Dr. Bhusan Thorat. He's completed his fellowship. So please come on the stage.
So Dr. Bhushan is from Amravati, and he is a very dynamic pediatrician, and he showed very much interest in pediatric endocrinology.
It is a moment of immense gratitude for me to receive this fellowship under the mentorship of Dr. Anurag Bajpayee sir. I'm very much thankful to sir for this entire journey. And I also done a short observership in Regency Hospital. And I'm grateful for the sir for this opportunity. And I'm thankful to all fellows who also guides me through some calls and messages regarding some cases. Thank you, sir.
Now I would like to call Dr. Amit Kumar from Patna. He has completed his fellowship. Please come on the stage.
Thank you, sir, for this opportunity. Only one line, we all actually want to say that whatever we know in endocrinology, it's because of sir and his team. So thank you, sir.
Thank you.
So now I would like to call Dr. Kiran Kudlikar, sir.
Dr.
Dr.
Kiran
Kiran
is
has
from
completed
Aurangabad.
his fellowship, yes.
हाँ, संभाजी नगर.
Thank you, sir, for giving me this token of appreciation. Previously, I thought endocrinology was very complex and rare subject, but sir has made this module very beautiful and in a very simple manner. That's why I got this certificate. So, thank you.
Thank you. Thank you, Doctor.
So now Dr. Virendra Verma. Dr. Virendra Verma has completed his fellowship. Please come on the stage.
नहीं stylish भी लगती है. वो जो है. Dr. V.
Thank you, sir. I don't have much words, but for me, pediatric endocrinology was kind of a very difficult thing. It is constant supervision of sir. It is, I think, for 15 years I am in touch with sir. So that has advanced into this thing. And I'll be in touch with you, sir. And your guidance will always be there, I think.
Yeah, Dr. Tanmay Verma. Dr. Tanmay. Dr. Tanmay has completed his fellowship. Yes,
Dr.
please come on
Tanmay
the
is from
stage.
SMS Jaipur, and
Yeah.
he's a very dynamic person. He's an assistant professor there.
I would like to thank whole CDR team for this token of gratitude. Pediatric endocrinology was like 4 or 5 topics for me in last 4 or 5 years. But 2 years ago in 2023, when I came here for the first time, then the dynamicity of Anurag sir's excellence, his knowledge, and the depth of pediatric endocrinology, what I saw here, it took me on a path that I have to be in this way only, and I have to be sir's student, and I have to be in the part of pediatric endocrinology. I mean, if I'll be a knowledge appreciation of 10 to 20% of Anurag sir, then it will be a great pleasure for Jaipur people if I work from them. So thank you so much, sir, for teaching me the each and everything about pediatric endo. I'll try to be a good endocrinologist in future. Thank you so much.
Thank you, Doctor.
So now I would like to call all the participants and delegates who came in the on-site visit. So for the certification of participation. So Dr. Meena Singh Patel. हाँ, Dr. Prachi, next. Dr. Prachi Singh. Dr. Prachi. Dr. Raj Lakshmi from Patna. Next, Dr. Ravi Sood, sir. Dr. Ravi Sood, sir, if he is available, please come on the stage. Dr. Susil Kumar, sir. Dr. Susil Kumar, sir.
From Patna. He is in Nalanda Medical College.
Dr. Umesh Kumar, sir. Dr. Umesh Kumar. Dr. C.G. Delhi Kumar, sir. Dr. C.G. Delhi Kumar, sir. Dr. Delhi Kumar, sir. Next. Dr. Anil Kumar, KM. Dr. Anil Kumar, KM, sir.
So Dr. Anil Kumar is from Palaghat.
Dr. Aslam PK from Kozhikode. Dr. Rajesh TV, sir. Dr. Rajesh TV, sir, from Kozhikode. Dr. Rupali Rokde from Nagpur. Dr. Gayas Ahmed, sir, from Bahraich. Dr. Mamta Lalwani, ma'am. Dr. Meena Sanjay Singh,
So Dr.
Asian
Mamta
Hospital.
is from Raipur. Thank you.
Dr. Padmini, ma'am. Dr. Padmini, ma'am. Yes.
Dr. Padmini is from Vijayawada.
Dr. Priyanka Shukla from Riva. Dr. Priyanka Shukla, ma'am.
Thank you.
Dr. Swapnil Shukla, ma'am.
Riva. Priyanka Shukla. Thank you.
Dr. Swapnil.
Dr. Swapnil is from Lucknow.
Dr. Virendra Verma.
So he has been
हो गए.
done.
Dr. Gayatri Pridarshani.
Dr. Gayatri is from Chennai.
Dr. Fauzia. Dr. Fauzia from Lucknow.
Dr. Fauzia was our resident.
Dr. Rahul, sir.
Thank you. So Dr. Rahul Mupari is an endocrinologist from Amravati. Thank you.
Dr. Balaji. Dr. Balaji.
Dr. Balaji is the professor of pediatrics at SRM, Chennai.
Dr. Anil Kumar. Dr. Anil Kumar. Dr. Arushi Rai from Jodhpur. Dr. Arushi Rai. That's complete.
Okay, all have done. Dr. Anamika?
Dr.
Anamika.
Dr. Anamika Shah. Dr. Anamika.
Give any. Dr. Anamika is from Dhaka. They will give you, yeah, later. Okay. Yeah, they'll give. So now I'll request Dr. Rishi to please be there in the dais and Dr. Yutika for the vote of thanks.
Thank you, Dr. Anurag. First of all, I'd like to thank all the senior dignitaries, all the consultants here, all the delegates who have come from far and wide and around the country. And for the last 3 days, it was a very intensive program, right from the morning till the evening, sitting at CDR, seeing hundreds of patients. I hope you had a really good experience. And I would also like to thank the whole team of Regency CDR, all our fellows, and all the other staff who have done everything to make this program successful. Welcome to everyone, and thanks a lot for being here. Thank you.
So I'll now ask everybody to please stand up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंधु गुजरात मराठा द्राविड़ उत्कल बंग विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंग तब शुभ नामे जागे तब शुभ आशीष मांगे गाए तब जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
So I'll thank all of you for coming from all the parts of country, and thanks all the dignitaries in the dais, Dr. Ravindra, Dr. Vijay, Dr. Saurabh, Dr. Rishi, Dr. R. Chaurasia, Dr. Yutika. We are right on time. We are 3 minutes actually ahead of our schedule. So we are going fine. We'll have a quick break for tea, and then maybe you can grab the tea and we'll start the session in 5 to 10 minutes from here. Yeah. Thank you. Acha, एक minute. I request mementos to be given to the to Dr. Chaurasia. अभी अभी करेंगे. So we'll be starting our next session. And for this session, to chair the session, I'd like to invite Dr. A.C. Agarwal. Dr. A.C. Agarwal, who is a senior physician in Kanpur, to kindly join the stage. I'll also request Dr. Vivek Saxena, a very senior pediatrician from Kanpur, to join the stage. And Dr. Aisha. Dr. Aisha, please come up to join the stage. So this session is about glucose disorder. Then we are going to cover 6 important topics of glucose disorder. And there is a slight change in the schedule. So we'll be starting with Dr. Chetan Dave, who is a pediatric endocrinologist at Rajkot now. And he will be talking about type 2 diabetes. So Dr. Chetan. Yeah, Dr. Chetan is coming. So type 2 diabetes, we know there has been a dramatic change in terms of type 2 diabetes. I'll request Dr. Agrawal to kindly elaborate as to how things have changed in adolescents about type 2 diabetes in particular.
Thank you, Dr. Anurag. And firstly, heartiest congratulations for a exponentially growing growth society. And that is what is happening to diabetes in adolescence. Earlier, we didn't have patients, younger age group patients with diabetes. But now type 2 diabetes, early onset type 2 diabetes in adolescence is fairly common because of the increasing incidence of obesity. The scenario is very rapidly changing. Initially, in the very neonatal group or early childhood, they have neonatal diabetes or type 1 diabetes, but type 2 diabetes is also diagnosed very early sometimes. So the scenario is changing, and so is the management. So the approach to life, these are lifestyle diseases, and we have to really be very empathetic for the patient and the family once we diagnose diabetes in the adolescence. So let us see what are the challenges faced by the youth in diabetes. Dr. Chetan.
Thank you, sir. Very good evening. Now I'm finishing the inning. I also opened the inning as well. When I made my first presentation, that was for our presentation, we used a sentence that obesity is a ticking time bomb way back in 2017. But now let me tell you that this time bomb has been exploded. And as a result of the time bomb, we are seeing more of an adolescent type 2 that are below 18 years, which has got many more other metabolic abnormalities as well. So this type 2 diabetes among adolescents is very unique. It is very different from that adult type 2 diabetes. And why? Because there is very rapid beta cell function deterioration in adolescent as compared to those who are adult having type 2 diabetes. Average adult loses approximately 6 to 7% of their beta cells every year, while adolescent with type 2 diabetes loses approximately 17 to 21% beta cell every year, leading to earlier initiation of the insulin and earlier requirement of second line therapy. Also, they have greater insulin resistance. That's why significant reduction in insulin sensitivity is seen, requiring early second line therapy and ultimately insulin. They are having very poor response of diabetic medications, and they are more and rapid development of metabolic complications, those who are having macrovascular as well as microvascular type. And strangely, the adolescent prediabetes as well as type 2 diabetes have more preponderance to female as compared to male, which is reverse as far as adult type 2 diabetes is concerned. Of course, before type 2 diabetes, there is pre-diabetes. And the definition is same, whether it is type 2, type 1 or pre-diabetes. That is fasting blood sugar between 100 to 120, HbA1c of 5.7 to 6.4, and 2-hour OGT test between 140 to 199. If this is present, it is called as pre-diabetes. And why it is important? If you intervene at pre-diabetes level, it can be reversed and it will become normal for many more years. And the research says that youth with pre-diabetic HbA1c have low short-term rates of progression towards type 2 diabetes if you rightly act. So if you make patients losing weight, if you make patient losing BMI of approximately 10 to 12%, this pre-diabetes will be reversed and there will be no type 2 diabetes if the patient maintains same lifestyle. Lifestyle changes are the most important part of management of obesity, pre-diabetes or whether type 2 diabetes. And there are very insufficient data for the use of metformin or any other therapy including insulin for the management of pre-diabetes. So pre-diabetes, lifestyle, and with this lifestyle change, you can reverse your pre-diabetes and your risk towards going into type 2 diabetes. Again, diagnosis of type 2 diabetes, patients having any osmotic symptoms with the fasting blood sugar of more than or equal to 126, postprandial OGT more than 200, any random blood sugar more than or equal to 200 and HbA1c of more than 6.5 will be categorized to diabetes, that is any diabetes. If osmotic symptoms are present, that confirms the diagnosis of type 2. And if there are no symptoms, then any of the two investigational criteria will also qualify for the definition of type 2 diabetes. Now, as we know that any sugar more than 200, any HbA1c is 6.5, but there are subtle difference between type 2 and other forms of diabetes. So if the patient is obese, if there are signs of insulin resistance like acanthosis, tags, there are family history of type 2 diabetes, there is associated metabolic complications like dyslipidemia, obesity, obstructive sleep apnea, PCO-like picture, and negative pancreatic antibody. So these all are suggestive of type 2 diabetes. But if the patient is non-obese, at presentation, presence of decay, cerebral edema, pre-pubertal age less than 10 years, these are all in favor of type 1 diabetes. Of course, the presence of autoantibody is suggestive of type 1 diabetes. And if you don't have obesity, if you are pre-pubertal, if you have family history of each generation having typical type of diabetes and fasting blood sugar which is remaining stable between 100 to 150 with okay management of lifestyle, then possibly you are dealing with the genetic, that is monogenic form of diabetes. So just by examining the patient whether patient is obese or not, just by asking family history of diabetes, just by ordering simple test, you can probably going towards the diagnosis of type 2, type 1 or monogenic diabetes. So how to approach type 2 diabetes? That HbA1c should be more than 6.5, BMI should be more than 85th centile, age should be more than 10, preferably puberty should be going on, and absence of cerebral edema. If these all are present, then you should think of managing this patient as type 2 and you can treat as type 2 diabetes with the oral medications. If these all are no, you should be firstly treating as type 1, that is, you should be initiating insulin, and later on if antibodies and all are negative, then you can reconsider the diagnosis of type 2 and then switch over to oral therapy if autoantibodies is negative and patient having very low insulin requirement on the subsequent management. So this all is a preliminary guidelines to start insulin or to start the metformin, which is the first line therapy. So type 2 diabetes, speaking about the management, most important is lifestyle. It should be started from day one of diagnosis regarding the lifestyle management. Medicine comes as a second line, or you can say step 2 of the management of type 2 diabetes. And last option is bariatric surgery, which we'll be talking on the subsequent slides. So lifestyle, as we say, there are 4 pillars of lifestyle: diet, exercise, sleep, and screen time. So dietary modification includes decrease in the caloric intake. You should be avoiding raw carbohydrate like cold drinks, like maida, like bakery items, like chips and all, fried foods, processed food. What we advise as a doctor is that you should avoid those food which are made in factory, bakery, or those who are packed outside your house. So these 3 types of food should be avoided totally. And you can also cut down the portion size by 20% to 25% initially. After that, minimum 60 minutes of moderate to vigorous amount of exercise, including walking, including swimming, including running, jogging, maybe skipping. This all should be considered as minimum 60 minutes. Morning exercise is not necessary. Patient can do this exercise at any point of time with 2 to 3 hours of empty stomach. Third is most important is optimizing sleep routine. As an adolescent, this patient must be sleeping minimum of 8 hours of continuous sleep, because we know that the cortisol cycle is associated with sleep. So whenever patient remains awake till wet, patient's cortisol also remains awake. And this cortisol will lead to gastritis, will lead to hypertension, will lead to fluid retention, and the all complications of obesity. So sleep routine should be optimized. Ideally, we should be sleeping around 10, maximum 11 p.m. and we should be waking up around 6 to 7 a.m. That should be the norm. And also we should be screening those patients for the drugs, tobacco, maybe vaping and alcohol consumption, because we know that the type 2 diabetes is a disease of rich people. So there are chances that those obese patients might have one of these complications, or you can say comorbidities, which can lead to other metabolic complications as well. Talking to initial pharmacotherapy, if HbA1c is stable, there are no signs suggestive of diabetic ketoacidosis. Metformin is the preferred drug. We should be starting metformin by giving 500 milligram OD. We can go up to 2 grams per day. If the HbA1c is more than 8.5 and there is no ketoacidosis, we should start basal insulin, preferably in a lower dose, 0.3 to 0.4 unit per kg per day, along with metformin, starting with the 1 gram, a bit higher dose initially. And if there is decay or hyperosmolar state, we can straight away going with the admission, IV insulin followed by proper basal bolus regimen, and when the patient stabilizes, we should shifting towards the metformin trial. Of course, lifestyle intervention should be starting from the day one. So lifestyle is the first line of therapy. Monitoring therapy, routine stable patient don't require SMBG or self-monitoring of blood glucose every day, but those patients who are on insulin, who are having a symptom suggestive of hypo or hyperglycemia, those who are acutely ill leading to sugar fluctuations, and those who are poorly controlled, these all patients, we should be advising them to go for the self monitoring of blood glucose, and the targets are that fasting blood sugar should be between 70 to 110 and postprandial blood glucose should be between 70 to 140. We should be having target of less than 6.5. This target is a bit stricter as compared to type 1 diabetes, because there are very less chance of hypoglycemia in type 2 as compared to type 1, because type 1 are already on 4 or 5 shots of insulin. So that's why a tighter control is recommended in type 2 diabetes. Also, more vigilant dietary restriction are advocated in type 2 diabetes as compared to type 1 diabetes. And HbA1c should be screened routinely every 3 months. So after first month of therapy, you get the pancreatic autoantibody done, because there are many cases of obese type 1 diabetics are also there. So all pancreatic autoantibodies are advised. If they turn out to be negative and obese diabetes is there, so they are confirmed as type 2 diabetes, and we should be continuing with the metformin. We can try tapering insulin as well. If autoantibody is positive, definitely you should continue insulin therapy, and patient should be advised and explained regarding the prognosis of this type 2 diabetes. During the subsequent management of the type 2 diabetes, if the patient is good, having good dietary control, doing good exercise, having less of a screen time, if patient sleeps routinely with a normal good sleep, and the patient's HbA1c is controlled and remaining below 6.5, then we can continue single monotherapy, that is metformin, and the dose will depend on the sugar chart and HbA1c reading subsequently. But if the patient is having poor control, having bad lifestyle, having more of a carbs eating, then we should be reviewing this patient for addition of another therapy. 5-6 years down the line, we had only one second line therapy, that was the insulin. But nowadays there are few oral medications which have been approved by the ISPED and FDA, and so now patient has good oral therapy options as well. So second line therapy is indicated whenever persistent elevation of HbA1c. If weight management is desirable, suppose patient is having BMI of more than 95th centile with type 2 diabetes, then additional therapy who can help on weight management as well as those who don't want to go for the insulin shots and those who have needle phobia or reservations about needle based treatment. So in this, we should offer second line oral medical therapy for type 2 diabetes. Of course, basal insulin is advisable whenever HbA1c is going be above 8.5%. And in those patients who have already compromised renal or cardiovascular comorbidities, then also few second line drugs which are helpful in preventing these cardiovascular complications are advisable. So starting with the first group of second line therapy, that is GLP-1 analog, that is glucagon-like peptide receptor analog. This GLP-1 directly affects on the stomach motility, increase insulin via incretin pathways. And this wonder drug helps you slow down your stomach motility. Therefore, your stomach will feel that I am full. That's why appetite will be decreased. Your already glucose content and overall food intake will be reduced. Thereby, you have good amount of sugar control in terms of ingestion, as well as this may lead to weight loss. So liraglutide is the first agent. It has been approved for 10 years and above. It has been given as subcutaneous once daily, start with the 0.6 milligram. And the same molecule is approved for the obesity management as well, about 12 years of age, in which higher dose of 3 milligram per day is advisable. And this is the study showing the effective HbA1c reduction as well as effective weight reduction. But there are side effects of gastrointestinal things like fullness, gastritis, maybe vomiting, maybe feeling of uneasiness and all. So this is the common side effect of all GLP-1, but this was the first liraglutide molecule in the name of Victoza, which was approved for the type 2 diabetes. Another is exenatide, which is not available in India, but it is also injectable, but it is a weekly injection. 2 milligram weekly injection in the name of Buderion is available in America as well as Europe. Another Indian agent, or you can say the agent available in India is dulaglutide. We know the name of Trulicity. It is a weekly agent. It should be started with 0.75, that is minimal dose, and depending on the ability of the patient to contain the side effect as well as desired glucose control, we can extremely go up to 1.5 mg weekly as tolerated. So this is another study in which it was associated with significant reduction of HbA1c. But in pediatric study, these all agents are not that superior for the weight management or weight loss as compared to these agents. These are more helpful in weight loss in adults. But still, for the glucose part, these are good thing. Another oral GLP-1 which is not approved till yet, but it is also available, semaglutide, and it has been used off-label for the management of type 2 diabetes as well as obesity in adolescents. Coming to second group, that is SGLT2 inhibitor. It is responsible for causing renal glycosuria by decreasing the renal threshold through the glucose level, and hence they are excreting glucose in urine and thereby maintaining your blood glucose level. Empagliflozin is the first. It is available in the name of Jardiance, starting with the 10 mg daily, can go up to 25 mg per day depending on the you can say response. And it has been shown to reduce HbA1c by 0.84% in a randomized control trial. But again, this agent is also helpful in reducing the weight in adults. In adults, it can reduce weight up to 5 to 10%, but in pediatric or adolescent trial, there is no difference in weight control versus placebo as far as the concern. But there is another advantage of long-term cardioprotective action which is absorbed in the adults. So this might help in pediatric as well, because we know that the type 2 diabetes is having more rapid complication as far as the adolescent group is concerned. So definitely this can be useful as a protection of the cardiovascular status, but there is a risk of euglycemic decay or ketosis because of the renal glycosuria. So this should be kept in mind while you put the patient on SGLT2 inhibitor. Another is dapagliflozin. It is another agent of the same group, that is SGLT2 inhibitor. It is used as oral once a day, 5 milligram. You can go up to 10 milligram. And of course, 0.75% of mean HbA1c reduction has been observed with the use of this dapagliflozin. Again, same effect is same, side effect is same. Beware of euglycemic decay and ketosis. Another medicine which are already approved in adult, these are under trial for the pediatric use, but in pediatric trials still now they are not as effective and p-value is not significant. And this includes DPP-4 inhibitors and thiazolidinones. But maybe in future more studies are needed to establish these agents' role in the adolescent type 2. So maybe in future they might get approved after the current ongoing study finishes. But still now we have metformin, insulin, and then second line therapy in form of GLP-1 analog as well as SGLT2 inhibitor. The last option is bariatric surgery. Bariatric surgery is going to have a big role because the super obese culture in India is also rising. When I was doing fellowship in UK and all, the role of bariatric surgery was very much, because bariatric surgery can reverse your all metabolic complications including diabetes, hypertension, dyslipidemia, fatty liver, all. So if you want a quick result, bariatric surgery is the option. It has been approved about 12 years of age with a BMI of more than 35 kilogram per meter square or 120% of the 95th percentile, whichever is the lower. And there are many studies quoting the advantages of bariatric surgery over conventional therapies. So this paper was published in the Lancet and it has got significant declines as far as the remission of type 2 as well as remission of other metabolic complications occur. But of course, in bariatric surgery, we are having decrease in the volume of stomach as well as we might cut the intestine. So there are occurrence of mild anemia, low vitamin B12 as well as hyperparathyroidism. So this complication should be looked for. Those who undergo bariatric surgery has to keep some kind of lifestyle throughout their life because they cannot eat much and there are more chances of GI side effects like gastritis, like vomiting. These all can occur during any phase of life. But overall, bariatric surgery is advisable under proper surgery, proper surgeon and proper center where all facilities are available, including endocrinologists as well as good nursing care as well. Coming to the complication screening of type 2 diabetes, the people say that the type 2 diabetes may present with complication. While in type 1, it may take 10, 12, 15 years. So each and every complication should be screened at the time of diagnosis, whether it is retinopathy, neuropathy, or nephropathy. This should be screened at the time of diagnosis as well as annually. Other complication which might present is PCOD, obstructive sleep apnea, non-alcoholic fatty liver disease, as well as dyslipidemia. So these all should be screened frequently. If any complication is present, then you should be going to thoroughly evaluate that particular complication every 3 to 6 monthly as well. Mental health screening should be done for all. We know that in India there is not much of a mental health issue, but still there are chances that this patient might be having a case of bulimia nervosa or any other psychological disorder, which might lead to obesity and type 2 diabetes. So mental screening, mental support, psychological evaluation is must for all the patients who are having these metabolic complications or type 2 diabetes. And do not forget to record blood pressure. Hypertension, in our own study, we found that is the most common and most important complications of obesity / type 2 diabetes. So each and every visit should be recorded with the blood pressure, and blood pressure should be evaluated in terms of their age and height match criteria that this patient is having hypertension or not. So summarizing my talk, type 2 diabetes is more dangerous than type 1 diabetes as compared in the adolescent age group. Lifestyle is the most important first therapy. Metformin is still a first line drug. Second line drug are now available and approved about 10 years of age apart from insulin, and complication screening at the timely interval should be done. So with this, I would like to end my talk and thank you very much.
Thanks a lot, Chetan, for a wonderful talk. And type 2 diabetes is now increasing so rapidly that we presented recently our paper on 4-year follow-up of type 2 diabetes. Chetan was also part of that paper. And we found that the type 2 diabetes in children is very rapidly progressive. The need for second drug is much quicker. They lose 10 to 15% of beta cell per year as compared to adults who lose 7 to 8%. So it's a very aggressive thing. Best to prevent it, but treatment options are not there. One message that I like to add is that in our study, what we found that if a child is started on insulin, if we want to remove insulin, the best way is to give a GLP-1 receptor analog. If you do not give it, metformin alone may not be good enough. Thanks a lot, Chetan.
These two are approved, sir, by the FDA, and they are there in the ISPED guidelines of 2024, about 10 years. Empagliflozin and dapagliflozin.
So, comments from the panel?
No questions, but very good talk. And with the rapid rise of obesity and metabolic syndromes, we also happen to see the reports which are quite shocking for us, that the children now are having 15, 16, 17 years having developed type 2 diabetes, very high HbA1c levels. So yes, this is a problem and we all must tackle, and as a pediatrician it is our duty to actually see them, because we follow them up and they are gradually and increasing in weight. And this is all because of lifestyle management, and whatever they are eating is quite bad. Thank you.
Yeah, Dr. Aisha.
Very nice. Thank you, Chetan, for covering such an extensive topic so precisely in 20 minutes. And it was very nicely. Just one thing I would like to add: before going for bariatric surgery, one has to ensure that the child's full growth potential has been achieved. So though it is very easy, but everything has to be taken, like you should not rush for bariatric surgery. So lifestyle modification remains the cornerstone of treatment, is the first modality, and you have to wait for at least 6 months before deciding upon that.
Thank you, Dr. Aisha. We'll now invite Dr. Saurabh Uppal, who gave a wonderful talk in the morning about the insulin pump. And now we are going to call him to talk on a topic which is close to his heart: nutrition in type 1 diabetes.
Thank you, Dr. Vajpayee. And the first time I came to APES in 2017, I think it was my talk on carb counting only, carbohydrate counting, and I'm happy to be here discussing the update. Yes, here, yeah. So this is a very good session, one of my favorite sessions in all the meetings we go, because this makes us work very hard. You have to just present the update, how things have changed in the last 2 years. So the role of nutrition in type 1 diabetes is now beyond just carbohydrate counting. Nutrition is now viewed as a dynamic pillar of modern type 1 care. And because we have more technologies, we can see the effect of nutrition by CGM. It is now integration with technologies that transforms our nutritional strategies. We have totally transformed the way we look at foods after we see what they do on a CGM. The evidence now supports comprehensive approaches beyond carb counting. So we'll be discussing the current standard of care and guideline updates, research advances in macronutrients that have happened in the last 2 years, and emerging dietary patterns and microbiome research. And how do they apply clinically? Now, the core principles, this is 2024 is right, I'm sorry for the typological mistake. So how do the guideline updates compare? Over the years, we've been seeing that the percentage of food recommended as carbohydrates has been reducing. It was 55 to 60, then came 50. The ISPAT 2024 guidelines say 45% to 50% of carbs, 15 to 20% proteins, and 30 to 35% fat. But the ADA guidelines have now removed the percentage thing from it. There is no fixation in number of calories, no fixation of percentages, individualized approach, and focus on quality over quantity. That is where the nutrition is going from here. ISPAT guidelines tell us that the medical nutrition should focus to maintain growth trajectory. So there is no fixation on the type of diet, but whatever suits the child, whatever maintains good growth and development is recommended. And the ADA guidelines have now come that nutrition should be able to also contribute to keep the time in range, which is more than 70%. Because they cater to more of a Western population, reduction of cardiometabolic risk has also come up in the new guidelines, because now there are trials which have compared low carb diet with normal diet, Mediterranean diet with low carb diet, Mediterranean diet with keto, and all those things. So, and also both of the guidelines converge in individualization. That means not all patients who come to your clinic should just get one ready-made paper of diabetic diet, and one paper should go to everyone. That it is not going to work at all. And they're going to keep coming back to you with bad control. Individualization is needed. You have to see their readings and then cater your nutrition advice accordingly. Technology integration is very important. As we'll see, one concept has come, and family-centered collaborative approaches.
Carb counting still remains the bedrock of management, and without offering good carb counting, it is very difficult to achieve good results in pediatric diabetes beyond the first 1 year of diagnosis. Because in the first 1 year, they have residual insulin, they have C-peptide, so almost every approach would work. In fact, almost every insulin would work. But once their beta cells wear off, you need to be having your nutritional advice really tailor-made. One can use advanced methods like food weighing, like exact grams, as we tell them. There are digital tracking apps like carbs and cals and all. So you can take a photograph and AI will tell you how many carbs are there in that. Nutrition database lookup, just like this Healthify is coming up in India. It's a very crude managed method, but still better than nothing. You can even use simple methods like the plate method or the carb exchanges, which is the easiest way to teach somebody who's not very well educated, or even hand portion sizing. Whereas the advanced methods have higher accuracy and the simple methods have less accuracy, but they are sufficient for stable patterns. That means if you have a family which is disciplined with their meals almost every day, crude methods of carb counting also work well. There has been a study by Australian group Carmel Smart and group which have shown that you don't need to be very intelligent in carb counting. You just need to be consistent in carb counting. You may be doing it wrong, but if you do the same mistake every day, then your insulin dose titration works well and you achieve a reasonable outcome. That is where we are reaching. So the huge noise that you have to, all your patients have to be very good in carb counting, that's not true. They have to be very consistent in carb counting. Because these advanced methods have high mental workload and risk of burnout, whereas simple methods work quite well. Advanced carb counting, which means counting grams, is good for people who are on automatic insulin delivery, those who are following tight glycemic targets, and very intelligent and motivated families. Simple methods are good initially, newly diagnosed, young children, and those who have limited resources. In fact, I would recommend you start always with a simple method at diagnosis because the burden is too much on the family. And slowly you see their comprehension level and then you graduate to an advanced method. So it has to be individualized. And you have to also assess how much burden is being put on the family. Easier said than done. These are all the practical issues that come in when nutrition advice has to be followed. But I've seen over the years a lot of people talking about these burdens and looking at it as an excuse that we cannot put our patients on carb counting. This is absolutely not true. It has been seen in multiple studies throughout the world that if you have a language which is friendly to the family and you can take them forward, it is easy to teach them simple methods of carb counting, especially the carbohydrate exchanges. And without exchanges, it is very difficult to achieve good control over the long term. Food confusion affects most of the T1D families. Why I've added is because these are the things that have been coming up in multiple commentaries which have been coming, that still food confusion affects, and healthy food knowledge correlates with lower HbA1c directly. The more intelligent they are, the better their control is. Picky eating is reported in up to 65% of small children, and it correlates with increased family mealtime stress. That is why simple methods work better in small children. So what are the research updates in the last 2 years? Now, the impact of fat and protein, because now most of the children in the West are on CGM, the impact of fat and protein can be seen, and their diet is high in fat and protein rather than Indian diet. Indian diet is a carbohydrate predominant diet. Western diet now has more fat and protein. Now, this is a standard meal with 40 grams of carbs, where your glucose will rise up to 1 hour, and then after 2 hours, it will start coming down. But with a meal which has high fat and protein with it, the glucose keeps going up, reaches a peak up at 3 hours, and then comes back down over 6 hours. This in between this time, this phase, which is in between the 3 and 4 hours, this really impacts the HbA1c, and this also impacts the time in range. So something has to be done for it. Now, this is called a pizza effect because the classic example is like a non-vegetarian pizza, which has a lot of protein in it and also has cheese in it, which increases the fat content. So it's called the pizza effect, the effect of fat and protein. Now, why this happens is because fat is delaying the gastric emptying by 30 to 50 minutes, and protein takes time to digest. So it contributes to the late postprandial hyperglycemia, 3 to 5 hours. So in such kind of meals, the insulin need is increased by 25 to 35%. So if the child is younger, then this might not be a huge change. But if it's an adolescent eating a full double zinger burger, it contributes to a large amount of increase to the dose. And so you have to use fat protein counting in such meals. Fat protein counting is using converting the amount of fat and protein into FPUs, fat protein units. Now, one fat protein units is 100 kilocalories from fat or protein. And if we do not bolus for large meals, it leads to extended hyperglycemia 3 to 5 hours after the meal. So how do you calculate an FPU? FPUs have been around for a long time. In fact, I did discuss FPUs in 2017 also. But we were not very aggressive with FPU counting because CGM was not all pervasive. Now, because CGM is all pervasive and because of the rise of these low carb diets in the last 5 years, low carb, keto, Mediterranean, this has now come into vogue more. So you add the grams. So this is how you calculate an FPU. Grams of fat plus half of the grams of protein and you divide it by 10. It's called the Penkoska formula. Now, for example, if you have a meal which has 60 gram carbs, 20 grams of protein and 25 grams of fat, this converts into 3.5 fat protein units. Now remember, one fat protein units is equal to 10 carbs. So if your insulin carb ratio is 1:10, 3.5 FPUs will take 3.5 units extra because one fat protein unit is equal to 10 carbohydrates. So if you are dosing standard with and as we discussed in the morning, there is a prolonged bolus, especially if you are on a pump, you give your standard carbohydrate insulin. Why is this coming? You give the insulin for carbs standard and then 3.5 units over 4 hours in the pump. Or if you are only on MDI, in such a situation, the patient can be instructed that whenever you eat this kind of food, then you have to give an additional 3.5 units about 1.5 to 2 hours after you take your food bolus for that burger. Now, individual assessment is essential. Now, we've tried to do this. It is very, very complicated. In fact, I don't have time to go into detail. Very recent, there is a advice, I can't say guideline, which says that if the one FPU is in the meal, then your bolus has to be extended by 1 hour, 2 FPUs, 2 hours, 3 FPUs, 3 hours, and 5 FPUs by 5 hours. Fortunately, Indian children do not take such a high diet in fat and protein, so we don't need to bother much. In fact, up to 1.5 to 2 FPUs, it doesn't even matter because if your meal has more than 30 grams, 40 grams protein, you need to worry about the protein. And more than 40 grams protein is very difficult to have in the Indian scenario. Now, because automatic insulin delivery systems are there, we need to have updated advice on how to optimize your meal input for AID success. So we saw a case in the morning where the child was not announcing meals. Now, what happens is that the pump takes data from the CGM and then meal announcement. That means the user tells what the user is eating. The algorithm processes the data and tells the insulin pump. Insulin pump gives the insulin. In this scenario, if you announce the meal 15 to 20 minutes before the bolus, if there is high glycemic index meal, it improves the post-meal excursions by 32%. And meal announcement accuracy. So plus minus 20% carb accuracy maintains algorithm performance. So you have to be consistent. If you're making a mistake, make the same mistake every day. So algorithm performance is also significantly influenced by meal composition. High fat protein meals required extended insulin delivery, as I said. So the key takeaways for those on automated insulin delivery is they should pre-bolus for high glycemic foods 15 to 20 minutes before eating. Algorithm input precision will help their algorithm to perform better. For complex meals, fat protein units should be used. And consistent timing of meals. So children who are on advanced hybrid closed loops, if they have erratic schedules, they do worse than if they have the same schedules. That is because the pump calculates insulin sensitivity every 3 days. And the insulin sensitivity in the pump is calculated by time of the day. So if the time of the day of meal is consistent, the pump, because it is a blind machine, so the pump will just see the time of the day and change insulin sensitivity. If children are having meals at the same time, their results are better. And carb intake for activity, duration, and intensity. If adjusted gives a better outcome. We don't have time to go into exercise, but there are ways where you can reduce your bolus depending on your carbs, depending on how long you are going to exercise and how much your exercise is having a gap from your meal intake. So these improve outcomes. Now, for a few years, keto was great. Everybody was talking about intermittent fasting keto. Now, more and more people, it's being standardized. It's the low carb diet which is now in vogue. As I would say, maybe next 2 years something else is in vogue. So low carb diet, how does it fare? Overall, compared to a standard diet, the time in range is slightly more. Time above range is less, and there is no difference in time below range with a low carb diet. So low carb diet means less than 30% of carbs. It is very easy to do. Even you can do a low carb diet very easily. So low carb diet has an HbA1c reduction of minus 0.4%. So most of you know that you have to have it at least at 0.5% for it to be called very significant and to approve it as an intervention. So it's still not there, but it reduces glucose variability as shown by an increase in time in range and reduced time above range. There is no decay episode. A little increase in mild ketonemia is there. There is no impact on height velocity of children, unlike keto diet, which affects height velocity of children. And lipid profiles, it doesn't really increase. The lipid profile doesn't go haywire if you reduce your carbs from the diet and replace the equal number of calories from fats and proteins. So these approaches may benefit some patients, but require careful monitoring. And it is all individual. So a lot of what happens is that some children, they really respond well. Their parents have those CGM graphs which are flat, and they put it in WhatsApp groups and everybody comes to us. How can we have such a graph? Not every child will have a flat graph with a low carb diet, but some children will have a flat graph and they can continue with it. Now, a very common discussion these days in most nutrition is the Mediterranean diet. Now, Mediterranean diet is showing promise. Now, what is Mediterranean diet? It's not a fancy diet like a keto diet. It is a generous serving of fruits, vegetables, whole grains, and olive oil. Little less contribution fish, legumes, nuts, and yogurt. Then progressively reducing the poultry, egg, cheese, red meat, sweets. Why is it important? Is because Mediterranean diet is not predominantly non-vegetarian diet. Lot of people around the world can adopt it, even different cultures. Overall, the evidence in type 1 is that there are improved lipid profiles, 15% increase in HDL, 12% decrease in LDL, and reduced oxidative stress and inflammatory markers, 8% improvement in post-meal excursions. Why is it catching fancy? Is because a lot of children with type 1 in Europe and US are becoming obese. And obesity is giving a double burden of cardiovascular risk in those who already have type 1 diabetes, and it is causing its own problems. So these kind of diets are now coming up. Now, how does Mediterranean compare with a low carb diet? Because low carb diet is what we understand, Mediterranean is what we are understanding. Overall, both of them worked. Both of them worked. The time in range increase was plus to 12% for Mediterranean diet, and hyperglycemia reduction was minus 10% for low carb diet. It doesn't mean that low carb is inferior or Mediterranean superior. Both of them really worked very well. The delta was a little more for Mediterranean diet, but both of them were significant. There was no hypoglycemia risk comparison in both groups. Now, we don't need to discuss keto. We've discussed it many times over. Just to recapitulate, keto has high risk of euglycemic decay and hyperlipidemia, developmental risk because growth velocity of children has been impacted in certain studies. And there's a psychosocial risk also because children really hate being in ketosis and children really hate the taste of keto diet. So it leads to a lot of behavioral problems in children who are on keto. So keto should actually not be recommended. We were never so forthcoming against keto. We used to say, okay, if it's suiting you, continue. But now more and more confidence is coming that we should say children should not be subjected to it. People, they want to do it themselves, they can go ahead. So overall, I think I've discussed this. First line approach for most patients is still the standard and balanced diet. There is no diet which replaces it. Consider low carb diet in those who are motivated and those who are on automatic insulin delivery. Mediterranean diet is beneficial for families with cardiovascular risk factors. You have an obese child, strong families to have cardiovascular risk factor, encourage them to go towards a Mediterranean diet. And plant-based, I think I have no experience and children hate plant-based diets. Now, a new therapeutic target is emerging in type 1, as is emerging in almost everything. You go to an oncology conference, you go to a rheumatology conference, you go to a gastroenterology. Anyway, this is microbiome. So everybody is talking about a microbiome. I don't know whether it is association or actual causation, but it's catching a lot of fancy. Research has identified gut dysbiosis in children with type 1. Now, the mindset behind it is that because dietary intake changes gut microbiome, it affects the glucose control. How? Fiber-rich foods increase beneficial bacteria, short-chain fatty acid production improves insulin sensitivity, processed foods promote inflammatory bacteria, and lipopolysaccharide release increases insulin resistance. So this is the mindset behind the impact of microbiome on glucose control. Now, children with type 1 have distinct microbial signatures with lower diversity and fewer beneficial bacteria that produce short-chain fatty acids. Now, this has been shown in some studies. And these bacteria influence glycemic control through multiple pathways. So pathways are the same. Any conference you go, they'll talk about inflammatory modulation, permeability regulation, and production of metabolites. So it is showing an effect in glycemic variability also. Now, what are the microbiome supporting foods? Fiber, prebiotics, and probiotics. You all know, you are all in pediatrics, so I don't need to tell you. The research is ongoing, but consensus supports fiber-rich diet for glycemic stability for various reasons, and fiber also reduces the net carbs in your diet. So that means the carbs work lesser if your diet is high in fiber. This is independent of this microbiome point. Diversity correlates with fewer excursions, and specific stain recommendations are still premature. But evidence favors diverse intake. So 30 plus grams per day dietary fiber from diverse sources in children above 12 years of age. Regular consumption of prebiotic foods. And anytime when these children are on long-term antibiotics, one should consider a microbiome impact and maybe replace after these children have been treated. Targeted therapies are likely within 3 to 5, or I would say 5 to 10 years. So, but the clinical pearl is you should not get carried away with these things. You recommend food first approach before any supplements, before prescribing any probiotics. Track the glycemic response to dietary changes. Easy to do because children have CGM now, and consider individual tolerance and clinical preferences. Now, the foods which are making news these days are resistant starch, green bananas, cool potatoes, all these, the tide pool and these what do you call? Okay. So these groups, the online forums, they are awash with discussion of these. Cinnamon at 1 to 3 grams that shows modest postprandial glycemic benefits. Fermented fruits, foods like curd, kanji, kimchi, and all those things. Then berries and dark fruits. Allulose is a new sweetener which doesn't affect the blood glucose, and still it is not as having an aftertaste like stevia, or doesn't taste bad like the routine ones, and spirulina and chlorella. Now, what we know is now, so we had this fad of vitamin D, that high dose supplementation prevents type 1 diabetes onset in siblings of children who have type 1, improves glycemic control. There is no impact of type 1 incidence by high vitamin D. And the modest benefit only with those with severe documented deficiency for maybe other reasons. There is no benefit in sufficient levels on glycemic control.
Dr. Saurabh, please conclude.
Okay. So omega-3 fatty acids, only those who have cardiovascular risk factors, doesn't help others. Chromium has no benefit. Cinnamon has also shown no benefit in type 1. There is no evidence base. It is just hearsay. And this, I think we've already discussed. So key clinical takeaways. So think beyond carbs, consider fat protein content while calculating insulin dose for mixed meals. 1 unit for every 10 to 15 gram of protein. But if your protein meal is more than 40 grams, for a vegetarian, it is very difficult. Only if you're eating a lot of paneer bhurji can you eat this much protein. For a non-vegetarian, if you're eating 2 big pieces of chicken breast, or as in the West, they eat a lot of steak, and steak has this much protein, and that is where the whole calculation has come in. Counsel parents using automated systems to have consistent pre-meal timing practices to maximize algorithm effectiveness. Prioritize individualization over rigid dietary frameworks. This I need to really drive. Don't give the same diet chart to every child who comes to your practice saying it is a diabetic diet. Mediterranean style eating practice patterns show most favorable cardiometabolic profile. Maybe all of you can also start Mediterranean diet because it is very easy to do in our vegetarian setup also. Regular consumption of prebiotic-rich foods suggests it can improve glycemic variability. And please screen for food myths and family challenges at regular visits. Connect families with appropriate resources. Maybe next time we'll be discuss. So now we are going towards nutrigenomics, personalized nutrition based on genetic profiles. Early studies have shown 18% improvement when diet recommendations align with genetic markers. Because many people have their genome now mapped in West, they are scoring systems and diet is customized. Next time, we will probably have new algorithms where you may not have to announce meals to an automatic system. And then probably in 2028, 7th or 8th APES, we'll discuss prebiotic, probiotic formulations to modify gut microbiota. So that's about it. Thank you very much, and I'll be happy to take any questions.
Thanks a lot, Dr. Saurabh, for the wonderful presentation and covering a vast majority of topics in that regards. We love to have some inputs from the chair. Yeah.
So there are a lot of, increased protein, formulas available in the market right now. They are all vegetarian also, whey protein based. And do they have some positive effect on overall glycemic control if you increase these kind of protein intake?
Sir, as I showed, too much protein will actually have a bad effect on your glycemic intake.
No fat, only protein.
Yeah, even if you have a protein powder, so if you are having more than 40 grams protein, it is going to have an independent glycemic excursion. However, the benefit of these protein powders that we see is that they cause a reduction in appetite of the child. Protein gives a sense of fullness, so they eat less carbs. So in moderation, used intelligently, they can benefit. But going totally gung-ho after them is not good because they're going to independently impair the glycemic control.
Yeah, very nice talk, Saurabh. I have seen the transition over the years. Carb from 60, it has gone down to 50. So I have two questions. One regarding what do you advise in your day-to-day practice? So this is one. And the second question is you very nicely touched the microbiota area, the gut microbiome. And you mentioned very complex articles to be consumed by. So this all have come from West. And for Indian perspective, what all we should advise to consume?
I had the list of Indian foods also.
Kimchi, dokla.
So curd, most important, yogurt and curd, and salads.
Like only raw banana you have mentioned. The other fruits you did not mention. This is what just I wanted.
The raw banana is now being discussed in forums. That's why I wanted to bring it up. So microbiota, salads, curds, kanji, any fermented foods that are there will help in what you call normalizing or balancing the microbiota. And any food that is high in fiber will help in managing the microbiota.
Yeah. And how much carb you advise in your day-to-day practice? 50
Sir, in
or
day-to-day
60?
practice, actually from the last few years, we have been practicing quality over quantity. And we tell them that per meal, if you can cut down your carbs to 30 while maintaining fullness in your child, it works very well.
Just one
Yeah, I
quick
just
question.
want to ask one question. Yeah, thank you very much, Saurabh sir, for such a nice presentation. So Mediterranean diet is very fits with the Indian diet, so taste is same. But when we are talking about the FPU, that it is very well correlated with the Mediterranean diet. But what is the room for the FPU in the Indian diet? If you have a real life experience or like
What is the room?
Any space for the FPU for
That's what I said. That's what I said. Luckily, our diets are still carbohydrate predominant, especially the vegetarian diet. So the only place where we ask them to use FPU in an indirect way is when they're having something like a puri, or they're having like a paneer bhurji, or they're having like burgers. Burgers and pizzas are where they actually need FPUs. No parents feed children 5-6 puris now if they have diabetes. Simply put, we tell them 1 puri is equal to 1.5 chapati. Give bolus after the meal rather than giving before meal. So that takes care of the FPU part in that thing. But with a burger and pizza, you actually need to give either an extended bolus or extra insulin about 2 hours after the burger.
And do we have any data from the Indian perspective to usage of the FPU in
No, not at all. There is no Indian data on carbohydrate counting even.
Okay, thanks.
Dr. Saurabh, just one quick question. So your take on intermittent fasting. in type 1 because
Okay, so intermittent fasting,
especially time restricted fasting.
see, basically all these are the same thing. You call it time restricted feeding, you call it intermittent fasting. It is basically calorie restriction. And any type of calorie restriction works because it reduces your insulin spikes and it promotes autophagy in the body. Effectively, you say why intermittent fasting has caused the walk, because see, you need actually 6 to 8 hours to digest one full meal. We never give our body 6 to 8 hours. You start giving 6 to 8 hours after one meal, obviously it's better. For diabetes, what we have actually, I don't have much experience because parents don't subject their kids to these experiments. So even if they're on CGM, so but overall, the less you eat, the better it is in terms of carbs. So
Yeah, because I came across few studies which say it has got favorable cognitive outcome.
intermittent
type one,
fasting,
yeah.
I don't know about cognitive outcome.
Maybe.
Thanks a lot, Saurabh, for the wonderful talk. And about the gut microbiome, I think what we need to understand is that to really change the gut microbiome, you need a much more drastic effect than just changing the diet. This is going to make some subtle changes, but actually, people were talking about the complete transplant of the microbe, which actually resulted in devastating consequences of septicemia. And a couple of people died when they had a full fecal transplant. So, actually, to change the microbiota, prevention will be better with these things, but you can't just cure it. And I think it's more of an association, as you said, rather than a real causality in terms of all the gut microbiome. So I think we'll move to the next talk on hyperinsulinism.
So for the next talk on hyperinsulinism, I would like to invite Dr. Vijay Kumar.
Dr. Vijay Kumar is a senior pediatrician endocrinologist at Calicut. Yeah.
Again, I express my sincere gratitude to Dr. Anurag and team for inviting me. And the topic is hyperinsulinism. Even though rare, usually that will produce devastating problems in the child and very difficult to manage also. So here, the main topic is taken from the International Guidelines for Diagnosis and Management of Hyperinsulinism that is very recently published in 2024, and also some other articles also. So this is a case summary. This child was admitted in our NICU few months back. Child came from Wayanad. She is from a tribal community, and it's a term male baby with birth weight 3,200 kilograms, 3.2 kilogram, and child develops symptomatic hypoglycemia on day 5 with seizures. Glucose infusion rate started with 4 milligram per kg per minute, subsequently increased to 12 milligram per kg per minute, and the critical sample was sent, and as the dictum in neonatology, injection hydrocortisone was started. And the results of critical sample came with serum insulin 30.5 and serum cortisol 59.8 microgram per deciliter. Urine ketones was negative. Started on tab diazoxide, initially with 5 milligram per kg per day, increased to 12 milligram per kg per day. At that time, hydrochlorothiazide also added. Then at that time, the persistent hyperinsulinism was thought, and the genetic study was sent, and child was put on nasogastric feed. Since the child is not responding, child was put on octreotide subcutaneously. Started with 10, almost reached 20. Now better, and child is on follow-up. This is the story of that child. Now, what is the importance of hyperinsulinism? That is the most common and most severe form of persistent hypoglycemia in children. Unlike all other causes, the risk of brain damage is much more, and neurodevelopment delay is a norm since they cannot use alternate fuels for energy. And another interesting thing is that we were discussing about CGM, continuous glucose monitoring, even insulin pump. No therapeutic modalities since the development of diazoxide in 1976. Diazoxide was in the market from 1976 onwards. Now 50 years have passed. No other treatment has there for our treatment, in spite of newer advancement in precise diagnostics tools. And the incidence, the monogenic congenital hyperinsulinism, incidence 1 in 25,000 to 1 in 50,000 live birth. And how the diagnosis? At the time of hypoglycemia, we want to take sometimes critical sample, or if the plasma glucose is less than 50, whenever there is an evidence of excess insulin action, that is suppressed beta hydroxybutyrate less than 1.8 millimole per liter, suppressed free fatty acid less than 1.7 millimole per liter, inappropriately large glycemic response to glucagon more than 30 milligram per deciliter, and increased glucose infusion rate to maintain euglycemia more than 8 milligram per kg per minute. And you have to show the evidence of excess insulin. Plasma insulin more than 1.25 unit as per the recommendation. In Nelson it says 2, or any detectable amount of insulin at the time of hypoglycemia is diagnostic of hyperinsulinemia. And C-peptide more than 0.5 nanogram per ml. This is the diagnostic criteria. So everybody knows, I am not going into detail. So inactivating mutation of potassium ATP channel ABCC8, KCN7, 11 produce persistent closure of the closure of the channel, and that will produce hyperpolarization and influx of the calcium and insulin secretion. That is the main thing. And 90% of diazoxide unresponsive hyperinsulinemia is due to inactive mutation of potassium ATP channel. And other less common is GDH. There is here, if you can see the glutamate dehydrogenase, that can produce hyperammonemia also along with hyperinsulinism. Then glucokinase HI. So that can produce variable response to diazoxide. Then SCHAD, short chain hydroxyacyl coenzyme dehydrogenase deficiency, that can produce severe protein induced hypoglycemia. These are all rare causes. And HNF1A, HNF4 alpha, that hepatocyte nuclear factor, that the importance is they can develop monogenic diabetes later. So the type of hyperinsulinemia can be divided into two mainly. One is permanent, one is transient. Perinatal stress-induced hyperinsulinism, PSHI, that is as a result of perinatal stress. Usually they will resolve within 3 to 6 months, and most of them are diazoxide responsive. And mainly placental insufficiency, birth asphyxia, SGA babies, preterm, congenital heart disease, intrauterine infections, meconium aspiration, all these things can produce perinatal stress induced. That is very common also. Neonatologists may be knowing. And monogenic forms of hyperinsulinism, we were discussing that all these things, KATP-HI will produce 90% of the cases, and all others are less common. Then syndromic hyperinsulinism. One is Beckwith-Wiedemann syndrome and other syndromes. So in order to know that, always whenever see a child, you have to look for some dysmorphic facial features, then that may come under the syndromic form of hyperinsulinism. Genetic test is a must, that is a must. So the recommendation is genetic test should be done in all children for persistent hyperinsulinism, because we have to treat, for treatment genetic test is essential. The precise genetic diagnosis direct the choice of therapy and need for long-term follow-up. And genetic test is not required for perinatal stress-induced hyperinsulinism, but genetic test should be performed when the hyperinsulinism has persisted beyond 3 months. Then it will become a persistent form. And these are some of the clues. Whenever you see a large for gestational age baby, that may be potassium channel hyperinsulinism or HNF4 alpha and the syndromes like Wiedemann-Beckwith syndrome. Whenever it is a small for gestational age, that may be a transient form due to perinatal stress-induced hypoglycemia. Then congenital heart disease, that can be as a part of syndromes. And family history of MODY, that the child may be having HNF1 alpha or HNF4 alpha hyperinsulinism. And children without any hypoglycemia suddenly developing hypoglycemia after 2 years, that may be an insulinoma. Dysmorphism, syndromic HI we have to look for. High plasma ammonia, you have to look for glutamate dehydrogenase type of HI. And future chance of diabetes is there in this HNF1 and HNF4 alpha HI. So this is a child. So we took the photo, it's an old photo, 2015. There was a case of, what is the diagnosis? We can see that child with macroglossia, umbilical hernia. That was a case of Wiedemann-Beckwith syndrome. That is years before our exome sequencing and all these things has come in large. And another classification is whether the child responds to diazoxide, whether the child is not responding to diazoxide. Diazoxide unresponsive and diazoxide responsive. Diazoxide unresponsive, 90% will have a pathogenic variant of ABCC8 or KCNJ level mutation. Depends upon the type of mutation, we can see whether the child is having a diffuse form of hyperinsulinism or a focal pancreatic lesions are there. If there is a recessive biallelic variance or a dominant monoallelic variance can produce diffuse HI. And mainly the medical management may be the treatment of choice. And if the child is not responding, almost near total pancreatectomy should be done. Whenever there is a paternally inherited recessive variant and the loss of maternally inherited 11p15 chromosome, that usually produce focal type of HI. Then the rare forms of HI, hyperinsulinism, can be responsive to diazoxide also. So this was a case, that same child, finally that genetic test came and it was ABCC8 mutation and it was homozygous and autosomal recessive homozygous variety. Usually that may produce diffuse type. And almost same time, we got another case of hyperinsulinism. That was again ABCC8 mutation. That was a heterozygous but autosomal dominant. So monoallelic, it may be autosomal dominant monoallelic mutation. Both might produce sometimes a diffuse form of hyperinsulinism. And imaging studies, the recommendation is pancreatic imaging studies, DOPA PET, should be done to localize a potentially resectable focal lesion in all diazoxide unresponsive HI, except in those with genetic evidence of diffuse disease. We have discussed that. The diffuse disease is seen in as just once more dominant variants, biallelic recessive variants, and some glucokinase variants also produce diffuse variety of hyperinsulinism. How to manage it? The recommendation is goal of treatment of hyperinsulinism is to maintain a plasma glucose concentration within the normal range of 70 to 100 milligram per deciliter. So the initial steps begin with 10% dextrose, 2 ml per kilogram body weight, IV. Then along with that, continuous infusion of dextrose, 4 milligram per kg per minute to begin with, and titrate to upper. High infusions, if you are giving, we have to use a central line. Another thing is we can use injection glucagon 20 to 30 microgram per kilogram or roughly 0.5 to 1 milligram IV or subcutaneously as an acute therapy. Or a continuous infusion of glucagon also whenever a child's require increased glucose requirement to prevent fluid overload. We can even give continuous infusion of glucagon. Diazoxide is a drug of choice, as we have discussed. That is the first treatment for children with established diagnosis of hyperinsulinism. Everybody might have used diazoxide. We all know the difficulty in getting diazoxide in sometimes. Now it is almost available in Calicut. So diazoxide is related to a thiazide diuretic. It suppresses the insulin secretion by opening up the beta cells of potassium ATP channel. And the dose range is 5 to 15 milligram per kilogram body weight in 2 to 3 divided doses. And if you are using a higher dose, fluid retention is the process. If you are giving more than 10 milligram per kilogram body weight, fluid retention is a problem. So hence a diuretic should be started along with the higher dose of diazoxide. In our child, we gave hydrochlorothiazide 1 to 2 milligram per kilogram per day. Then whenever you use diazoxide, it is not a drug without any side effects. Major side effect is salt and water retention that will produce fluid overload, edema, hyponatremia, tachypnea. Pulmonary hypertension, there is an evidence of also there is a chance of pulmonary hypertension. So the recommendations advise echo monitoring 1 week after initiating treatment and serial echo on long-term follow-up. Then hypertrichosis is a non-complication, host facial features, hyperuricemia. So monitor serum uric acid level regularly. Neutropenia and thrombocytopenia. Hence, prior CBC is a must before starting treatment, and every 6 months we have to continue. we can see our child was on disoxide for a long time. Then we started octreotide, and we have gradually reduced disoxide. You can see his hypertrichosis. This child has developed hypertrichosis within a span of 1 month. So what is meant by disoxide unresponsive? The rate of dextrose infusion cannot be reduced even after 5 days of treatment with disoxide at the dose of 15 milligram per kg per day, blood glucose level less than 70 milligram per deciliter. If the child cannot generate hyperketonemia, beta hydroxybutyrate levels above 1.8 millimole per liter prior to developing hypoglycemia, then child is having symptoms of neuroglycopenia, and all KATP channels defects are disoxide unresponsive. But we got the result a little bit late because of some financial problems and all. So recommendation is genetic test is a must in all disoxide unresponsive hyperinsulinism. The second line of drug, somatostatin analogs, that is the second line of treatment, who are unresponsive and who are developed side effects with disoxide. The dose is 5 to 20 microgram per kg per day to 2 to 4 subcutaneous doses, or continuous infusion using pump. Monthly injection of long-acting SSA or lanreotide 3 to 60 milligram per month. The side octreotide is also not a good drug. Actually, they are telling necrotizing enterocolitis is very common in infants less than 8 weeks. That is 2 months. But many of our cases, we are forced to start disoxide in the newborn period itself. This child we started almost at, Rajesh may be knowing, Rajesh was in charge newborn at fourth week. We have to start because child was not responding. Luckily, the child never developed NEC. And gallstones, so monitor serial gallbladder ultrasound scans. There was a discussion in the morning about the chance of gallstones later turned to be hepatitis and all. And transaminitis, monitor liver enzyme levels frequently. Hypothyroidism, always do thyroid functions once in 6 months. Malabsorption, growth monitoring is a must. Here we can see our tribal mother. We are training the mother how to take subcutaneous injection using an insulin syringe, so that at least they are doing very well, and the child is on follow-up and with almost good results. What about other drugs that also were discussed in the morning? Calcium channel blockers, mTOR inhibitors like sirolimus and corticosteroid, they have no role in the treatment of hyperinsulinism. Actually, years back, Rajesh may be remembering, one case we had to start sirolimus. Then we stopped it because of the lot of adverse effects. We were reading the text then, but we had to start actually at that time, because at that time, disoxide was not available. Then carbohydrate supplementation, sir was discussing in the morning also. Continuous intragastric infusion of glucose via nasogastric route or gastrostomy, or glucose supplementation of formula feeding, and uncooked cornstarch 1 to 2 gram per kilogram in children above 9 months. Surgical management. Surgery is a choice for hyperinsulinism with a resectable focal lesion. Suppose there is hyperinsulinism with diffuse lesion, surgery is the option if euglycemia is not achieved with maximum medical therapy. Postoperative hyperglycemia, that is the problems of this surgical. Sometimes there will be postoperative hyperglycemia that we have to manage by subcutaneous insulin. Sometimes there will be persistent hypoglycemia, again continuing with octreotide. Some may develop permanent diabetes later. Exocrine pancreatic deficiency requiring enzyme replacement. Fat-soluble vitamin deficiency requiring supplementation. So this is not a simple case. You have to monitor all these things during follow-up. So this is a small algorithm. Whenever you confirm hyperinsulinism, disoxide still, as I have told, from 1976 onwards, disoxide is the drug of choice. Responsive if plasma glucose is above 70 milligram per deciliter. Then continue disoxide. Perform genetic analysis transient or perinatal stress-induced hyperinsulinism, so there is no need of genetic analysis. We have to continue diazoxide for 2 to 6 months. If it is persistent, we have to do a genetic analysis. If there is child is responsive to diazoxide and we cannot stop it, we have to continue till puberty or even lifelong sometimes. If it is unresponsive, plasma glucose is less than 70, stop diazoxide, dextrose containing fluids and octreotide, perform genetic analysis. When the genetic analysis show biallelic recessive or monoallelic dominant mutation of ABCC8 or KCN11 genes or GCK, that we can presume that this is a diffuse HI and that child requires intensive medical therapy and if unresponsive, near total pancreatectomy with all these complications. If it is a paternal recessive monoallelic ABCC8 or KCN11, we were discussing that focal HI is a possibility. Do a PET scan, DOPA PET scan, or if it is a Wiedemann bequeath or some other syndromes, then variant of unknown significance. If we don't know that, you cannot categorically tell that this is not a diffuse form, then you have to do a PET scan again. If it is a focal, surgical resection of the lesion. If it is diffuse, intensive medical therapy. If unresponsive, near total pancreatectomy. This is the algorithm. And even after, whether you're doing pancreatectomy or not, we have to follow up the child lifelong. Frequent oral feeding, nasogastric feeding via gastrostomy feed. Access to glucagon therapy for emergency use. Actually, this child we were planning to teach the mother about the glucagon use, but that is very costly, that glucagon. Frequent glucose monitoring. CGM, I have no experience, and no experience if I searched journals also. There is no experience worldwide because CGM is for diabetes, not for hypoglycemia. It is not that sensitive to dictate hypoglycemia. Severity may decrease over some time, like HNF alpha, HNF4 alpha. They may develop sometime monogenic diabetes also. Post-pancreatectomy screening for diabetes, HbA1c should be done every 6 to 12 months. Pancreatic enzyme replacement in some, fat-soluble vitamins, and always check for the side effects of the medications. And neurodevelopmental assessment is a must. All children with HI should undergo referral for developmental surveillance and early intervention. This is also a part of the game. At least 50% can develop neurodevelopmental delay, epilepsy in 30%, microcephaly, speech delay, behavioral problems, learning disability. On few patients on our follow-up also have, none of them are having normal development. They are having developmental delay because they cannot use the alternative fuels, and that is a norm actually. So in short, the take-home messages is hyperinsulinism is the most common and most severe form of persistent hypoglycemia in children. Genetic testing is a must, not for a fashion, but for all congenital and syndromic form for treatment. Pancreatic imaging studies should be performed by DOPA PET scan to localize a resectable focal lesion. Goal of the treatment is to maintain plasma glucose concentration within the normal range, 70 to 100 milligram per deciliter. Long-term follow-up is necessary due to increased risk of neurocognitive deficits. That is, in short, in nutshell, the management of congenital hyperinsulinism. But everybody knows, and even I know, that treatment is not that satisfactory always. Thank you.
Thanks a lot, Dr. Vijay. It was a wonderful talk and you covered a lot of topic, and particularly hyperinsulinism. There are so many changes, but yet we are often stuck with the diazoxide as one of the drugs, and pancreatectomy we were discussing is not something easy. It is easy said than done. Then you remove the pancreas for life. No exocrine, no endocrine is going to be a big issue. So any words from the panelists?
Yeah, and it is, the transient form is much more commoner than the permanent form. Yeah.
That is, I think, the good part, that a lot of prolonged hyperinsulinism we are able to pick up. They respond very well to diazoxide. The severe forms are a difficult story still. Although long-acting octreotide is a good drug, which is being used in many cases and can prevent pancreatectomy. But Yes, so it's not that much development as type 2, type 1 diabetes, but probably yes, the prolonged form is very good. We respond very well.
Thank you, Dr. Vijay Kumar. And in your last slide, you said about 18F DOPA PET CT for localizing and diagnosing focal hyperinsulinism. And that is a condition in which probably partial pancreatectomy may be beneficial and the patient may be cured.
Thanks a lot, Dr. Vijay Kumar. I'll now request Dr. Sandeep to kindly hand over a memento of appreciation to Dr. Vijay. We have gone through a lot of topics today, and especially the topic of type 2 diabetes, in which Dr. Chetan talked about how difficult it is to manage children with type 2 diabetes once they develop it. And we all know about that. And the best way, of course, is to try to prevent it. And that's why prevention of childhood diabetes requires prevention of obesity, which again is easier said than done. And now, once obesity is becoming a truth, we will also need to explore options just beyond prevention and whether treatment could be options on that. And I would be talking specifically about one modern way of treatment which has been used both for type 2 diabetes as well as obesity, and how GLP based therapies can have a role in terms of management of pediatric obesity, particularly. There's a lot of word upon that. Before that, this 16-year-old boy with obesity presented with massive obesity, 46.7 BMI, had everything type 2 diabetes, fatty liver, and was advised bariatric surgery. Now, parents are not really ready for bariatric surgery. Do we have any options there or not? So I'll be focusing about the options of why, what, and how do the GLP analogs will have a role in that perspective. So first of all, why? We know that there has been a dramatic increase in obesity, and this is the data from the globe which shows 20 to 30-fold increase in burden of childhood obesity. There is an increase of BMI, which is basically there has been an increase in the BMI, which is basically there of a tune of approximately, seems to be trouble in there. So there's an increase in the BMI of the tune of approximately 1 globally across this, and this has resulted in a lot of increment in terms of overall aspects of development of these complications and the need for development. In India also, we have noted that there has been a lot of increase in terms of diabetes burden as well as the obesity burden, and that is why we need to have options in terms of therapeutics which will provide options to improve outcome. So as we can see, there has been a dramatic increase both in terms of the percentage of obesity and the average BMI across the globe of approximately 1.4 to 1.7 points across. In India, this has been to the tune of around 70%. So obesity across India has increased significantly. Our own data that we have done from our side has shown a dramatic increase in terms of development of complications, and childhood obesity is a clear-cut predictor of long-term complications and a lot of morbidity. So children who are obese at 18 years have a very high chance of remaining obese for life, and they will have also implications in terms of worsening outcome in that regards. So this is something which is very, very clear that if you're obese at around 12 years, there is a lot of chance of adult mortality. At 18, the mortality becomes much more. More importantly, there is a lot of chance in terms of progression of these disorders, and this has got increased implications in terms of long-term outcome, which we need to be aware about and understand. We know that complications are extremely common in terms of type 2 diabetes, and the most common complication that we see are with regards to a number of issues, including not only type 2 diabetes, but also hypertension. I think there's been a trouble now. Seems to be a problem. एक बार निखिल से पूछें क्या प्रॉब्लम हो रहा है. There seems to be a technical glitch, so just एनोटेट हो रहा है बार बार. नहीं, ये एनोटेशन वाला प्रॉब्लम. Blank. Okay. So as discussed, there is a significant prevalence of childhood obesity, and it is causing a lot of complications which are happening. And our studies have clearly shown that there are a lot of issues in terms of overall aspects of complications. And the key aspects to reduce complication is the fall in BMI standard deviation score. Now, how much BMI standard deviation score should fall? The figure is 10%. So if we are losing 10% of BMI standard deviation score, then only we will be achieving a good outcome in that regards. So there is also a continuum which is happening with regards to the overall aspects. I don't know what's happening with this. तो उससे क्या होगा? एंड करके फिर ही लॉगिन कर। आ रहा है वहां से करके वो breathe। Okay, so apologies for all these confusion and all the technical glitches. So what we are seeing is that childhood obesity, the most important part, if you want to really control the complications, is to really curtail the BMI standard deviation score. So our studies has shown that if you want to cure pre-diabetes, you would be needing approximately 10% of BMI SDS loss. So if you want to know what is the appropriate loss in obesity, it is 10%. Similarly, fatty acid, what we found that most patients have persistent fatty liver over a period of time. And if you want to do something, you need to lose 5 to 10% of BMI standard deviation score. So this is the target of BMI. So whenever I am going to talk about various drugs, you should know that if they are doing a 5 to 10% loss, that is good enough. Otherwise, probably it's not that good from that perspective. We also know that there is a continuum in terms of complications. So it all starts with obesity, which results in development of metabolic factors, renal involvement, cardiac involvement, and all the things are amplified. And we need to break this cycle to achieve that. Otherwise, metabolic dysfunction will result into kidney disease, into heart disease, and all the complications happen. So we need to break the cycle early. So what are the options which are there in terms of pediatric obesity? The options include lifestyle, medications, and the bariatric surgery. Now, if I talk about lifestyle, generally speaking, lifestyle has been found to be not very effective. In most cases, if you have a weight loss, there is a body mechanism by which itself it will counter-regulate it. So what happens is that if you are losing weight, the body has got a set point for leptin. As soon as the leptin level falls, they feel that this person is going to starve to death, and then they start to decrease the energy expenditure. So in this regard, the response to fall of body fat is a decrease in leptin and an increase in ghrelin. And these parameters will then stabilize the weight, and further there will be a weight gain. So there is always going to be a ceiling effect as far as the amount of weight that you will lose or the BMI you will lose while just nutritional or lifestyle intervention. That's typically 3 to 5%. So I said you need 10% to correct pre-diabetes. You need 5 to 10% for fatty liver. So this 3 to 5% is not going to make a huge difference in that perspective, and it is ill-sustained and it will invariably be regained. What about the currently available drugs? Now, orlistat, the drug has been available for quite some time, but the amount of weight loss with orlistat is not going to be huge. You will have a benefit again of around 3%. So this is again not going to do any benefit. It is something which most people have left it. Metformin as a drug, everybody know that metformin is a drug predominantly for diabetes, PCOS or fatty liver. As a weight loss drug, it is not going to be effective. It is not going, there is a randomized trial which was done, but it was not found to be effective at all. It was very minimal, around 2%. So this is something which we should not be using unless there are other things like type 2 diabetes, NAFLD or PCOS. So our armamentarium of drugs is very limited. Drugs which are centrally acting have been found to have a lot of CNS problems, and that's why they're also not being approved in most scenarios. What about bariatric surgery? Now, bariatric surgery is clearly proven to be a highly effective therapy in terms of response, and it shows a decline of around 20 to 25% as far as BMI. This is the study from adolescents. So it's the most effective therapy for reducing BMI in adolescents, but there are a lot of other complications, including mortality. So most people, as was in this case, would not like to go ahead with bariatric surgery. So currently, lifestyle measures are only going to give us 3 to 5%, not sustained. Drugs are variable response, adverse effects, and bariatric surgery is high responsive, but there is a lot of morbidity. So what options do we have? We want a drug which is safe, selective, doesn't act on the central system, and is also effective at least 10% fall of BMI. This is the ballpark figure that we are going to chase out in that perspective. So what is the option? I'm going to focus predominantly about GLP. Chetan talked a bit about GLP. So this is basically a compound which is secreted via our intestine in response to intake of the carbohydrate. There are two predominant, the glucagon-like peptide and the gastric inhibitory peptide. Now these have different actions. The GLP-1 will go and decrease the gastric emptying, so you will feel full most of the times. It will go to the brain and tell that, okay, we already have food now, don't eat any further. So food intake will come down, satiety will be induced. It is going to act on the pancreas to increase the insulin secretion, and insulin also is known to induce satiety. That is one factor, and is also going to inhibit glucagon release. So GLP-1 has got multitude of actions, and these actions in nutshell will cause increased satiety, reduce gastric motility, resulting in lesser food intake and possibility of weight loss. This is the basis of the incretin effect. There are multiple GLP-1 receptor analogs. We talked about liraglutide, exenatide, semaglutide is the one which has been developed a lot. A lot of talk has been there. Now we have dual agents along with the GIP, which include the tirzepatide, and then there is a triple therapy in which we have a combination of GLP-1, GIP, and glucagon also, which is coming up. So this is area wherein a lot of work has been done, particularly because the effects in the CNS is not like a neurotransmitter modulated. It is a direct metabolic mediated pathway from that perspective. So liraglutide and GLP-1 receptor analogs have multiple roles. They have a role in terms of overall reduction in visceral fat. So they are particularly helpful for individuals who have fatty liver and beneficials in that regards. They have been shown to reduce the fat mass as well as preserving muscle mass. So we have increased as far as lean mass is concerned, while there is a decline in terms of the fat mass in that regards. Now coming on to adolescent study, liraglutide was the first trial. Look at the figure. The amount of weight, the loss which is happening is to the tune of 5 to 6%. So the first drug for which approval was given by FDA is causing 5 to 6% loss in BMI. So from my side, it is not very good, but it was given an approval. So liraglutide is available as a daily injection, and it had only moderate effects. So probably it was not a game changer from that perspective. However, there were some studies which were done using liraglutide and other GLP-1 receptor agonists in complicated scenarios like Prader-Willi syndrome. This study also did not find much benefit. So in a way, liraglutide is not a good drug as far as obesity management is concerned in children. Then came the second big agent, which was semaglutide. And if you look at semaglutide, what you're seeing a percentage loss of 15%. So this is a very good number. We are talking about 5 to 10%. Here there is a loss of 15%, which is clearly there. But what are you seeing after 68 weeks? After 68 weeks, when the drug is stopped, there is again a regain. Now, this is common for all GLP studies. As soon as you stop the drug, the weight tends to gain again. Proportion of children who are achieving weight loss, of course, is much more. So this is much more potent as compared to liraglutide. But of course, we have to look at various other factors in that perspective. So efficacy outcome clearly show that it is quite superior as an obesity agent. Change in BMI was 16.7% to be precise. There was more than 5% reduction in around 95% of cases. BMI SDS came down by 1 standard. So it was a good amount in terms of their weight loss of around 15 kg. So this was a good drug from that perspective. What about adverse effects? Anybody who has prescribed GLP-1 receptor analog knows that a lot of patients will come to us with bloating, abdominal pain, not feeling well, nausea. We have to tell them these things are common. 4 to 5% in this study and in general practice also will stop the drug. So best is to start at a low dose and then gradually build it up. Tell them that this is going to happen and this is going to improve. But if you are giving a weekly injection, then that may be a problem because you've given the injection, the effect may be there for quite some time. So this is a negative effect which is there. We should avoid drugs like prokinetic agents because they are going to nullify the effect. If you give a prokinetic, of course, the gastric motility will go up from that perspective. So the adverse effects are there. Now, what really has been found that in 45% children who were very obese, it was able to bring them off the obesity category. So this is one drug which can be game changer in the sense of reducing the overall amount as far as obesity is concerned. So semaglutide at the moment 2.4 milligram is not available. It's going to be available very soon. So I think this will be a good drug to be used in obese adolescents, and we are all looking forward to this drug in that regards. And clearly the benefits are irrespective of the age, irrespective of the gender, irrespective of the obesity category. So it's quite a good drug across all obesity categories in adolescents from that perspective. Very importantly, conditions where we find it very challenging to manage obesity like hypothalamic obesity, also there has been benefits via semaglutide which has been found in that perspective. So semaglutide is one agent which has really brought the bar up for all the GLP-1 receptor analogs, and then came the role of dual agents. So these agents are going to focus two aspects. Tirzepatide is a drug which has been studied in adults predominantly, and what we are seeing here is a loss of around 21 to 22%. 5% for liraglutide, 15 to 16% for semaglutide in adolescents. This is for adults, not adolescents, but it is 21%. So this is a drug potentially which is going to do again a good work in terms of reduction. And again, what we are seeing as the dose increases, there is a good response in terms of body loss and weight loss and other parameters as well. There has been a recent study in NEJM, and this is a wonderful study which shows that if you give tirzepatide to obese individuals, you can prevent the development of diabetes. And you can see over this 4-year period, the prevalence, there was no diabetes happening in this group, while those who were not being treated had a lot of diabetes. So this is another drug which is going to helpful. Of course, it is targeting two different strategies from that perspective. There has been no pediatric study there, but now there are AI models. Based upon that, they have predicted what will be the appropriate dose of tirzepatide. Tirzepatide is available in India now, and it's being used in adults predominantly. So they have tried to look at the dose, and they have come up that for adolescents, approximately 3.75 to 5 milligram will be a good enough dose in that perspective. And they have even calculated based upon the dynamics, but we need to wait for the studies at the moment. So tirzepatide is a good drug. And the evidence of this comes from the study of Alstrom syndrome. These patients are very refractory to therapy. And you can see when they were given dulaglutide, semaglutide, liraglutide, they did not have any response. As soon as tirzepatide came, somehow they had a good response. So this is just two patients, but probably we are talking about a novel mechanism which is going to add out in terms of response. Now, there are also novel agents which are focusing on three aspects, not only GLP-1, but GIP, but glucagon also. This is an experimental study. This is more in terms of a mice model at the moment. But what you can see, the calorie intake has nearly come down to around 5 to 10% of what it is in these studies. So clearly, this is an agent. By targeting three aspects, you may get more benefits from that, but this we are waiting for that. Very recently, there was a phase 2 study on a once monthly GLP-1 receptor analog. So probably now people have realized that GLP-1 receptor analogs are the way to go forward in terms of managing obesity. So we have now daily to weekly and now monthly. And overall, this also has shown a good reduction of approximately 16 to 17% reduction. So we are now going to hear about this drug a lot in that perspective. So what we wanted was a safe drug which was selective and which was effective. So probably GLP-1 is a good drug in that direction. Semaglutide clearly has got good evidence in adolescents. Tirzepatide has got good evidence in adults. We need to wait for the picture. But at the moment, I think the availability of semaglutide will help many of these morbidly obese patients in which bariatric surgery is being planned, and then we may be actually able to avoid that from that perspective. I apologize for all the delay because of this technical glitch. And if there are any questions, we'll be happy to take up.
It's all things what we said that there is a ceiling effect and then you tend to get. So is there any age cutoff when it comes, or
So that
because we
generally the most studies have been done were done in terms of adolescent age group.
Yeah.
And also in older individuals, the same phenomena goes
so
that
perhaps nipping them in bud, or
very early, probably pre-pubertal may have a different mechanism. So they haven't been studied well, but definitely in older adolescents it's been shown that lifestyle will have a limited effect and then it will tend to seal off. But yes, I agree. If we start early, so primordial prevention would be clearly the much better way than to go for primary or secondary prevention here.
so can we deduce from whatever we have that after the puberty is over, then the leptin effect or the
So all the maturation pathways will basically mature by around 16 to 18 years. And in a way, the body is programmed toward obesity. That was one of the slides which I couldn't show well, was that if you are obese at 12 years, you have 40% chance of being obese as an adult. If you are obese at around 16 years, it becomes like 60%. If you are obese at 18, it becomes 80%. So probably there is a sort of a programming which is happening there.
Can we trace it back to the obesity rebound at 5 years or 6 years?
So the earlier you are having the obesity rebound, you have a higher chance of obesity. So these are all basic tendencies which have been looked into programming part. Yes, Saurabh?
And also, the last month there was an NEGM paper that after this rebound, once you stop these agonists, if you continue for a 2 weekly or a monthly or even a 2 monthly dose of Manjaro, the effect keeps on being sustained rather than a weekly one. So probably we are going towards a very long chronic treatment for a chronic disease.
Yes. So now if you ask anybody in the US about type 2 diabetes in adolescents and what is the treatment, they'll say GLP-1 analog. How long? They will say lifelong. It's like that is a concept, but probably it's very scary that you will give a lifelong treatment to an adolescent just for obesity management. Most people will want maybe few months and then they will be able to carry. But the problem is they may again regain.
Yeah, thank you very much, sir, for the nice presentation. So now semaglutide is approved beyond the 12 year of age. So my question is that that induce the GERD in the many patient, and the obesity is also related to the GERD. So in that kind of the patients, shall we start with the semaglutide or
obesity associated with?
Means might be obesity also causing the vomiting and the gastritis. If we treat the obesity, that time we are treating the root cause of the GERD. So might be in that setting what we have to do.
So it will depend upon, generally we will tell them that it will take time, it will settle down, we start with a low dose, gradually build up. So I said 4 to 5% generally will be having a problem. So it usually improves on that. So I think we should be patient. Dr. Rishi has a lot of experience in adults, so probably he'll be able to add into that.
Actually, I'm the only here. You can call me hybridologist. Because I have, and I can share my experience. The semaglutide with children, somehow the adolescent, the experience is they tolerate better. So this is one thing. Then semaglutide in adults. This is a very rosy molecule, but provided it suits a patient. That is very, very important. They come and even after 3 milligrams, no more molecule. Severe nausea. Something similar, I think tirzepatide, I wrote quite a lot in last 2 months or so. So again, you have to keep your brain open. I mean, many of US children in US and the parents come, sorry, start my Monjaro. And one parent I started this, sir, अब मैं अब नहीं लूंगी. Because the tolerance is a very individual effect, and that is very important for us as a clinician. So that one has to keep in the mind. And how long? The answer is again, it has to be lifelong. Actually, I wanted to reduce 3-4 kg and I thought of taking semaglutide. I shared with Dr. Anurag. Then I was supposed to speak last year. Then semaglutide curve, I said, moment they stopped semaglutide, it came back to same. So I thought whatever lifestyle I could do, it would be all right. So again, keep in your mind that it has to be individualized. It is a good drug provided it suits to our patients. This is very important. And don't pressurize unnecessarily. convince once or twice. I think very recently one of my patients got admitted in the hospital for Munjaro. अब इतनी vomiting हो रही है घर में संभला नहीं जा रहा है. So this is the way I'm sharing openly because I have experienced quite a lot. So take everything with pinch of salt. Everything is not as rosy as it appears. Thank you.
That when we trying to weight loss, that time we have a muscle loss also. So it causes sarcogenic obesity. So how to prevent that kind of obesity?
So generally, I think most of these drugs have been shown to actually preserve the lean mass, but definitely physical activity is something which has to be maintained on that perspective.
I can answer any weight loss by any means, by lifestyle or whatever weight loss, it has to be associated with lean body mass, independent of whatever you do. So forget about the fact. So I think the complementary or supplementary measures as the
And I think
high-protein diet,
relative loss,
physical
which is
activities,
more,
all right. But
which is fat
any
is
weight
more
loss
and-
is associated with lean body mass.
So the percentage will be very important. So I think we will move to the next talk. Any comments, sir, from your side?
So what is the current day recommendations for use of semaglutide at what age for obesity management?
12 years and above, it is approved by the FDA
For obesity.
for obesity management, irrespective of diabetes. The dose is much higher. So when we use the oral semaglutide, the dose has to be 3 times more. Maybe then probably it will be equivalent. So dose is much higher, but 12 years and above non-obesity, it's recommended.
Sir, one question. This might sound stupid, but in the side effect, the presentation that you showed on semaglutide, so did I notice a COVID-19 there? I'm not sure.
That was
So
at that point of time because they were mentioning all the adverse effects. So the study part of it was done at that point of time. So they were saying that this patient, any event will be reported. So that is like an adverse event report, which is
Yeah, so that showed COVID-19. So those patients taking the drug had COVID-19. Maybe
yes. So it's a chance because COVID was probably there in so many patients at that time. It's irrespective of
Yeah,
that. Yeah. Unreal. Yeah. Yes. Yeah. So there is, as I showed, there are a couple of studies on Alstrom syndrome and hypothalamic obesity and Prader-Willi. There is some role which is coming up. The better agent there will be MC4 receptor agonist. That will be a better agent in many of those scenarios, but that's going to be very, it's not easily available. But it has been shown Prader-Willi we have used in couple of patients, some response, but not dramatic.
Thank you.
So now we'll invite Dr. Rishi. Dr. Rishi needs no introduction. He is the one who established endocrinology in this region, and he'll be talking about newer insulins.
Good evening, friends. I'm the most discriminated person in this community. I was known as an endocrinologist, and you people had made me adult endocrinologist. So thank you, Dr. Anurag, for the opportunity. Actually, Dr. Saurav was talking about nutrition. Dr. Anurag was talking about the GLP-1 receptor analog. And I was thinking about this nice samosas kept at the back. I think he should have kept some. I mean, for the first time in this hotel, I tried 3 types of samosas. So food attraction is actually very important. And how to take care of, I think, because I don't want to continue with GLP analog, because I have spoken a lot about this, but I consider GLP analog as a very spiritual drug. Because yeah, the spirituality problem is what? You have to take care of your thought process. Your mind goes towards the food. But when you take this GLP, you don't feel like taking. Money nahi ho raha hai. So what you call? But mind you, only for one domain of desire, and that is food. So rest of the domain you have to manage by your own. So coming back to the newer insulins, but new is not possible. I'm a little old, but new is not possible. I was thinking it is very contradictory thing because new is not possible without old. They cannot exist without night. So old is very important. So I'll just share my thought process because many of you have not known what we have seen. Dr. A.C. Agarwal is sitting must have seen those days. So these are the insulins, and we started with porcine and bovine insulin and syringes, and we were the people who used to use steel syringes for insulin, U40 marks. So how many of you used insulin syringes, steel syringes with needle? No, nobody. So we started with that, and that time there used to be the animal insulin, the bovine and the porcine, and there used to be fight. One community of people will come and say, no, no, we don't want bovine insulin. Ye गाय की है. Other will come, we don't want porcine insulin. So we started with that era, and then came the monocomponent insulin, and then the human insulin, recombinant insulin. And before that, the new innovation, and that came pen. It also changed the mindset of people. Oh, you have to dial and just put it. But it's to be a rich man's people. I still remember I injected at that times Haryana CM Mr. Bhajan Lal. I injected insulin to him. हमारे boss ने कहा था go and Rishi you demonstrate him. So that was the time. So I moved from that time. And when came the recombinant insulin? That made us understood how we can modify and play with the insulin. And basically two changes have occurred. One set of modifications that reduce the duration of action, faster action, quicker peak. Another thing, it make the insulin use the long acting insulin. So these are the two basic changes that were made by various modulations. So we started seeing all those things, and we fought from that era. And now, but the problem is A1C at that point of time was probably 9 and is still about 8.8 or 8. A1C has not gone down. So this is the unfortunate part. So these are the different types of insulin. I'll not be going into details. Some newer insulin I'll be touching, which will be useful because they're going to be launched. The Icodec is about to be launched. FCTOR, I think, thank you, Dr. Vibha, you sent me a paper on this. And Icosima. What are the basal insulins we use nowadays? The glargine U100, Ditamer, Degludec, and co-formulation of Degludec and aspartame. What is important is that basal insulin alone is the most convenient initial insulin for the control of. But the contradiction also came that I wanted to say. If you use the mixtures, mind you, I'm talking of type 2 also. If you use a mixture and try to keep postprandial blood sugar below 140, then chances of reducing A1C below 7 are around 90%, versus using only basal insulin, the chances are around 65 to 70%. But provided you are keeping it below 140. So that is, there are contradictions also, but basal insulin continues to be the most popular insulin. And conventional versus basal insulin, I think I'll not be going into detail. NPH insulin or Insulatard, how many of you are using nowadays? Medical college. I was due apology to my old friend in SGPGI. I was talking to him, how come you are using this Insulatard? And they are all my friends. So how come, अरे यार तुम नहीं समझते हो. So but anyhow, but I think the lowest insulin is Glargine. U100 if you use, it is better insulin that the excursions are lesser, the hypoglycemia is lesser, the nighttime hypoglycemia is lesser. And then is the Degludec insulin. Degludec is better in the sense that duration of action is more. The glycemic variability is more or less same. Reports are contradictory, but you can give it at any point of time. So this is the advantage. And then for Detimer insulin is known as a pregnancy insulin. And now we have a good amount of rich data to to support glargine insulin or degludec insulin in pregnancy also. So we can use any of them. And essentially, I have stopped using determinant insulin in pregnancy. This degludec or tresba, it is the flattest curve compared to any other insulin. The U100, this is actually, this comes or not? No. The U100 insulin versus 100 insulin. I think what was important, I was in that meeting. How come this U300 insulin came? And they found with this 300, the molecule release is slower, the duration of action is more, the glycemic variability is less, and the hypoglycemia is less. And to surprise, just all of you are researchers, the young people are there, professors also, you can put, we asked the question at that point of time, can we make it U500 so that we can have even better action, or U600? This acodec insulin that I am going to talk is U700. And just prior to that, I finished the trial on mixed R3070 U500. It was never released in the market, but we finished the trial and we did not find any significant difference compared to regular. So it was just a miraculously this 300 word came and it yields that wonderful results. So there's just a chance, and how researchers come, and all of you know how insulin was invented. So degludec is a little better insulin compared to U300. The hypoglycemia is lesser. Then if we talk of all three types of insulin, the glargine, the time flexibility is less. Within 1 hour you have to give. The U300, I think U300 you can give it any age group, pediatric population. So within 3 hours, and degludec you can give at any time of the day. So this is the advantage. And now coming to a newer insulin, icodec. It is once weekly basal insulin analog and designed to cover basal insulin requirements for full single week, and it is a subcutaneous injection. And as I shared with you, it is formulated as 700 units per ml. So this is important, and it comes with the pen, and it is comparable with the OD glargine insulin, OD degludec insulin. So this is again the important. And how does it act? It is once a weekly, and it bounds to albumin in the subcutaneous plane and makes the precipitate, and from there it is gradually released, and again it is genetically modified. At 3-4 places there are modifications so that its action is prolonged. And it is compared with the different trials, and basal insulin titration, double bind titration, with app also. So wherever it is found that it is either equivalent or little superior with the other types of insulin. The glycemic variability, if you look, it is a little superior compared to Actually, most of these insulins are compared with either glargine or degludec insulin. So glycemic variability is also much lesser. I think here Dr. Saurabh very nicely talked a very technical talk. But again, I'm asking, how many of you are using CGM or AGP in your day-to-day practice frequently? One. Not many of us. I think one is the cost reason. Second thing is our mental inertia that I would like to share. What is our mental inertia? Like suppose you ask 10 people for to use CGM. Then no, it is not possible. बहुत महंगा है. How can't I afford it? Then our mind resets that nobody is going to use it, and we continue to move with that reset. So don't reset your mind every time, recharge that even 21st person. Sometimes, I mean, semaglutide initially I saw that एकदम फटे कपड़े पहने आदमी आया कि यार हमने कहा बड़ी अच्छी, तो हाँ साहब लिख दीजिए. Looking at person, you can't imagine. So don't get biased or judgmental. So this is again a very psychological thing that we have learned. I try to teach all my fellows. So use it more frequently, and those who like it, they would like to use it for very long. And question is how to initiate, because it is going to be launched within couple of months in India. And what are the recommended doses? This is once a weekly insulin, 70 units per. I mean, how come this 70 figure came? The basal insulin starting dose is usually 10 units per day. So multiplied by 7, so 70 units. How to modify it? Initiation at 70 for a weekly in accordance with ADA guidelines, and then suppose somebody's basal requirement is 20 units or 30 units, then you multiply it by 7 and use it. And what you have to do as first injection, give 50% more. So somebody's requirement is say 20 units. So for 7 days requirement is 140 plus 50% more. So 210 as a first shot, and then continue giving as a 140 units weekly. So this is going to be launched, and you can use it in your adult type 1 patients. And how to titrate doses? This is again very interesting, but it is a very simple thing. Keep measuring your fasting blood sugar, take average of fasting blood sugar, and if it is more than 130, increase 20 units. 80 to 130 is the range, no change. Less than 80, average blood sugar, make it, reduce it by 20. So this would be a very interesting, because first question came in my mind, how to titrate the doses. So you have to measure the fasting blood sugar, and based on that you have to titrate the doses. And I'm sharing all this because this is going to be launched soon. Then Icosema, this is another, just wanted to put the concept. Dr. Anurag has already talked about semaglutide, but once weekly Icodec mixed with the weekly semaglutide. So it would be very nice for all obese patients. One prick once a week, and it will take care of. Again, I would like to emphasize about what is my experience. I think everybody, all of you would agree, and me and Dr. Anurag have also shared that whenever we use GLP-1 receptor agonist in adolescent population, the blood sugar, the glycemic variability goes down, and this is one molecule which has the most prolonged action. I mean, some of my young type 2 patients on 14, 15, 16, they are on semaglutide oral and they are doing wonderfully. So that is one thing, those who can afford, at least you should talk. And if you say that, and none of them have, I think a couple of patients I remember, they have not come on insulins. They're doing well, because otherwise within 1 or 2 years, most of them come on insulin. So this would be a very interesting molecule, weekly semaglutide and the weekly insulin. Then Efsitora would be another insulin, weekly insulin, again genetic modifying. It is in process, it is by Lilly, and that is by Novo. So thank you again, Dr. Vivas, for sending me details. But again, it is not it is not much discussed because it is not going to be launched shortly. Rapid acting analogs, I will not be talking, but whatever are the rapid acting analogs, what is observed that onset of action is a little faster, insulin peak is little early, the prandial sugar is little better, but hypoglycemia and HbA1c are the same. So I use it, but I use it less frequently. Now another interesting area, innate insulin, which is again going to be launched in just couple of weeks, couple of, I think 1, 2, 3 months. Afrezza, and just when I reviewed everything in 1925, only the the concept of inhaled insulin was launched much before, almost 100 years from now. And 71, the nebulizer with the arrival of nebulization, it was all done. And 2006, the first inhaled insulin was launched in by US FDA approved Exuberate, all of you know. And because of lung cancers and all, it was withdrawn from the market just within a year. 2014, again, the same insulin, Afrezza, was launched, and now Cipla and Mankind, they're collaborating and they're going to launch in India. So I think all of us need to know about this. It was approved in 2014, and now it is going to be launched in India. It is approved by uh, Indian drug authorities also. And the indications are patients with type 1 diabetes must use with long-acting insulin, not recommended for treatment of diabetic ketoacidosis, and not recommended in patients who smoke. I think what is very important before he is using, there has to be a normal lung function test, and FeV1 expiratory volume should be normal in all patients. And contraindications are during episode of hypoglycemia, any chronic lung disease, COPD, chest infections, and hypersensitivity to regular human insulin. And how it is delivered? Same in inhaled insulin, it comes, reaches up to alveoli, and from there it is absorbed into systemic circulation, and then goes for a first pass insulin, and the it almost matches with the subcutaneous insulin. And it comes in three forms: the 4 units, 8 units, and 12 units, and you can mix and match. And simple thing is, it is like an inhaler. You have to put a cartridge and then inhale it, and within 15 minutes the effect will be on. You have to take it out and then take the next one. So this would be interesting to use. I mean, you give one icodec and 3 pricks of inhaled insulin to your type 1, so it will be almost prickless. So this would be interesting. Then compared to endogenous insulin secretion, compared to time to measurable effect is 10 minutes here, 12 minutes is here. Peak is 45 minutes, 45 minutes here. Time to return is 210, almost 4 hours. So this would be interesting to observe. And compared to placebo, there is HbA1c reduction, fasting reduction, the hypoglycemia. It is more or less same as of regular human insulin. Now the question is, will it have any effect in lung functions? So this was on your left side, 24 weeks trial, and they did not find a significant difference. And on right hand side, it is a 2-year study, and they found a very marginal change in lung function. But normal lung function is mandatory before you use it. The side effect wise compared to placebo, the cough was little more, otherwise more or less same. Cough, throat pain, headache, diarrhea, fatigue, nausea. So all side effects were more or less same. And look at the ADA recommendation. So inhaled insulin is also recommended by ADA, other than uh, the long-acting and short-acting insulin. So a freezer summary of evidence. It is the first commercially proven non-invasive route for administering insulin in diabetes mellitus. Thus, it provides an option for early insulin initiation. It has a rapid onset of action, and this provides the benefit of repeat dosing in case of adequate. I think multiple doses you can also take it. Carb counting, use the inhaler. In randomized controlled clinical trials, it has demonstrated consistent efficacy in improving glycemic control in type 2 and as well as in type 1. Long-term study of for 2 years has demonstrated lung safety. And so again, everybody has shown this. I am the organizing chairman. All of you are invited for this type 1 special meet in Kanpur. This is tie-on up. This would be the third meet. First meet was Aurangabad, second was Jaipur. And this meeting comprises of everybody who is treating type 1 diabetes. A basic physician, pediatrician, pediatric endocrinologist, dietitians, educators, and we are also involving type 1 advocates who have reached to. So all of you are invited, and Dr. Anurag is the scientific chair. So you can coordinate either me, I think he is in direct access to all of you, and Dr. Vibha is the joint secretary. So you can contact any one of them. And all of you are very warmly invited. So please block 5th, 6th, 7th December in Kanpur. Thank you so much.
Thanks a lot, Dr. Rishi, for a wonderful talk on so many new topics. And clearly, this tie-up event is going to be very good. It's going to tie up a lot of people. And I'll request Dr. Vibha to kindly hand over the momentum to Dr. Rishi. So now we will move forward to the last talk of the session. And this talk is about a very interesting topic of neonatal diabetes, which Dr. Neha will give. So as I was discussing, Dr. Neha was the initial fellow who joined with Dr. Chetan in 2017 with us. And she is now working as pediatric endocrinologist at Regency Lucknow. And she is doing a lot of wonderful job in terms of pediatric endocrinology. So over to you, Dr. Neha.
A very warm good evening, everyone, and many thanks to respected Anurag sir for warm welcome. So with majority of us feeling hypoglycemic at the moment, I'll try my best to recall some theories, some papers on a condition known to cause hyperglycemia, which is neonatal diabetes. So over the next 2 to 3 minutes, we will discuss about what is neonatal diabetes, when to suspect, and how to manage. So just for an overview, neonatal diabetes is a very rare condition.Maybe majority of us will never come across such a case in our life, but still we need to know about this condition. So it is a rare disorder found in 1 in 1 lakh to 2 lakh newborns, leading to hyperglycemia. Onset is usually less than 6 months, may happen in between 6 to 12 months, in which we need to rule out autoimmunity before targeting or making a diagnosis of monogenic diabetes or neonatal diabetes. Insulin is the treatment of choice in the initial management, and a switch to oral antidiabetics, particularly sulfonylurea, can be taken after genetic testing is done. So let us go through few common causes of hyperglycemia in the neonatal period. Extremely low birth weight because of immaturity of the pancreatic axis, lipid infusions, metabolic stress, infection, medications, exogenous parenteral glucose, neonatal diabetes, of course, pancreatic defect, hepatic immaturity, hypoxia, surgical procedures. So these are the list of causes that we need to keep in our mind when we encounter a baby with hyperglycemia. So just for an instance, we often come across hyperglycemia in prematurity, but is it a contraindication to genetic testing? Maybe after re-going through this paper, not. So this was a study published quite long back in 2016 in which nearly 146 preterm neonates less than 37 weeks were compared with term babies to find the cause and the presentation of hyperglycemia. So hyperglycemia in children in preterm is thought to be due to immaturity of the pancreatic axis rather than monogenic diabetes. But this paper showed that patients with neonatal diabetes due to monogenic etiology, in particular 6q24 or GATA6 abnormalities, are born preterm. So even in preterm neonates presenting with hyperglycemia, we need to keep a possibility of monogenic diabetes up the list and not a very down the list. So we have gone through this insulin release physiology in the hyperinsulinism section. So I will just go it quickly through it. So we have beta cell, we have glucose transporter 2, which senses glucose, phosphorylates the glucose 6-phosphate, opens the potassium channel, refluxes the potassium out of beta cell, causing hyperpolarization, leading to influx of calcium and release of insulin. So whenever there is excess of glucose sensed by glucose 2 transporters, it causes production of ATP, leading to closure of the potassium channels. There is an increase in intracellular potassium, leading to calcium efflux, influx, and insulin release. So these potassium channels are coded by genes known as SUR or KIR 6.2 genes, which encodes for ABCC8 and KCNJ11 protein. So neonatal diabetes broadly can be grouped on the basis of clinical phenotype into three categories: transient, permanent, and syndromic. So transient is most commonly caused by 6q24, which we will discuss in detail in the subsequent slide, but it can also be caused by certain heterozygous mutations in ABCC8 and KCNJ11. Permanent neonatal diabetes, on the other hand, is most commonly caused by insulin gene mutation or glucokinase gene mutation, and simultaneously ABCC8 and KCNJ11 are also responsible for permanent neonatal diabetes. Then we have certain syndromic neonatal diabetes forms, such as FOXP3 gene mutation, PTF1 alpha mutation, IPF1 mutation, and clinical presentation of neonatal diabetes can vary from being asymptomatic to severe forms of diabetic ketoacidosis, among which KCNJ11 is the most common form. So let us walk through this case. This was a 3-week male presented with hyperglycemia and polyuria. Now just start imagining a 3-week male entering your OPD with hyperglycemia and polyuria. So the first thing that comes in our mind is sepsis. So a sepsis screen was done, which was negative. Metabolic screening showed metabolic acidosis with ketones. So this was diabetic ketoacidosis. Be it any cause for hyperglycemia and polyuria, the gold standard is start insulin and then continue with evaluation. So this baby was also started on insulin infusion. Diabetic ketoacidosis was managed. Subsequently, he was transitioned to subcutaneous insulin, and simultaneously NGS study was sent, which showed 6q24 mutation. So this being a temporary cause or a transient cause, it resolved by 3 months of age, but still the baby requires monitoring continuously. Why? Because there are high chances of relapse, particularly in periods of growth spurt. So because of a risk of relapse, which may happen in nearly 50% of babies with 6q24 mutation, we should not leave the babies after neonatal diabetes is resolved. So transient diabetes, neonatal diabetes presents within days to weeks after birth. In general, it gets resolved by 12 to 18 weeks. There are chances of it being relapse in 50% cases. Most common cause is 6q24. These babies are usually born with intrauterine growth retardation, and they may have associated macroglossia and umbilical hernia. Insulin is the treatment of choice. And moving on to the genetics, why it happens. So these are the genes or chromosome of 6q24, and what you can see is it can happen due to 3 mechanisms. Either uniparental disomy, that is duplication of the father chromosome, paternal duplication, maternal chromosome is there, but a segment of father chromosome gets duplicated, or maternal hypomethylation. Now, moving on to the permanent neonatal diabetes forms, we have KCNJ11. So whenever there is a mutation in KCNJ11, it causes permanent opening of the potassium channels, leading to efflux of potassium, which causes defective internal mobilization of calcium, and insulin release is stopped. So these are 80% sporadic cases. And because KCNJ11 is also expressed in muscle, neurons, and brain, these are associated with neurodevelopmental or neuropsychomotor problems known as DENT syndrome, which is developmental delay, epilepsy, and neonatal diabetes. So these babies are born low birth weight, and sulfonylurea is a drug of choice if proven after genetic confirmation. Talking about ABCC8, again, this codes for the potassium ATP channel. So a mutation in ABCC8 will lead to permanent opening of potassium ATP channel, leading to efflux of potassium, difficulty in influx of calcium, and thereby stopping the release of insulin. Usually these patients are not associated with neurological features, but not 100%. Again, sulfonylurea is the drug of choice. Next, we have insulin gene mutation. As the word tells you, it codes for insulin manufacturing. So it encodes pre-proinsulin. A defect in insulin gene will lead to protein misfolding, accumulation in beta cell. So these babies usually present later in life by around 9 to 10 weeks as compared to 6q24 gene mutation. And they will require lifelong insulin. Then we have certain syndromic neonatal diabetes forms such as APEX syndrome, Wolfram syndrome, Walker-Trolleson syndrome, and genetic analysis is must in all the cases of neonatal diabetes, irrespective of the course of the disease, irrespective of associated syndromic features or not. So talking about the most common form, which is Walker-Trolleson syndrome, it happens due to a mutation in eukaryotic IF2AK3 mutation. It causes again misfolded protein, and 3 organs that are affected in this disorder is liver, kidney, and pancreas. So these children may present with spondyloepiphyseal dysplasia, which is a clinical clue to the underlying genetic condition. Moving on to IPEX syndrome, it happens due to FOXP3 gene mutation, which leads to impaired T cell functioning. The organs affected may be thyroid, diabetes, exfoliative dermatitis, enteropathy leading to intractable diarrhea, and the only treatment available with us is bone marrow transplantation. So coming back to how to approach a baby with neonatal diabetes. So molecular genetic analysis. So management will be insulin for all the babies irrespective of the cause, and after genetic confirmation, you may switch to oral formulations such as sulfonylurea. So molecular genetic analysis is must, not only because it will help us transition from an injectable to oral therapy, but because early sulfonylurea initiation may also prevent development of neurodevelopmental complications. So doing antibodies is not a contraindication, especially in babies presenting between 6 to 12 months of age. Transition to sulfonylurea, as already told, is to be done after genetic study, and if it is not possible, in some studies, they have shown to transit to sulfonylurea even without genetic studies because it helps in prevention of neurodevelopmental complications. So what are the challenges? Compromise of calories is the biggest challenge that we have because what we often do is we withhold the glucose infusion that is going on in neonates. Blood sugar is more than 300, switch from 10% to 5%. Blood sugar is 300 on 5% dextrose, maybe stop fluid for some time. But what we are ultimately doing, we are causing calorie compromise. So we should not go below a certain glucose infusion requirement in newborns. Sorry. Lack of a pharmacokinetic profile for subcutaneous administration of insulin in neonates. So there are multiple studies showing effect of multiple insulins, but the end result is glargine is the insulin to go for in neonatal diabetes. And because the doses are so small, they are highly error prone. There is limited data of insulin dilution, and because it presents in mostly preterm and IUGR babies, there is a lack of subcutaneous fat. So giving it becomes logistically difficult. So we have a clinical scenario here. So he is a term male infant, presents as 6 weeks of age with poor feeding, polyuria, weight loss. Birth weight was good, average birth weight 2.4. Family history, non-contributory, non-consanguineous marriage. On physical examination, mild dehydration, otherwise all the systems are normal. So no dysmorphism. On routine screening, initial screening, blood glucose was 356, ketones positive, but no acidosis. C-peptide was low, insulin was low, and antibodies were done, which was negative. So we have a case of insulinopenia without autoimmunity. So we are heading towards a monogenic etiology in this case. So differential diagnosis, because we are not dealing with any dysmorphism, syndromic diabetes is out. We are either dealing with a potassium ATP channel mutation or 6q24 methylation defect. INS may or may not be because of early presentation. So genetic study was done, which showed a heterozygous activating mutation in KCNJ11. After initial management with insulin, the baby was transitioned to oral sulfonylurea and is being managed. So management plan again, start with insulin, switch to glibenclamide, starting dose of 0.05 mg per kg per day, up to a maximum of 1 mg per kg per day. And our target is to have an improved fasting and postprandial glucose without any hypoglycemia and to attain normal growth and developmental milestones. So learning points from this short and crisp talk is, Early recognition. Always think of neonatal diabetes in a baby presenting with hyperglycemia after ruling out normal causes such as sepsis. Start early treatment with insulin. After stabilizing, send for genetic analysis if possible. Switch to sulfonylurea if mutation is positive, or may give a trial without genetic confirmation after agreement with parents. Thank you.
Thanks a lot, Neha, for this wonderful, crisp talk, as always. And you have covered the entirety of neonatal diabetes in that perspective. Dr. Vivek?
Yeah, so the center point of the talk is genetic testing. So any neonate in an ICU having persistent hyperglycemia, one should be very careful that dealing with some form of diabetes, and always try and go for genetic analysis. Thank you. Thank you.
Okay, thanks a lot. I'll request Dr. Sandeep to kindly give a token of appreciation to Dr. Neha. I'll request Dr. Nimisha and Dr. Alappan to kindly give moment of appreciation to, I think, to Dr. Vivek. Dr. Aisha has received. So we'll be moving towards the last talk, last session of the day. And this is going to be a very interesting session. I'm sure all of you are tired since morning. It's a long talk, but this is going to be quite interesting case-based scenario. And for this, Dr. Sandeep, you can call the panelists.
So this will be a ground round on inherited glucose disorder. So I now request Dr. Vijay Kumar, Dr. Hari Mangtani, Dr. Chetan Dave, and Dr. Ravindra Kumar to come on dais as chairpersons.
As experts.
As experts. I invite Dr. Anurag sir and Dr. Nimisha to come on dais and for the speak.
So the way this grand round is structured, and we are going to have 3 grand rounds in the whole session, is that we'll have a very brief theoretical in the initial part just to review, and then we'll go through the experts. So Dr. Nimisha will ask questions from the experts, they will give the answer, then we'll go forward from there. So it's a way to cover the various aspects. So we're focusing on genetic glucose disorders. A word about monogenic diabetes before we go ahead. So type 1 diabetes, we know 80% of cases is type 1 in children. Type 2 is around 15%, in MODI will be like 2 to 5%. So we need to know when should we suspect monogenic diabetes in that regard. So it's 0.4% of all diabetes. But if you identify monogenic diabetes, you may be actually able to provide a specific treatment. You may give oral medications. Some may respond to sulfonylurea, some may respond to GLP-1 receptor analog. And you know whether there is a kidney association, liver association, which is there. So we all know that if you have a child who is onset between 1 to 10 years of age, it's usually type 1 diabetes. Default mode is type 1 diabetes. If you have a child who is obese or overweight in 10 to 18 years, pubertal, think of type 2. Lean individuals with multiple generations involved, you should start thinking of monogenic forms of diabetes. So clearly, if you think of monogenic diabetes, typically they present at 10 to 25 years of age. Almost all of them are pubertal. This is an autosomal dominant condition. Ketosis may be there in 5% cases, and C-peptide will be normal. So these clues will give you the clue. So in child who looks like type 1 diabetes, but who is not requiring insulin after 1 to 1.5 years of age, has a strong family history of diabetes, has negative antibody, we should start thinking of genetics from that perspective. Similarly, suspected type 2 diabetes without obesity. So this is our algorithm. So what we say is that onset before 6 months, Dr. Neha very clearly said that you should get a genetic testing done. After 6 months, Depending upon the insulin requirement and the phenotype, we can decide. So lean individual not requiring insulin for more than 1 year, we suggested you should do a monogenic evaluation from that perspective. So monogenic diabetes can be because of insulin deficiency on one hand, in which you have a problem in transcription factors. And on the other hand, you will have a release defect. The classical example is glucokinase. The characteristic feature of transcription factor modi is high fasting, high PP. While if you talk about glucokinase, it will basically have fasting is high, but the delta increment is quite limited in that perspective. Then there can be resistance syndromes as well. So we'll start off with the cases, Dr. Nimisha.
Starting with the case 1, 15-day-old girl presented with failure to thrive. Birth weight was 1.8 kgs. On presentation, the weight was 1.6 kg. The baby was looking sick. The blood glucose levels were high, 425 milligram per deciliter. The ketones level were low, and the child appeared dehydrated. To Dr. Vijaya.
Yeah, working.
And her weight is 1,600 gram, and she's sick looking. So first, and there is high blood sugar, blood glucose levels are 425, dehydrated. So first of all, you have to think, because we are dealing with a premature child, and we have to discuss and we have to investigate about sepsis and other conditions, at least especially fungal sepsis, and can produce hyperglycemia. That may be the first thing. And along with that, we have to, as discussed in the previous topic, we have to discuss, we have to think that this child is having neonatal diabetes also. And since the child is below 6 months, always genetic study is a must in this case.
Yes, sir. The child was started on fluid and insulin, and the genetic study was planned.
And the other thing that there were no other infection markers. And
Yeah.
this was a persistent diabetes. Now, the problem with this patient often happens not affording genetic study. So what will you do, Dr. Vijay, here?
So if the child is not affording genetic study, I think we have to start insulin. And the problem is that many a case, this genetic cases may require sulfonylurea. Here also, we also have some problems so some delay in the diagnosis. So we have to start insulin. And this child improved over time with insulin.
Yes. And then the requirement, so everybody happy.
Then
we were happy, patient was happy that there's no need. But do you think we should be very happy now, or we should be cautious?
We have to, even though the child improves, and we have to follow up the child. So because they can develop later, during adolescent period and somewhere like that, they can produce diabetes later, monogenic diabetes.
So Dr. Ravindra, in this, the questions, Dr. Ravindra. So as we were discussing, this looks like a transient diabetes, but what are the issues that we should be following up in this child?
So as you have very rightly in neonatal diabetes, we have already discussed that this case is supposed to be neonatal diabetes. Improved means must be having some transient form. And there are chances that this transient form may recur. So just keep under observation. Otherwise, this patient will end up in decay someday. So always keep monitoring this patient. And if it develops, if genetic study possible, then it's okay. Very good enough. Nowadays, as Sir Dr. Anurag said, it is a costly therapy. Okay, yes, that is fine. But neonatal diabetes is one arena where free diagnostic is available. In India, Dr. Madras from Chennai, he's doing, you can send him sample and he'll do it free of cost, hardly costing 250 rupees.
Yeah. So now at 12 years, Nimisha, what happened?
On following up, after 12 years, child presented to us with polyuria, with high blood sugars, 240 milligram per deciliter. The HbA1c level were high, 8.4%, and child was started on insulin again. The plan of management.
So as Dr. Ravind, you said that genetics should have been done right away. And that time it was quite like 15, 16 years ago.
Okay.
Now the genetics was available. And what do you think would be the most likely type of diabetes in this case?
This must be some 6q24, as we have already discussed, transient neonatal diabetes. This must be 6q24, which is having a biophasic curve. During the adolescent time, at 12 years, it again resurfaces. Now, patient is having the diabetes, any type of diabetes, the management will remain the same. It has to be basal bolus regime, start on insulin, and it will continue on insulin because mutation is there, which has given its own effect now.
Yeah. So now we got the genetics this time and we found the ABCC8 defect.
ABCC.
So this is the potassium ATP defect. So now we have a theoretical option for switching over to a agent.
Switching, because now this is the one arena where you got this ABCC8, because just ABCC8 or KCNJ11, both of them, they respond very well to the sulfonylurea. So there is a schematic diagram, because first treatment has to be the insulin, whatever may be the type of diabetes, always, because our first aim is to control the sugar. After that, with that systemic schematic diagram or program, we may shift it to the sulfonylurea. Probably it will respond to the sulfonylurea now.
So Dr. Nimisha, what happened with sulfonylurea in this child?
The child was started on sulfonylurea and on follow-up, child was insulin was decreased gradually, and child blood sugar levels came to be normal.
This child just came to our on-site course recently. Now he's only on glibenclamide, 10 milligrams, a perfect HbA1c. So Dr. Ravindra, what are your messages for neonatal diabetes?
So neonatal diabetes, as we all know, neonatal hyperglycemia, although whosoever is looking after nursery, is an uncommon thing, because neonatal hypoglycemia is very common. In every case you will be having neonatal hypoglycemia. But any neonate who is less than 6 months of age having hyperglycemia for 2 weeks or more than 2 weeks and require insulin for the treatment probably qualifies for neonatal diabetes. You have to treat that patient with the insulin irrespective of the etiology. Keep monitoring the patient even if the genetic study is not possible. Any mutation of a ABCC8, that is why it improved over the time. Otherwise, it would have resulted into the permanent neonatal diabetes.
Thanks a lot. Yeah.
Moving to the second case, 2-month-old boy presented with failure to thrive. Birth weight was 2.5 kg. Now the weight was 2.8 kg. There was hepatomegaly, myopathy, and weakness at the time of presentation. Blood sugar levels were high. HbA1c was 9.9. Triglyceride was 550 milligram per deciliters. I would like Dr. Hari sir to kindly comment on this.
So, looking at the child profile, an RBS of 487 with high HbA1c suggests a possibility of diabetes, and looking at the age of 2 months, it is neonatal diabetes. Okay. Now, whenever we encounter such patient, we have to start on therapy with insulin and send genetics. This is the first plan we should have, because unless we have a diagnosis, genetic diagnosis, we won't be able to plan whether the child can be shifted onto sulfonylurea.
And if we compare to the last case, Dr. Hari, we have some subtle clinical pointers which are different in this case.
So here, myopathy, weakness, hepatomegaly. These are the additional findings apart from this. So this suggests some kind of specific genetic mutation. Now, what are the genetic mutation? The potassium channel defect, which is common in muscle and neuronal tissues, that if there is a severe KCNJ affection, the potassium channel affection is there, then it may actually affect those neuronal tissues and muscle, causing myopathy and developmental delay or epilepsy kind of a syndrome. So if we actually think of some syndrome, the KCNJ11 including that, Dent syndrome is one of the syndrome which comes to the mind, which is developmental delay, epilepsy, and neonatal diabetes. So yes, if we do this targeted panel, KCNJ defect was seen in this child. I may not go into details of the cell physiology as it was adequately discussed in previous talks. But a KCNJ defect, if they are in intermediate variety, then we may actually not have epilepsy, only neonatal diabetes, and some developmental delay can be seen. So this is present in almost say nearly 15 to 20% of total cases of KCNJ, a severe variety.
So what will be,
What will be the plan of management?
So plan will be starting them on once they have started on insulin, gradually shift them on sulfonylurea drug because they are known to respond to sulfonylurea. And KCNJ, they respond, most of them, they respond to sulfonylurea.
So all newborns in the 6 months of age, 6 to 12 months, antibody negative with diabetes should have genetic analysis, and later onset, as in this case, can also be indicative of a permanent one. Genetic testing becomes well in that regards.
Actually, I have shifted one of my patient to sulfonylurea, neonatal diabetes. They could not do genetics. So, but the transition was successful. So I think most of them, we will be able to successfully transfer them or shift them to sulfonylureas. But genetics done, will be able to give them a future perspective.
So that has to be very cautious because only 40% will actually respond to sulfonylurea. We agree that you were there, you were monitoring very closely.
Yes.
So we should not give advice that you do that because otherwise they will go into decay also. But yes, under a very close monitoring, we can consider that as a trial. But ideally genetics, as Dr. Ravindra said now, MDRF does it for free. So only courier charges have to be given. So that can be considered here. Okay,
Coming
next
to
case.
case 3, a 12-month-old girl, failure to thrive with birth weight of 2500 grams. Blood sugar levels were high. Ketone was not detectable, 0.3 millimole per liter. There was a history of consanguinity in family, and an X-ray film of hand was done. Dr. Chetan, sir.
So again, this is a case of diabetes which presented at 12 months. So this can be type 1 versus monogenic. This is non-ketotic diabetes. So it may be detected early whether ketosis has not developed yet. But looking to the X-ray, we found bullet-shaped fingers, which is not normal and which is unusual. Also, there is history of failure to thrive and family history of consanguinity, which is suggestive of monogenic possible genetic cause of this diabetes. And we know that the skeletal dysplasia along with the type 1 along with the neonatal diabetes favors EIF2AK mutation, and the name is Walcott-Relison syndrome. So we should be again looking for the genetic diagnosis whenever there is diabetes with specific other symptoms and signs suggestive of monogenic etiology.
So again, this is one condition which is having beta cell destruction, and ultimately they will be insulin dependent only. So as I said, only 30 to 40% will actually be sulfonylurea responsive. So clearly it is the commonest cause in consanguineous family. And if you have skeletal abnormalities, always look at fingers. You will find this as a possibility. Have you experienced hepatic dysfunction in this condition?
No, I have only one patient of confirmed genetic mutation of EIF2FK, in which the patient is not responding to the conventional dose of insulin. Currently, he is on 2.53 unit per kg per day, still having sugars in the range of 250-300s. Also, there is a component of failure to thrive. In that patient, SGPT is remaining between 40 to 80. So there is not much hepatic dysfunction, but overall the patient is having trouble in terms of digestion and persistent vomiting is there. It is not growing well. So I have explained them poor prognosis, but again, this is fairly common.
Yeah, so Western reports say universal, but there are many Indian patients who have not developed. So probably we have a different mutation which is there.
Moving on to the next case, 2-month-old boy presented with failure to thrive with high blood sugar levels, with skin infections, diarrhea, and on checking the GAD antibody, it was positive. Dr. Vijay.
So is it type 1, Dr. Vijay?
So the GAD antibody is positive, but here the main problem is child is having diarrhea and child is having skin infections. So it is an autoimmune process, but we have to investigate for other causes also. So many cases, so this is almost a clear-cut case, APEX syndrome, but we have to investigate and find out. So sometimes many immune defects can be a part of type 1 diabetes, as we were discussing little bit earlier, immune endocrinopathy. So lot of things are there. It was a very nice talk, and we have to investigate for other immune systems also.
So Dr. Neha just mentioned that antibodies may be positive in younger children. That does not mean it is type 1. It could be IPEX also. So this is a bad condition. IPEX generally is a very, very bad condition. It causes a lot of other problems, abdominal symptoms, pancreatic, thyroid, immune, Do you have any experience of this condition, Dr. Vijay? Not really, but this is, I have had couple of cases, very bad outcome. Even in Western countries, it is a bad prognosis. And only treatment is hematopoietic stem cell transplant, which is considered in this scenario. So this is a bad scenario. So if it is early onset immune diabetes, multi-system, think of IPEX syndrome. Now, next case, please.
16-year-old girl presented to us with increased urine output with high blood sugar levels, HbA1c of 8%, ketone was 0.8, BMI was 16 kg per meter square. There was no acanthosis and diagnosed as type 1 diabetes mellitus. On insulin, there were repeated episodes of hypoglycemia. Dr. Ravindra, sir?
So that's very interesting case that at the age of 16-year-old, she was diagnosed as a case of diabetes as with RBS and non-ketotic, but patient is not in DK. Obviously, patient is not obese, so BMI is just 16. Now, interesting is that when it is a case of type 1 diabetes mellitus, and she has been put on the regular management as a standard protocol, why the patient is developing recurrent hypoglycemia. It means, I mean, this can't be some type 1 diabetes. Had it been type 1 diabetes, and if we are treating appropriately with the right dose of the basal bolus regime, it means it is something which is in between. And when someone is adolescent, you know that there may be something more than that, because we have not done the antibody in that case. And if we see the algorithm, because now, as doctor, she has projected that she has gone the antibodies and it is negative. Now, here comes the role of, you will think, can it be a MODI? Because this is the case where the scenario patient may develop hypoglycemia based on the insulin. And you have to be very careful, just take the history. If this is the third generation, see, so one of the parent is having diabetes, or their brother and sister, and their grandparents. Third generation, always look for the MODI, do the genetic testing again in that case, because this might be one case where that patient may need only tablets and oral medication may be done. So if we go to the algorithm, as sir has already shown, that it is 16 years, get antibody positive, there is no obesity, negative or positive genetic study, then genetic study has been done and it is came out to be HNF1 alpha defect, means again it's a MODI which may be treated with the all these late onset progressive fasting normal, as sir has said, and that may be management by just OHA, oral hypoglycemic acid, then they will respond very beautifully.
And very good thing is that the GLP-1 receptor analogs are very effective without even causing hypoglycemia. So if you diagnose them, you start 0.5 milligram of glimepiride, they will do wonders. So this is one condition of insulin. So this is a very good disease to have. So as Dr. Ravindra said, that lean, low insulin requirement, 3-generation family, get a targeted panel. Don't rush in everybody. So what we say, if your insulin requirement is persistently low after 1 to 1.5 years of diabetes,
Yes,
that is
that is
clear-cut scenario. Otherwise, genetics, a lot of people keep on doing genetics a lot. That should be avoided.
That is the very, message is very loud and very clear. You know, there is a honeymoon phase. And this, if honeymoon phase is persisting, because usually persists for a couple of weeks, if persisting more than a year, then this is not a type 1 diabetes. You have to look for, probably you are dealing some sort of MODI.
Coming to the next case, 15-year-old girl presented with osmotic symptoms. Fasting was high, 220 milligram per deciliter, and 2 hours OGTT level was 380. HbA1c was 10.4. They were started on insulin. Child was lean, no acanthosis. There was family history of similar complaints in mother. Fluctuating sugars after and insulin was stopped. Dr. Hari sir?
Yeah, so fasting sugar high qualifies her to be a diabetic person with two criteria met. Though she had DK and recovered by insulin, she's lean and no acanthosis, so there is no type 2 diabetes. There is a family history in the mother, and the sugars are fluctuating. And she was, I think I read somewhere. So again, this becomes a case going towards MODI, because there is a strong family history and she's requiring low doses of insulin at that time.
So this is persistently low
again,
insulin
persistently
requirement.
low insulin requirement. And yes, now this is a renal ultrasound, which is like showing some cyst in the kidney. So HNF1 beta again is known to have extra pancreatic manifestations. In fact, it can be the renal cyst which appears first, and patient may present with renal cyst without diabetes. Later on, they may go on to develop. And hypoplasia of other organs, particularly they have pancreatic hypoplasia and reduced secretion of exocrine pancreatic insufficiency also. The thing which we see in such patients is they respond to sulfonylureas, but the response is not a long-lasting response, and most of them they will be have to shift it to insulin therapy as their disease progresses. So it's a late onset kind of a progressive disorder, renal cyst dysplasia and pelvic.
So this patient also had to be started on insulin after glibenclamide. So again, fluctuating course, renal cyst, family history, think of HNF1 beta defect.
11-year-old girl, type 1 diabetes, diagnosed at 8 years of age, started on insulin at 1 unit per kg per day, presented with visual complaints of and was diagnosed of retinopathy. Dr. Chetan sir.
So this girl having a duration of 3 years of type 1 diabetes, insulin requirement is stable at 1 unit per kg per day. So very unlikely that this patient will develop type 1 diabetic complications as retinopathy, because we generally observe that retinopathy and nephropathy usually starts occurring after 10 to 12 years of type 1 diabetes. So this might be another genetic thing which can lead to type 1 diabetes along with the visual effect in form of retinopathy. So maybe again genetic evaluation is warranted, and we have Didmod syndrome in which the patient develops type 1 diabetes insipidus as well as hearing defect as well as retinal issues in form of optic atrophy. So this is a Wolfram syndrome rather than plain type 1 diabetes.
This is very important to identify because the prognosis is very bad for this condition. So general guidelines are that if you are antibody negative, an early onset visual complaint is equal to Wolfram syndrome. That is something which is very, very clear in that regard. So this case turned out to be a Wolfram syndrome with a bad prognosis. So non-immune diabetes, early onset optic atrophy is Wolfram syndrome. Again, genetics is very, very important. Remember, we always say did mode, but DI happens much later. So don't think about DI is not there, so why it is did mode.
Coming on to the next case, 11-year-old girl on routine investigation, the fasting blood glucose levels were found to be impaired and the postprandial blood glucose levels were normal. The BMI was 18 kg per meter square. There was no acanthosis. HbA1c levels were high, 6.4, and ketone was low. And started on insulin but developed hypoglycemia. Dr. Vijaya sir.
Here it was antibody test was done or not done? GAD?
Yeah, we got the test done later on.
Negative.
Yeah, but we
so this is a almost clear-cut case of GCK mode because all these things are there. So postprandial is not much, and whenever you give insulin, child will develop hypoglycemia. That is a very benign disease also. So you can, without insulin, we can manage the child.
Yes, sir. The GAD antibody was negative, and child had a high fasting glucose with postprandial increase was minimal. This was a glucokinase
Glucokinase deficiency.
So glucokinase deficiency, as you said, there's a problem in glucose sensing. You have high fasting, but the sugars immediately get in control. So this is something the delta value is usually less than how much, Dr. Nimesha? Less than 40, maximum 50. So from fasting to PP, the rise is less. They do not need treatment. The only condition where they may need treatment is pregnancy. When the child is not affected, then they will behave like IDM. So lifestyle measures are required. So this again is a mild diabetes, non-progressive, no need of treatment. So we have seen so many children with diabetes who require either oral or who require no treatment at all. So it's not that every childhood diabetes will require insulin. That is also something we are giving a message.
Moving on to the next case, 12-year-old boy presented with polyuria, developmental delay, history of hyperphagia, infantile hypotonia present with Fasting blood sugar levels of 140 and 2-hour blood sugar levels were also high. The child was obese. Dr. Ravindra sir.
Actually, I want delegate to answer it. I mean, you can't have more apparent clinical diagnosis. Yes, but the case is Prader-Willi. See, you see, all of you have become so intelligent after the whole days these lectures. So everything this patient is having, diagnosis is written on his forehead, although it has been blacked out. It is a case of Prader-Willi syndrome. It is difficult to manage because there are so many problems are there. Diabetes is just one part of them. Hyperphagia, hypogonadism, many things are there. So this is uh, Prader-Willi syndrome. You know that. If possible, genetic testing may be done. Treatment is very difficult, although metformin and now we have GLP-1 analog. And recently, I think whosoever is member of endocrine group, one drug has been approved for this hyperphagia because hyperphagia is very problematic. I don't know how many of you have seen this sort of cases. I've seen two cases, and believe me, I mean they are very difficult to treat. Number one, and number two, this is not that rare as we think of. The incidence is just close 1 into 25 to 50,000. So if you look at the daily 2-3 crore population, so how many PWS are moving here and there? However, infantile hypotonia, later obesity, hyperphagia, diabetes in second decade, we have to be very careful, especially who are doing in nursery, because the neonatal hypotonia, earlier very low birth weight, and then suddenly they start from 6, 7 or 8 months, they start gaining the weight.
The main message is if they develop diabetes, you're too late. And by that time, it is going to be very difficult. In the Western country, the average age of diagnosis of Prader-Willi is in the 6-month age. So they're picking up neonatal. So they do all that to prevent obesity. I have found very much difficulty. This child had sleep apnea. He was on ventilator, CPAP, insulin. So it's going to be a real mess. It's not an easy one. Maybe think of bariatric surgery, GLP. It's like a desperate measure, but we should work early. I have given growth hormone to a few patients who have done well because they have not gained weight, but they have become diabetic. I think this is pretty much a very, very bad scenario in that regards.
Next case, 17-year-old girl presented with hirsutism with Perriman-Galway score of 21 and complaints of amenorrhea. There was severe acanthosis. The BMI was 16 kg per meter square with blood sugar fasting level was 145 and postprandial was 221. USG shows high large ovary with PCOS appearance. Dr. Hari sir.
So when we look at the complaints, they are very clear cut, suggesting of PCO, the diagnosis of polycystic ovary and acanthosis. This all point towards insulin resistance, and the major cause of insulin resistance is obesity. But here the BMI is less. So there is insulin resistance, no doubt about it. But the cause is somewhere else. The cause is not the obesity. The cause must be in the INS or insulin receptor gene. So if we
This
see
case,
this,
basically we are treating as a, we did not get the genetic
Yeah.
study done. We are assuming this is more like a autoimmune insulin resistance, which
So,
happens
yes,
later on in life.
and it's like many different types of presentation. One is heterozygous, which is the mildest form, and then we have homozygous form, the so-called Donnai syndrome, and compound heterozygote also, which is Rapson-Mendenhall. So if there is absolute resistance to insulin, then it is very severe neonatal onset condition, very difficult to save such kids. The easier ones are this infantile onset insulin resistance, and type 1 is the mildest form, which can be managed by metformin initially, and perhaps
But often they are not very mild, because this case, what happens is that ovary was very big and it had led to testosterone levels of 200 and above, causing virilization. We saw this case in the on-site course, and we had to actually do a ovarian drilling to remove part of the ovary. And very, very difficult, because otherwise they will go into severe this is like hyperthicosis. Here and syndrome, what we typically say. This is very, very bad scenario.
What I want to mean is, amongst that
Yes,
insulin resistant type, this is the mildest
True,
form.
absolutely.
But otherwise, clinically considering PCO, this is the most severe form. And I mean, testosterone of 200, we can just imagine how the child must have.
So this is very, very dangerous. Again, if we wait for some time, the ovaries will be burned and then ovaries will behave like a bomb sort of a thing. They're producing testosterone like anything. In one child, we had to give GnRH analog to knock down that. We had to give anti-androgen. We had to give estrogen to increase SHBG. So it's like a nightmare. So this case, we earlier got a ovarian drilling done. So now she is relatively better. But again, hirsutism is persisting, I think. Yeah. So now we have talked a lot about monogenic diabetes, a bit about hyperinsulinism. My work has been done, made very easy by Dr. Vijay Kumar, who has talked very clearly. So very situation in which you have a hypoketotic, non-reducing substances with detectable insulin is hyperinsulinism. This is what already has been mentioned. And in this regards, basically this could be because of increased insulin, which could be transient, prolonged, or monogenic, which we discussed a lot. And then rarely there could be increased insulin action which can be there. The approach already Dr. Vijay Kumar has mentioned that rule out the transient causes, manage with diazoxide. If not, go for diazoxide response. If there is a response, continue that, get a genetic study for GTH. If it's not there, get a genetic study for potassium ATP channel defect and decide whether a focal or a diffuse form could be there to decide the management. So main management is about diazoxide response and genetics. This is what has already been summarized. So we'll directly jump into the cases.
It was a 14-day-old boy presented with history of birth asphyxia, admitted in ICU with blood sugar levels of 28 milligram per deciliter. Was started on GIR of 14 milligram per kg per minute. It was non-ketotic with high insulin levels of 4.2 microunit per liter. The birth weight of child was 1.6 kg. Dr. Chetan, sir.
So this is a case of neonatal hypoglycemia, which is hypoketotic in nature, and any detectable insulin at the time of hypoglycemia is suggestive of hyperinsulinism. And we have two risk factors in this case. One is low birth weight, that is IUGR baby, and second is birth asphyxia. So these two can lead to transient or maybe temporary hyperinsulinism, leading to the prolonged use of diazoxide, and it can last up to 8 to 12 weeks as well. So after doing echo, we can start the diazoxide in these patients and see the response, how baby reacts.
On follow-up, child was started on diazoxide at 10 milligram per kg per minute. The GIR was reduced. There was now weight gain and edema, complaint of edema.
Yes. So edema is a non-associated factor with the use of diazoxide. So along with the diazoxide, we should use hydrochlorothiazide because it is known to cause fluid retention. So along with the diazoxide, we should use low-dose hydrochlorothiazide once a day.
This message was given very well by Dr. Vijay Kumar. So if it is 5 milligram, maybe avoid. 10, you should give a thiazide. Very, very important in that. So prolonged insulin, we discussed, is a good diagnosis. This is going to improve and we can get a good response in that perspective.
Coming on to the next case, 3-day-old boy presented with severe hypoglycemia with birth weight of 4.6 kg, was on high GIR of 18. Ketone was absent, and on testing the insulin level was 2.4 microunit per liter. Dr. Vijay, sir?
This is a clear-cut case. Actually, we have discussed this. This case, actually, we have started the diazoxide.
Yeah, so this is macrosomia.
Everything macrosomia, glucose, high glucose and features of hyperinsulinism. First that we can start is diazoxide, and we can send for genetic study.
Okay, so yeah, we started diazoxide, increased to 15.
Start hydrochlorothiazide.
Hypoglycemia is persisting. So we should go for
octreotide, glucagon infusion,
and was found to have a potassium ATP channel defect. So you just maybe reiterate the potassium ATP channel defect that you just mentioned.
Yeah. So actually there are two types. So whenever it is an autosomal biallelic recessive or monoallelic dominant, so there is a chance of diffuse thing. So we have to continue. We have to we can avoid. So we have to continue with the other intensive medical management. Suppose if it's a paternal KATP channel So there may be a chance of focal disease, do a Doppler PET scan and go for surgery. That is the plan.
So clearly, again, the message is onset macrosomia, refractory. Think of this is a very, very bad case too.
Coming on to the next case, 18-day-old boy presented again with hypoglycemia, birth weight of 3.4 kgs, on high GIR levels with ketone level of 1.2 and insulin of 2.4 microunit per liter. Dr. Ravindra sir.
Again, I think now the delegates have to answer. The question case is very clear, neonatal diabetes. What should we do? What should we do now next? We have to treat this case. Insulin is 2.4. I mean, hypoglycemia, if someone is having in such a high insulin, obviously it is hyperinsulinism, and any amount of detectable insulin is abnormal. So what should be done in this case? Very good. Start digoxide. So because this is a case of neonatal hyperglycemia, because of the hyperinsulinism, we started the digoxide 10 milligram. No improve. My God. So this case is not improving. Still hypoglycemia is there. So what is the next step? It means it is having some sort of mutation which is non-responsive. As you see the algorithm, there is a one group of patient which is responsive, one group which is non-responsive. You again will go for the paternal mutation has been done. It is found to be the paternal potassium ATP defect. FDG PET must have been done, and it is found to be focal defect. If focal defect is there, then surgery is the answer, because otherwise the insulin will keep on secreting from that place no matter what sort of medication you are giving. Surgery has to be done. The problem is that you will find very few surgeons will be able to touch these neonates. I don't know about your city. I am from Delhi. I know. I mean, just couple of last year or 1.5 years back, there was someone has asked in our group, "Okay, is there any surgeon who can touch these baby?" So very few people they will be touching these baby, because doing pancreatic surgery is almost next to very difficult, because nobody will touch the patient. However, if it is early onset, normal birth weight, go for the genetic mutation, paternally inherited potassium ATP defect is there. FDG PET is the answer. You see, it is diffuse or local. If it is focal, go for surgery. And just one message which I think sir has just want to give. If it is neonatal diabetes, don't start oral hypoglycemic until unless you are having genetic mutation. If it is neonatal hypoglycemia, you can start the digoxide, because that is a treatment.
Sure. Wonderful. So next.
Next case, 21-day-old girl presented with hypoglycemia, birth weight of 3.2 kg, on high GIR requirement, ketone levels were 1.1 and insulin was detectable. Dr. Hari sir.
So I'll not elaborate more. This is clear-cut detectable insulin, high GIR, and day 15 neonatal hypoglycemia, and clear-cut hyperinsulinism. And the first-line therapy is always a digoxide, which we start in such cases. So there was a clinical improvement after starting digoxide, and the GIR was reduced gradually. But one thing which could see here is ammonia, which is quite high in this. But looking at the child, he was asymptomatic, I guess. I mean,
There
he
was
had
some
not
seizures later onset compared to the other children who had day 3, day 4. He had a later onset.
because hyperammonemia usually suggests towards the urea cycle defect or some amino acid metabolism defect.
Yeah, from
but
that perspective, neurologically was not asymptomatic. Hypoglycemia was a
yeah,
symptom.
hypoglycemia was a symptom. So we have got something called hyperinsulinemic hyperammonemia syndrome, HEHA syndrome, which is because of a mutation in GDH. This is a constitutively active, active or constitutively active, which converts alanine, I think aniline to, and reverses the ATP ADP ratio, and which causes membrane depolarization and hyperinsulinism. That is the mechanism in this, and they respond beautifully to digoxide.
So as against, even if you don't do genetics and they're responding to diazoxide, it's good enough
Yes.
in this regard. So it's very nicely pointed by Dr. Ravindra that there is a difference between diabetes and that, because in neonatal hypoglycemia, you don't have any alternate treatment. In diabetes, you have insulin. So to stop insulin, you require a proof, but here to start, you don't need a proof because you have nothing else to do. You can give diazoxide. So again, very good scenario.
But how long this continues? I think for many years.
Yes, so often what happens, the requirements go down, but
Yes.
during intercurrent illnesses, they will again have a problem.
Because I have one patient
Yeah.
of this. She is
So low
still
dose, they will continue on that.
Diazoxide low dose, she is still continuing.
Yeah, so that is a good diagnosis. And with age, they will come down. We have seen this.
Moving on to the next case, 12-day-old boy presented with lethargy with low glucose levels, with ketone level was negative, insulin levels were high during high critical sample, and birth weight of the child was 4.2 kg. There was umbilical hernia and ear crease present. Dr. Chetan, sir.
So this is a macrosomic baby having hypoglycemia due to hyperinsulinism with low ketone. So macrosomia might be due to infant of diabetic mother or due to other genetic issues. And in this case, umbilical hernia, ear crease, and a large baby is suggestive of Beckwith-Whitman syndrome, which represents with hypoglycemia due to hyperinsulinism, and genetic evaluation is necessary to stem the diagnosis.
So it was proven to be 11p15 defect. And now Beckwith-Whitman syndrome, they may also respond to diazoxide, but sometimes they may not. Then you can think of focal lesion, which may be there, where surgery may be required in that regards. So I think this was a good discussion, and all four of you had a wonderful inputs on this condition. And we have tried to cover the entirety of both monogenic diabetes as well as hyperinsulinism in this. And the whole glucose session, I think, has been wonderful. We had got great talks right from nutrition to type 2 diabetes to neonatal diabetes, hyperinsulinism, newer insulins, everything was covered. I'd like to thank Dr. Hari, Dr. Chetan, Dr. Vijay, and Dr. Ravindra for the wonderful session, Dr. Nimisha for the wonderful moderation. And with this, I think we come to the end of this day. It's been a long day. We started, I think, exactly at 10:30. So it's now 11 hours. And we still have a lot of people who are there right from the beginning. So I think this is, all of you deserve a round of applause. I think it's been very good for all of us. Our team who is sitting here, Dr. Sandeep, Dr. Alapan, Dr. Vibha, they have been really doing a lot of hard work, but I think everybody deserves a good dinner. And just to tell you that we'll start very early tomorrow at 8 a.m. The reason is that a lot of people have flights early, so we don't want to start late. We want to start early at 8. Very good debates are there in the beginning. And then we have got sessions, again, 2 good grand rounds on bone and calcium, which is there. And one would be on testicular disorders. And then we got a lot of good talks also.